Okay, so we'll start with our sessions, and we have among us Dr. Major Mamta Sood ma'am here, and she'll be presenting on the topic women's mental health. To start with, we welcome you, ma'am, and ma'am is a professor of psychiatry at AIMS, New Delhi. She's an MD psychiatry and served in the Indian Army Medical Corps as a graded and classified specialist in psychiatry for a good decade from 1995. And her area of interest lies in understanding severe mental illnesses, use of mobile technologies in mental health, bridging technology and psychiatry for interventions, medical education, teaching, training psychiatry for undergraduate and postgraduates. She has been recognized and given several awards, such as Colonel Kirpal Singh Award for the Indian Psychiatric Society, Young Psychiatrist Award of the Japanese Society of Psychiatrists and Neurologists, NND Oriation Award of IASCP, Vice President, Indian Association of Social Psychiatry from 22 to 24, and she's been the Vice President, Compassionate-elect, Indian Psychiatric Society, North Zone. So we welcome you, ma'am, and she'll be speaking on women's mental health. Please give a round of applause for her. Thank you. And okay. And I would also like to invite the chairperson for Dr. Major Mamta Sood for her presentation. That is Dr. M. Manjula ma'am, and she's a professor, Department of Clinical Psychology, NIMHANS, Bangalore. Professional background, she's MPhil and PhD in clinical psychology from NIMHANS. Her area of interest lies in cognitive behavior therapy, third wave therapy, schema therapy, process research and psychotherapy, mood, anxiety and suicidality, personality disorder, stress, trauma disorders, sexual dysfunction, and youth mental health. She has also been a recipient of different types of awards and recognitions, and she's been editor of IJCP, section editor of IJMPM, member of International Consortium for Validation of Questionnaire related to Schema Theory of Personality Disorders. She's been a joint secretary of NIMHANS Alumni Association, member of steering committee of DST, that is Satya, and member of NTAGI, and comes under Government of Family Welfare. We welcome you, ma'am. Please request you to please take a seat on the dais. Thank you. Please give a round of applause. Round of applause. Also, I would request Kalpana ma'am to be the second chairperson for the invited session. And Dr. Kalpana Srivastava is the director, MIT Institute of Behavioral Health and Allied Sciences. She's scientist G, retired from DRDO, Department of Psychiatry, FMC, Pune. Her academic qualification is MPhil Medical and Social Psychology from CIP and PhD from RIMPAS. And she has completed almost 22 major research projects in DRDO, DGHS, WHO, and FMRC, development of Manas app for positive mental health. She has also worked with Manas Office of Principal as a principal scientific advisor with the Government of India, and she has a lot of collaborative project development scales of test norms for armed forces. She has a publication of almost 190 publications, wherein seven are international. She has edited several international national books and has a lot of chapters plus more than 3,000 citations. She has been the recipient of Chief of Army Commendation for Meritorious Services in the Armed Forces, and she has been a recipient of more than 23 awards of various scientific bodies, both national and international. She has also won Colonel Kirpal Singh Award and International Award. Currently, she is the president of Association of Industrial Psychology of India, Vice President of Clinical Psychology Association of India, and she has been the past president of Indian IACP and past editor-in-chief of IGP of 20 years. And her special area of interest of research lies in community mental health and positive mental health. So we really welcome you here. Thank you so much. Please give a round of applause.
So, good morning, namaste, and I am glad to be here. And also a word of sorry because I reached little late. My calculation of timing was quite wrong. So anyway, the session is starting little late because of that. But I'm glad there are not many people in the hall because that way I can interact directly with everyone. And I have brought a little story of myself in the end. So hope you will enjoy it. So today I have to talk about women's mental health. I'll be talking under these headings: introduction, epidemiology, mental disorders in women, mental health issues specific to women, health at workplace, and challenges and way forward. And in conclusion, I tell you my story. So I have uh, done a very superficial job of it. I have not gone into details of anything, but I've tried to touch on almost everything here. So, I mean, this is my favorite MD exam question. What is the definition of mental health? And I find this is the best, life goal also for all us. That this is by WHO, a state of mental well-being. It enables people to cope with the normal stresses of life, enables to realize their abilities, enables them to learn well and work well. Learn well means doesn't mean that getting marks in the exams, but whatever lessons you can learn in the life to learn well and work well and enables to contribute to their communities. So these are 5 components of mental health as given by WHO. So if anybody I have to counsel, I start with mental health definition. Anybody, so it's a 5-year-old child, I simplify it, and 70-year-old person, then also I use this as my starting point. So I start with this. So what is women's mental health? As you all know, women are significant part of the society. Ideally, they should be 50% or more, but we are in India, at least as per census, it is less, but 48.5% of us are women. Mental well-being in women is determined by a host of biological factors, reproductive and hormonal, but also by a complex interaction of multiple psychosocial factors. So it is biopsychosocial standpoint we have to take to women's mental health. Factors which are certainly unique to women. There are biological differences. Women also differ in their needs and vulnerabilities, way of communication, dealing with relationships, expression of their feelings, and reaction to stress. Also, there are psychosocial factors like economic independence, physical, sexual, emotional safety, and security. These are needed for good mental health, but may not be available to all the women because of their particular status in the society. So, largely, women's mental health has been discussed from view of maternal and reproductive health. We need to look beyond reproductive health on the psychosocial determinants of mental health at workplace, and various socio-cultural issues we should be able to look at. So, what are the stressors which contribute towards women's mental health? One is women's reproductive role as bearer and nurturer of children has unique potential for stress-related effects. Many women during their lifespan face severe problems. So, women mental health we have to see from a lifespan perspective. Domestic violence, particularly spousal violence, dowry related stressors, poor family support, etc., etc. With rapid urbanization and improved opportunities for education and employment, more and more women explore venues beyond their specific gender roles of nurturers, reproduction, etc., etc. And there is increase in number of working women, which is additional. They also have to face additional stress of juggling multiple roles, workplace related stress, issues of gender discrimination at workplace, etc. Violence against women, more specifically sexual violence, also remains a major factor. So, what is the impact of all this on women? Is it interrupts normal course phases of life, if we see in the lifespan perspective. it impairs their functioning, self-esteem is lowered, employment chances are lowered, quality of life is affected. There is a lot of stigma around women's mental health. They have a lot of physical comorbidities and all kinds of violence they face. And there is also homelessness. So these are some of the things which happen. So, what the data tell us? The data tell us that when we compare men and women, in childhood, women have less mental health issues. They start rising in adolescence, higher prevalence of depression and eating disorder, suicidal ideation attempts, more prone to symptoms that are inwardly directed. And as they become an adulthood, there are higher prevalence of depression, anxiety, bipolar depression, higher comorbidities, and Alzheimer disease is also their chances. More women are living. The prevalence is same, but more women are living with Alzheimer disease. And help-seeking behavior is, they say that the perception of distress is higher. They are more likely to perceive having an emotional problem. They try to seek help more early, and they are more likely to use to relieve their emotional problems. The help-seeking. They come to more likely in primary care. Any diagnosis, more likely to use outpatient services, more likely to be diagnosed as depression. Rates of prescription of psychotropics, you go, a woman having white discharge, etc., and in her prescription, you'll find Nexito somewhere. Nexito is escitalopram, SSRI. So that is more. Safety during provision of psychiatric services is very important for women. And this is National Mental Health Survey data, which tells us that women have more of BPAD, depressive disorder, neurotic and stress-related disorder, all bold items, and phobias and generalized anxiety disorder, and suicidal risk is also more in the women. This is the Indian data. So what are the mental disorders in women? Common mental disorders are much more in women. Both community-based studies and studies of treatment seekers indicate that they have 2 to 3 times at greater risk for having CMD. There is greatest risk for developing depressive disorders during childbearing years. Psychosocial events contribute to the increased vulnerability of this is a standard exam question, at least in MD psychiatry, Viva. What is the prevalence of depression in women and what are the reasons? The reasons are more psychosocial. These are role stress, victimization, sex-specific socialization, the way it increases their vulnerability, internalization, the coping style, disadvantage social status, perceived stigma of mental illness, violence, etc. Anxiety and somatoform disorders are common in women. You all must be aware of Nietzsche's study, which he did in South India in Brahmin women, where he found whenever they had emotional distress, they would express it by physical symptoms. So it was called idioms of distress. So women use physical idioms to communicate psychological distress due to social disadvantage. For example, I used to run family OPD when I was in armed forces. Most of the patients would come with vaginal discharge, some somatic complaints. And when you would go in detail, you'll find there is anxiety, there is depression. So, and I knew that these are problems. And the patients would keep coming back, and the rows, who would like to show to me would increase because I would be looking at other angles, not on their physical symptoms. So severe mental disorders, in bipolar disorder, I'm just touching upon all these things. Women have more frequent episodes of depression, more commonly have rapid cycling and seasonal pattern of mood disturbances. So atypicalities are more in women bipolar disorders. In schizophrenia, women have later age of onset and better course and outcome. Still, they have more social consequences. That means abandonment is more, homelessness is more. In women who are homeless, the prevalence of psychosis is around 20 to 40%. Sexual and physical abuse is more. There is chances of exposure to HIV, unplanned and unwanted pregnancies, stigma. All these things are much more in patients with severe mental disorder. Substance use in women is also very it also behaves in a different way than men. Their onset is early. Use is usually in the context of the family, either with the spouse or someone or friend. Greater emotional problems and poor social support. They also have more physical ill consequences of using substance use. Also, they face delay in recognition of the problem. There is associated stigma, lack of support systems for treatment and follow up. So, women have double whammy. So, one, they have illness, and then they are not encouraged to seek treatment. Mental health issues specific to women, where I'll talk about reproductive. So, there are four phases in a woman. One, when they are achieving puberty, menarche, when they are transitioning to reproductive role. At that time also, there are more chances of having internalizing disorders, body image disturbances, eating disorders. And there, if the puberty is early, that is less than 6 years in African population and less than 7 years, the puberty starts less than 7 years in Caucasian population. It's called early puberty or precocious puberty. All these problems are more, but they are also more and severe. And substance use is more, disruptive behaviors are more. It is difficult for them to adjust. So, this is when they are transitioning to their reproductive role. Then, menstrual cycle, we all know that many of women they face lot of PMS, which you say premenstrual symptoms, and when these are severe, we call it premenstrual dysphoric disorder, which has both psychological symptoms as well as somatic symptoms. They are present 1 week before the menses and disappear after onset of menses. Perinatal period, I'm speaking least. Pregnancy may, you can have all kinds of disorders, pregnancy, depression, anxiety, obsession, psychosis, bipolar. And also in postpartum, you have postpartum blues, depression, and psychosis. Blues are very common, around 50 to 70%, depression 10%, and psychosis. And these have adverse outcomes for mothers and children. So one day I had to prepare a talk on maternal mental health. So I was reading WHO document. 10%, the risk of suicide is very high in the postpartum period. In a study from England, in 1 year, the suicide risk was very high, around 10%. One study said that. Then I went on to compare with other causes of death in postpartum. Our postpartum period is after the delivery. So even hypertension, even diabetes, even all those things are less than suicide. So maternal mental health is very, very important and it has adverse outcomes. Menopause is also a phase when women have depression, and depression increases, anxiety increases. They have higher psychopathology. There is something called involutional melancholia, which used to be common in a woman who is menopausal. Women mental health at workplace, this is another new topic which now is being talked about. So here there is no data available. Depression, anxiety, stress, burnout, eating disorders are common. Exhaustion is common. Biggest gaps are found in all over the world. These gaps are found. 75% of the women they report burnout. And reasons are pay inequity, caregiving responsibilities, gender based violence, underrepresentation in leadership roles at work, sexual harassment, imposter syndrome, biological factors like infertility, all these what we have discussed. And most of the women are in informal economy as compared to the formal economy. So many women also avoid discussing their concerns at work due to societal pressures to handle their competing responsibilities, increased child rearing, adult caregiving responsibilities compared to their male counterparts, fears of negative work consequences. Women may neglect their own care often as they prioritize the care of others in the family. Social stigma or feelings of guilt can prevent women from seeking the help they need. So you all know about this POSH Act, which is sexual harassment of women at workplace, and it's a Prevention, Prohibition, and Redressal Act. I just wanted to tell you about this, that this act is available, protection against, and there is a committee in all the institutes, all the workplaces, where employees are mandated under law to comply with certain requirements laid down under the POSH Act. This law also lays down the redressal mechanism wherein the aggrieved person can file a sexual harassment complaint with the internal committee of the organization. So this must be there in every. I am part of the AIMS committee which looks at this. So, wow, so just finishing my talk, challenges and way forward. Conflict due to lack of concordance between modern and traditional values. These are the challenges because women are now want to take up many other things than just rearing, looking after the home. But at the same time, there is widespread stigma. You know, earlier, whenever a woman would behave, hysterical, hysterical. Now it is borderline. So, so if you try to, fight, so you are also stigmatized in your own way. It results in reduced utilization and accessibility of mental health resources by women. Families, they do not bring women to the care, and women have less allocated resources. For example, in any hospital, anytime the if you see bed occupancy, 67% are men and 23% are 33% are women. So always there are discrepancies. Violence and abuse experienced by women with mental illness, not really we do not ask these questions in the clinical examination. There is a need for that. At policy level, it is very strange. In the national health program specific for women like Janani Suraksha Yojana, component of mental health is completely missing. This is despite the fact, as I told you, that 1 year postpartum chances of suicide or completed suicide are very, very high. So this is what is the state of the problem. And we have to look at women's mental health beyond reproductive health. Whenever, when I search for anything, so WHO also talk about most of it is reproductive health, maternal health. So very less on on mental health of the woman. So women's mental health in public health, we have to see it in the public health framework. That means prevention, primary prevention, secondary prevention, and tertiary prevention. And we can reduce the policies can be aimed at reducing specific risk factors that affect women more, like poverty, poor housing, lack of basic facilities like education, poor work conditions. All these will act on the primary prevention. Enhancing protective factors like social support, social services, empowerment can be done by making policies sensitive to gender specific issues and keeping focus on women's mental health. Research, training, and clinical practice should focus on gender sensitive and gender related aspects of mental health. So I will conclude by, I told you, I'll tell you my story. I was facilitated on a International Women's Day that gave me a time to think about myself. So there were so many issues when I started. I come from a very small provincial town, as was the custom. If you are, I know this is beyond the topic, but I thought let me share it. If you are good in studies, you become a doctor. So I also became a doctor. I had finished reading book on Freud Passions by of mine when I was in fourth year, and also had bought a book. And then I was posted in psychiatry and said I'll do this. In fourth year, I decided, and then I took a very complicated route, did lot of entrance exams, etc., where I filled psychiatry, and then I did CIP. From CIP, DPM I did, then MD I did, and by 26 years of age, I was a psychiatrist. And then circumstances were such that I had to join armed forces. I was the first and only woman psychiatrist. But what happened was that psychiatrist was only a man. So I was always posted in Jodhpur, and I was always sent to the family OPD. I was never sent to the psychiatry OPD. And this kept on happening for 2 to 3 years. And then I used to cry because I always wanted to be a psychiatrist. So then what I did was, any presentation I would say, I will do the presentation. Any case would come from anywhere, I'll say, I'll attend the call. So gradually I made my space there, and I was allowed to work as a psychiatrist. So I would, so I also appreciated a lot of nuanced differences between the two settings and wrote paper there. As I was finishing my tenure here, I got selected at AIMS New Delhi as assistant professor. Here also, I had a problem. In my cohort of 75 professors who got selected at that time, I was the only one who did not have elite pedigree or networks. It was a complete change for me from powerful position of being a major in army, master of whole of psychiatry department, to junior most being faculty with no knowledge of the system. I gradually understood the work that I needed to do at AIMS, which is quite a lot. Anyway, there are many things which we do. So I had to face challenges. Some were of general nature, some were unique to me. What I found was lack of transparency in institutional structures. Institutional structures not of AIMS or army, also home, also society. But you don't get mentoring. You do not get, there is no transparency. And I also had lack of networks and pedigree. I didn't have time also, and lack of networks, and I didn't come from a pedigreed college. I was not from AFNC, I was not from AIMS New Delhi, or I was not from MC. So I was from a provincial place, and I was from that. So I had to work twice as hard, twice as longer to get even a fraction of resources. Major challenge was lack of networks, understanding of how to get support and mentorship some to the from who was outsider in the system. And that happened in CIP, that happened in armed forces, that happened in AIMS, and then gradually you settle down. So what sustained me? It was very frustrating, like that. Ability to focus and prioritize, work hard and persevere, ability to continue to work despite no rewards. Never compared, this was my mantra, I will never compare myself with anyone. I have my own journey and I'll do that. God has blessed me with an inherent flexibility where I can keep redefining myself. I'm very assertive and I stuck to my values. Many times I did not get what I deserve, but then I also got empowered by rewards given by my students, my colleagues, and my patients. Kalpana is my uh, colleague from CIP and also in armed forces. So I'm here because she has called me. So all these things are a kind of reward which you find. What sustained me was I never gave up my hobbies. I read, I watch world cinema, and I travel, and I have a lot of resilience. Otherwise, I would have been drowned. So, in a sense, struggles of being recognized, acknowledged, and supported as equals for women leaves us a lot more to do for all of us. There is still more to do as a society at governmental, institutional, and personal level. Challenges can manifest in different ways, very subtle. Nobody knows, but you know there is a bias. If we want more women to transcend boundaries of their circumstances, we need to institutionalize mentorship. And also, there is a lot of old boys club. There are less people here, so I'm sorry, but there is old boys club which works. So anyway, I have done a lot of I was asked to talk on women in psychiatry a long time back. I produced 6 papers out of it. So this was one of the papers where I said that women are there in psychiatry increasing in number, and they are in junior positions, but now they are coming up in senior positions also. This is an article which I wrote about women in medicine, that women have to, women doctors or professional mental health professionals are more democratic in their approach as compared to men. The studies in West also, in here also. There's a lot of things. Then also I wrote this. So these are some of the things. These are some of the papers. When I was collecting material for this, then I realized I have done a lot of work. So then this is some work I did. Then this is another work. So thank you so much. Thank you.
I'm sure all of you have seen the presentation in such a lucid way and comprehensively it has been covered by Dr. Mamta. Uh, what is very important here to mention that despite of the work and the nuances you have covered with, it needs a lot of courage and a lot of honesty to accept and talk about the hazards of the gender in the forum like this, in a public forum. I don't want to engage in that kind of a self pity behavior because we all consider to be the empowered women who are sitting in the hall. But the stigma from the psychiatry, from the mental health issues, and from the gender, we cannot brush it away. We cannot brush it off by saying that everything is very fine. If there is stigma about mental health, there's a lot of struggle which is inside for rising the position and also contributing without facing any stereotype. I wouldn't say stigma, it is stereotype, gender stereotypes. So all of us know that we combat in our way, and Dr. Mamta has really done very well. She is also the president-elect of Indian Association of Psychiatry. She talks less about her achievements and does more work. There are some people who may talk and do work, more work, less work, but she has done tremendous work, and everybody knows the field of the psychiatry, especially within and outside, and recognizes for her work. Thank you very much. And if you have questions, I would ask from the audience any comment, any addition, any questions, please. You may pose one or two questions.
I brought in my story just to tell you that if you work hard, if you prioritize, these are some of the things actually which take you forward, not the pedigrees. So I just wanted to tell you that. So that's why this story.
Jamna would like to say something. Yes. You are the one person who can really point out your opinion if you would
Yes.
like to say. I can see Dr. Ashima also sitting in the audience who just joined in. So I would like to take the comment and views from Dr. Ashima, Dr. Jamana, who are sitting here, and Professor Jedi, because the one opposite we should ask for equivalent. Let's hear from them. Please, Pantapay. You want to ask something?
Yeah.
After that,
Hello.
we-
Ma'am, I'm Shilpa Mazumdar, a clinical psychologist, and I come from a medical background a lot, entire family, my husband and all. So, by default, I have many doctors as my patient. Lately, last 3, 4 years, I've seen in my practice that a lot of gynecologists are coming with BPAD symptoms a lot. Is there anything to do? Bipolar. Is there anything to do with their night practice? They do a lot of. So just this is just my curiosity, and for that time.
So for bipolar disorders, I have also made a public video. There are 4 things. The you have to sleep at night for 8 hours. You can't do shifting. If that those anybody is gynecologist, it's anybody. So that is one pillar of prevention and stability of bipolar disorder. So it's very, very important. You're right in pointing that. Thank you.
Thank you for that very lucid talk. I completely echo Dr. Kalpana's views. And yes, the stereotypical behavior in every institution is prevalent. But once you voice it out, you are subject to so many problems that you face. So, how do you overcome those kind of problems? I agree with you that you have to work hard, you have to do these things and prove yourself. But there are many things which the administration decides not to put you despite your competency.
I've been very lucky in the sense I was in CIP. So CIP, I was the only woman. In army, I was the only woman in the world, and also at that point of time when I joined. And all my colleagues and once I worked hard, I also got worked hard, and I was not in any politics. And at AIMS also, I worked hard, and now I'm settled in AIMS also. So I think not getting too much into too many things and defining your clear path, understanding, and also understanding what are your real core needs. I think that's very important. What are your core needs? And then working towards those core needs. That
Thank you, ma'am.
Just a small one because we will proceed to the session. One comment from Professor Jayati and then Dr. Ashma, one comment because then we have the overs like Dr. Debbie waiting to be connected from the.
Dr. Sood, I heard about you, and I'm also CIP in 76, 78 batch, teacher of many teachers. Anyway, it's a, you have two part of your presentation. One is the subject matter, another is your personal story, which is facilitating the things. So far, the personal story, I salute to your struggle and your ultimate achievement. Regarding the first part of it, you have given a number of cases, number of situations when the women are reporting or have been reporting, in which one point is very common and which is also that coming out to the male folk also, that is multi-skilling. The women are basically supposed to be multi-skilling from the day one. And now situation is changing. So multi-skilling itself is stress. Nothing to do particularly for your gender and all this thing. It is there, maybe with a different scenario. And postpartum issues are either not reported or it is not coming very, very strongly as it used to be. In CIP, every third, fourth woman in the tube ward used to be from postpartum issues, and we were quite concerned about it, how to take care of this part. But now, perhaps it is reducing that, maybe because of better counseling, maybe because of prenatal cares, parental acceptance of the issues, whatever may be this. That is my subject expression, and I salute to your struggle and which is.
Thank you, sir. Multi-skilling is, I think, a boon as well as a bane. So let's not talk about that. Multi-skilling बहुत ज़्यादा करने की जरूरत नहीं है. हमने बहुत कर ली. जरूरत one. Second is when I was preparing for I have actually given talk on each of these things, on each topic. Maternal mental health in AIMS data of last 1 year. In that was 2008. Only 2 cases were referred. So very less referrals. I agree. Thank you. Thank you, Sach, sir, for appreciation.
I'm Dr. Maitili. I just wanted to, give my experience about the disability in women. Basically, what I saw, I think you must have been, you must have got cases like where POXO cases, or when a woman or a girl is disabled for various reasons. It could be mental retardation, intellectual deficit, or autism, or any other. And when they go through abuse, sexual abuse and all, those cases are so difficult, and there are no policy level changes or not specific how to deal with those cases in the court. Basically, have you come across, or in AIMS, how do you deal with those cases? Just wanted to know about that.
That I can talk to you later. POXO cases are dealt with by the child psychiatry. There are child psychiatry units.
Definitely.
So otherwise, the rest all we are dealing.
Okay. Hi, good morning, Dr. Mamta, Dr. Kalpana, Dr. Jabana. I'm sorry I just got in late, and when I came here, it was barely a couple of last minutes of your talk is what I heard. I missed your personal story as well. I do know you well, and we've had this conversation about how you've managed and multitasking. Especially, I remember that conversation when you were constantly working even at home. This is one question from you for the audience and for me as well. Women have multiple roles to play as a mother, as a homemaker, and as a wife, as a daughter-in-law, and of course, as a professor as you are. How do you really manage all of that, managing time when you're saying that a woman must sleep for 8 hours? How does one manage that? This is one thing that I'm thinking on. Secondly, I wanted to just share from the neurological conditions. it is the women who are never brought to a hospital set up for treatment. And we've seen this especially when it comes to epilepsy. They don't even want to acknowledge that they are having any disability. So they don't think that they need to be brought for a treatment. So they continue with faith healing and iron rods, hot iron rods, and they're continuing. And we have publication from AIMS. So yeah, thank you.
You have to identify your core needs. And then these are my core needs, and then keep prioritizing to look after your core needs as professional, as mother, as whatever, and keep prioritizing one day one, another day another, and third day that. So I think that, and never compare yourself with us. Never. You are unique. You have your own journey, and that's the mantra, I think.
Thank you, Dr. Manchana.
A few last comments and one or two questions to you. It was a comprehensive presentation. And I think over the ages, generations, the women are facing and have been facing a lot of struggles, and also women are resilient. And if you ask any women in the audience, like they will have a story to say. I think that is something which women have learned over the ages to survive and to thrive and all that. My question is specific to the psychiatry and psychology practice. Like being a woman, how do you what are the specific things that you look for when when you are assessing a woman with mental health, and what are those things which needs to be kept in mind by a psychologist or a psychiatrist? Like, that because it is the when we talk about women's mental health, it is a lot of other factors, social, cultural factors that come into play. So when you're assessing a woman with mental illness, and when you're treating them, what are the things that you need to keep in mind? Yeah.
This is an extremely good question. I have done a presentation of 45 minutes on this particular topic. So, first and foremost is the age of the woman, young, and marital status, and family support. So, age, her personal resources like education, etc. Age is very important for me. Is she young? She's married, or she middle age, or she's old age. That is first cutoff. Second cutoff is her personal resources, resilience, which is asked by history. And then third is the family support. So this is a general half an hour first assessment when I do. These are three things are must. That, and then gradually, longitudinally, then I keep assessing. Then as we have established rapport, then I go into I am always looking for what are their aspirations for themselves. Maybe fourth session, maybe fifth session, and then we work together towards that. And my aspiration for her aspiration for herself. So these are some things which are very done. But at the first thing, these are something which are very important to age, their personal resources, of course, some stresses they are facing, and family support. Family's attitude, basically, and support.
Thank you, Dr. Mamta. I think over to you. We are just come to the end of this.
I would like to extend my thanks to all the dignitaries, audience, chairpersons, speakers for their valuable discussions and the insight on the talk on women's mental health. And I would request Dr. Manjula ma'am to kindly facilitate Dr. Major Mamta Sood ma'am. Please give a round of applause. I would request now Kalpana ma'am to facilitate Dr. Manjula ma'am. Thank you. And now I would request Professor Jamna Rajeshwaran ma'am to please come on the stage and welcome Dr. Kalpana ma'am. Felicitate Kalpana ma'am. Yes, sir. Thank you. Thank you.
Good morning again. The next session we have Dr. Debbie joining us, Dr. Debbie Joy Ellis. I hope, ma'am, you have joined as a panelist. If you can, IT can help. Yes, hello, hi.
Hi, how are you?
We are all doing good, and we are in the second day of the conference. Welcome, and I would request, let me just kind of. The session is going to be a plenary session, and the session's topic is recent advances in REBT. Dr. Ellis has joined us from US, and I would request Professor Dr. Kalpana Srivastav, ma'am, to come and introduce us, our esteemed speaker. Ma'am, please.
Very good morning from India. I know it's good night for you. Like it must be very late in the evening for you. Thank you very much for being awake for us. At the outset, I welcome you for this international and third annual conference of Clinical Psychology Society of India. If I say namaste from India. Okay?
Namaste from New York City.
That's so nice of you. We are really looking forward to your session. Just a small introduction of Dr. Debbie Joffrey Ellis. She was born and raised in Melbourne, Australia, New York City, and she has been there for the last 2 decades. She's a licensed psychologist, licensed mental health counselor, New York, writer, adjunct professor of Columbia University in New York City, where she teaches rational emotive behavioral therapy and comparative psychotherapies. For years, she worked with her husband, the brilliant and renowned pioneer of modern cognitive therapy, Dr. Albert Ellis, giving public presentations and professional trainings in this approach of rational emotive behavior therapy, as well as collaborating with him on writing and research projects until his death in 2007. Before his passing, he stated and wrote that he entrusted her to continue his work. She is being recognized as a world renowned expert of REBT and regularly presents throughout the USA and countries around the world. To students, academics, practitioners in the helping situations, and professionals around the world, she creates a general public awareness and connects with all the people who really look forward to the psychotherapies and training of psychotherapy. She wrote the second edition of the book, Rational Emotive Behavior Therapy, published in 2019, that she co-wrote with her husband in her first edition. She's also featured in DVD produced in the American Psychological Association, demonstrating and discussing the REBT approach. She has written chapters for various textbooks, articles, has reviewed publications, and has been a part of American Psychological Association Psych Critiques Journal. In 2014, she was named Legend in Counseling at the American Counseling Association annual conference and has received various other awards and acknowledgments for her work. She recently was nominated by former American Psychological Association President Dr. Frank Farley and renowned psychologist and author Dr. Stanley Triplett to receive the American Psychological Association's International Division as a Global Citizenship Award. She joyfully and passionately continues her mission informing as many people as possible through her presentations, teaching, and writing, and the way she strives to walk her talk. That each one of us has a power to create our own emotional destinies, despite and including challenges, circumstances, and through teaching how to's of doing so. Thank you so much. And we welcome you for this session. Over to you, Dr. Debbie.
Thank you. Thank you so much for that lovely introduction and welcome, Dr. Kalpana. I really thank you for your gracious invitation to me to speak at the conference. Thank you to your organizing committee. Thank you, the President, Dr. Jamuna Rajeswaran, and the honourable patrons and my fellow speakers, the attendees who are there live in person. I wish I were with you at Amity University. And also I thank all the attendees watching on their screens. It's really a great joy to be with all of you. I'm delighted. I actually tuned in yesterday morning for your morning session, and I thought only it was 1 a.m. in the morning, and then it was 2 a.m. And I just wanted to keep watching. There were so many important things that were said and shared, and I wish I could have come for the high tea. I bet there's nothing like an Indian chai. Anyway, I digress. So, but I do and I don't digress. So back to what I was hearing yesterday morning, and I jotted down some points. And obviously, I'm not going to have time now to mention all of the points that that grab my attention, but a few of them I will, in relation to what I'll be talking about. The power, the gift of the pioneering cognitive approach of rational emotive behavior therapy. A lot of people, unfortunately, since my late husband died, are not aware that rational emotive behavior therapy, I'll call it REBT from now on, or I'll lose half an hour of the time. REBT actually was the first main cognitive approach. I want to acknowledge the work of Dr. Alfred Adler, because his work also had some cognitive elements that my husband acknowledged inspired him as well. But in terms of challenging Freud full force and not just challenging and breaking away like Jung did and some others did, but creating a whole new world in psychotherapy, that was Albert Ellis. And a lot of students that I've met, that I teach, and young practitioners that I teach not only in the USA, but all around the world, are not being taught the chronology that, in fact, rational emotive behavior therapy, REBT, was first introduced to the psychology world in the early 1950s. And the great Dr. Tim Beck, who's known as the father of CBT, actually reached out to my husband in the 50s, and my husband was a mentor to him and a great inspiration and influence, and CBT came out in the late 1960s. So I think it's important, for the sake of historical accuracy and educational integrity, that we know our roots. And it's not a matter of this came first and this is better than that. No. It's a matter of, well, this came first, it influenced this. These are the qualities you see here. Oh, but look what he added. For example, Dr. Beck and other CBT practitioners and researchers have produced and continue to produce an enormous body of excellent research. Dr. Beck was connected to the University of Pennsylvania, which facilitated that. My late husband, and then in the final chapter of his life when I was with him, so we were in his non-for-profit institute. Some research was done there, but not the great body that has been done under CBT. The good news is that all the research that I've read, and I do not claim to have read all the research, but I've read a lot of the CBT, supports the premises of REBT, which is not surprising because CBT is based on REBT. but doesn't emphasize some of the points that REBT does, which I'm going to mention, and to link into your wonderful conference theme, that serve our attending to diversity in our clients, in our society, in the world. I'm not saying that CBT doesn't. It's not a competition. I'm just saying certain approaches have certain main emphases and differences and similarities. But my main focus is REBT. That's what I'm here to mainly talk about. And just as part of the introduction and that historical context, because I'm talking to you, and I wonder if you have had the accurate education, particularly the younger practitioners and students, that CBT and ACT and DBT and positive psychology and other approaches are so may not have existed in the forms they are in without those roots of REBT. And so my goal in the time we have today is to just give the basics of REBT. My hunch is that some of you know the main principles, some of you may or may not, some of you don't know. And so for some it'll be a refresher, for some it'll be a basic introduction. And I will... my intention is to relate them to the excellent conference theme, of course. I would like to talk about my hope for future directions. And Dr. Kalpana, originally only had 45 minutes, and now we have an hour to give opportunity for questions. And I really look forward to hearing your questions. I'll do my best to answer them because I may not, in the time I'm talking, cover everything you might want to know about. So anyway, that's the general plan. Some of the... I'm looking down now because I made notes, as I said, of what some of the speakers were saying yesterday morning, and just a few. I don't have time for all, but some of the things that jumped out at me that I thought, oh, REBT can serve this. REBT attends to this. And by the way, I'm not saying it's the only one, but I'm here as the champion of REBT at this moment, and that is my focus, and that is my passion, and that is my mission. And REBT, by the way, is multimodal. So for people, psychiatrists, psychologists, therapists, counselors who practice primarily another modality, where is it written that you can't bring in some of the techniques of another approach? And so it is with REBT. You know, we're encouraged to serve our patients, our clients. And if there's something that's not REBT, but it'll help the client, and we have sufficient enough education about it as a therapist, bring it in, bring it on, serve it for our client. So anyway, one of the things that I wrote down that Dr. Jamuna Rajeswaran talked about was the importance of tending to lack of training. You know, in any profession, not just the healing professions, we have the effective professional, the more effective, the less effective, and the harmful. And without sufficient training, and I would say ongoing supervision, then at the very least, the hope is the therapist would do no harm, would do some good, but at best can offer greater inspiration, motivation, tools, techniques, and encouragement. So I so much agree with Dr. Jamuna, the importance of adequate training, of mentoring, and of being educated about how to handle ethical dilemmas. And again, having a mentor or some supervisor who we can go to if we don't know how to handle a particular dilemma. And let's say, coming back to the theme of diversity, someone of a certain gender orientation who the therapist has never worked with before and feels a little unsure what might be offensive, what not. First of all, it's a good idea to do the homework. Secondly, to reach out to someone who knows, who has experience. And thirdly, to model when with the client of a diverse or different, less familiar background or orientation, to not be afraid to ask questions, to admit with an attitude, and this is one of the things that REBT emphasizes, model unconditional other acceptance. That even if I don't understand what you do, even if I don't like what you do, I remember and I honor that you and every other individual has worth simply because you exist. You know, separating the behavior or the choices or the beliefs from the essential worthiness of each human being. According to REBT principles influenced by general semantics of Dr. Alfred Korzybski, our behavior doesn't dictate our worth. We are not what we do. We do what we do. We're responsible for that. But essentially, REBT and other approaches assert we have worth because we exist. And so if we're in a session and working with someone who we feel somewhat ignorant about in terms of their lifestyle, or can ask questions, you know. So anyway, there's some of the thoughts that came up as I listened to Dr. Jamuna, and then Dr. Selvamurti with his smile and his zest. It's such a pleasure to listen to. And he was talking about the importance of attending to vital mental health challenges, including handling stress, and not living in the present, and lack of gratitude, and people's, many people, not addiction to gadgets these days, and isolation. I'm thinking, ding, 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 ding. REBT attends to these in a simple, easy to apply, easy. My assumption when I say that is for a person who's not cognitively impaired and who's not suffering from a psychotic condition that prevents them from being in touch, as you might understand what I mean when I say reality as we know it, and is not able to understand the principles. Then REBT and other approaches have limited, I'm not saying no help, but limited. But anyway, you'll hear in a few moments the particular elements that I'm talking about in REBT that target those areas. And Dr. Selvamurti was also talking about the need to build resilience, embrace our uniqueness, that each person has their own samskaras. I studied yoga and I used to read Kashmir Shaivism and Vedanta, and I love those terms, samskaras. And a need for a personalized approach. In REBT, and I would hope in any approach, it's not one size fits all. It's not, this is the technique for depression. This is technique for a woman who's being treated with inequality. This is, no, with REBT, there are a variety of tools and techniques, cognitive, behavioral, emotive. Of course, in our time, I don't have time to go over all of them, but just saying that the effective therapist in any modality, but I'm talking about REBT, will tailor, as Dr. Selvamurti indicated was important, a personalized approach. And I'll add that REBT reminds us while modeling unconditional acceptance of that person. He talked about the importance of actively looking for reasons to be happy and to not let materialism override the profound spirituality of your magnificent, your rich Indian culture. Dr. Nishi Mishra talked about the mind being the most important weapon. I remember often hearing when I was in India, after I finished my psychology studies, I was in India for a while and I was studying yoga meditation, and many of the messages got in various ways, hearing lectures and talks as the mind can be our best friend or our enemy, right? And another expression that I really love from Patanjali, the Yoga Sutras, forgive my poor pronunciation, but yoga chitta vritti nirodha. Yeah, that yoga is to still the waves of the mind, right? And what REBT and other philosophies, other forms of wisdom remind us that when we use the mind in a rational way, in a healthy way, we create healthy emotions. Healthy mind and healthy emotions contribute to better physical health. And REBT reminds us of the inseparable connection between the mind and the emotions and our physical health. And I hope Patanjali will not consider me precocious or audacious. I'm thinking and hoping his spirit will unconditionally accept me when I say, in addition to yoga chitta vritti nirodha, REBT chitta vritti nirodha. If we're going to use it and apply it, it's not enough just to think about it, but action. So REBT is truly imbibed with universal wisdom. So important when it comes to matters of diversity, small scale, large scale. So, and I'm going to say something to you that I've said to a few other people one-on-one perhaps, but I don't think I've ever pronounced it at a conference or to a large gathering. But I feel it's appropriate and I feel comfortable enough, I hope that's the right decision, in sharing this with you, that I believe that REBT is a solid, evidence-based bridge between science, psychology, and spirituality. One of the other things that Dr. Selvamurti said, I mentioned it, materialism, don't forget the spirituality. And it's really important that I clarify what I mean by spirituality when I say that. I don't mean religion. My definition here of spirituality is the desire to care about and for other people, to help other people, not just with mouth, but through deed when possible, and with compassion and loving kindness. And so this spirituality is seen, as far as I know, in all the main religions, at least all the main religions that I know of. You could Hinduism, Muslim faith, Buddhism, Christianity, Judaism, whichever else I left out, and and the philosophies of Kashmir Shaivism and Vedanta and so forth, and also it applies to secular humanists. REBT doesn't just apply to people who believe in God or a deity or many deities. It's about compassion, human kindness, and decency towards others, ourselves, and life in general. And so now, quite quickly, I've lost track of time. So I hope, Dr. Kalpana, that you or someone will stop me when it's time to have a period for questions, please. Now, quickly, the basics of REBT. So the first main point is it's not what happens, it's not our circumstances that creates our emotional destiny, our emotional experience. It's what we tell ourselves about those circumstances that creates our emotions. So whether a person is suffering from a particular mental health condition and they feel, it's a stigma. I can't, I'm ashamed to let people know, whether it's people that might, you be quiet about that. Shh, don't let the neighbors know that you're depressed or anxious, or whether it's inequality for women or for people of any group. Whatever it is, it's not that circumstance that creates an emotion. Again, it's our beliefs about the circumstance, our perception of it, that creates the resultant emotion. REBT asserts that when we think in healthy, rational ways, we create what REBT calls healthy negative emotions if it's in regard to a challenging or painful or brutal situation. And when we think in, what I say, healthy, rational ways, we create healthy negative emotions. When we think in unhealthy, irrational ways to an unwanted or brutal situation, we create unhealthy negative emotions. Now, one of the many brilliant things that my husband came up with was under the umbrella of negative emotions, because many approaches talk about positive emotions and negative, but under the umbrella of negative, my husband distinguished between the healthy ones. They may be painful, but they're part of the enriching tapestry of life that contains loss and suffering and uncertainty and disappointment. He distinguished between them and the, I'm sorry, it's after midnight. I keep losing my train of thought. The unhealthy ones and the healthy ones. So let me tell you what they are. When we think in irrational ways, the unhealthy negative emotions include depression, hopelessness, despondency, anxiety, panic, fear, guilt, shame, and rage. And when we're in the habit of thinking in rational ways about the same brutal or unwanted situation, instead of anxiety, we create concern. That's healthy, that's motivating. Instead of hopelessness and depression, we create healthy sadness and disappointment. That's healthy. It's part of accepting we don't always get what we want. It can motivate us if we're sad and disappointment. What was my part in this? How could I do it differently next time? Yeah? And also healthy grief. Now, in its early stages, grief can be agonizing, and it can be very hard to distinguish it from depression. But as time goes on, and it's a different period of time for different people, but let's say some months, the healthy grief is that emotion of that vacuum, that missing of whoever they've lost, or maybe a period of life is over, that they didn't want to be over, yeah, that grief, yeah. And there's the realization that the grief is a result of our gratitude and love for that or whom we have lost, yeah. And so in time, it's clear what is healthy grief versus depression, which is no interest in life, don't want to get out of bed in the morning, no interest in feeling better. You know, with grief, once one is out of that raw, agonizing period, one can shed the tears, feel the pain, but still laugh at a joke, still go, wow, at a beautiful sunrise or sunset. You know, it doesn't overwhelm us, it actually enriches us. So then back to the different healthy versus unhealthy emotions. When we think in rational ways, instead of rage, we experience what REBT calls healthy anger, which is connected to our moral compass. And what also makes it healthy is we don't react. We have the discipline and restraint to think things through. You know, do I approach the person? Do I run for the hills? Do I call the police? Do I do some yoga or do a workout to let off steam? You know, we think things through versus rage, which can do more harm and usually no good. And finally, instead of guilt and shame, which are often there when people attempt suicide, feeling worthless, feeling not enough, emotions that people who identify with groups or communities that a lot of people don't accept, you know, again, back to diversity. And so instead of guilt and shame, when we think rationally, we experience regret. Maybe we did something bad. REBT teaches us that each one of us is a fallible human, capable of making mistakes. We are not a mistake. We may make a mistake. We're fallible humans. And so with regret, we can hopefully learn from it, not repeat it, make amends if it's possible. It's not always possible. But practice unconditional acceptance of oneself. Sometimes things happen, and others, and life. I'll say more about those in a few moments briefly. So I hope it's clear the difference between healthy and unhealthy negative emotions. So then what REBT offers is the education, and it's highly psychoeducational. It's active directive, not passive. It teaches the difference between irrational thinking and rational thinking, which of course it encourages the latter. How valuable to have this taught to children. My husband wanted that. And in fact, in his institute decades ago, there was a school for children that taught the regular syllabi, but also principles of rational thinking in a language and at a level that children could understand, called rational emotive behavior education. So if we could educate children, people in the workplace who are stressing themselves out and don't realize they have a choice, don't take time to actively hang on. What am I telling myself now? To make myself feel so disempowered or furious or powerless. And how can I change my thinking? So, you know, the workplace, the school, and anywhere else to educate people. And those of us who are therapists have the marvelous opportunity to educate our clients. in a level of communicating that they can understand. If our clients are doctors and academics, we would use more intellectual manner of speaking than if our clients or patients are less educated. REBT is not complicated, but it's empowering and so effective. So when we think in irrational ways, what are the elements? Rigid, non-flexible. We have demands, not preferences. There are shoulds and oughts and musts, and there are three main ones. I should always be loved, liked, approved of by everyone. There's a setup for a fall. A second one is you, and you can be an individual or a family or a community or a political party or a religion or a country. You must believe what I believe. You must believe and act the way I think you should. And the final big should is life should be fair and with justice. Now, of course, REBT encourages people to take actions to make life more fair and create more justice. But in the here and now, which we're living in, it appears it's not totally unfair and there still is some justice. And to tell ourselves it should always be fair and with justice, yes, ideally, but it should always, when right now it isn't, is the formula for rage or hopelessness, or both, or anxiety. So continuing with the elements of irrational thinking, we overgeneralize, we catastrophize. It's the worst it could be. And if we're alive and not in pain 24 hours a day, it's not the worst it could be, is it, right? We have no sense of humor. We blow things out of perspective. We have low frustration tolerance. I must have what I want when I want it. There's a need for certainty, lots of luck. What in life is certain except possibly that we're going to die? And we damn others and ourselves and life when things don't go the way we think they should. When we think in rational ways that create the healthy negative emotions, we have preferences, we have wants, we have desires, not demands. We have humor. We have high frustration tolerance. I love this mantra. I share it with you. I can stand what I don't like. I just don't like it. Instead of, I must have what I want when I want it, little baby that I am. We don't catastrophize, we don't overgeneralize, we don't stereotype, we don't awfulize. And one of the most important areas that REBT emphasizes that is not emphasized as much in the other cognitive approaches is the importance of developing unconditional self-acceptance, unconditional other acceptance, and unconditional life acceptance. That doesn't mean we accept bad behavior, but we're willing. Let's say someone else has done an atrocious deed. The rationally thinking person would, if they could, seek justice somehow with the law or police or authority, do something, but from a state of emotional stability, not rage. And one of the effective ways of doing that, but it's a choice. Some people love their righteous rage. They don't realize what they're going to do over time to their physical health. There's so much research. The Journal of the American Medical Association has published articles about the impact of chronic anger on the cardiovascular system, on the immune system. I'm going to talk in a few minutes about REBT's emphasis on the importance of daily gratitude. And one of my closest friends is a cardiologist, and she gets the Journal of the American Medical Association, and she's shown me a few articles, and you don't get much more scientific than that journal. So the articles, I hardly understand the long chemical terms and the stats and the graphs, but I understand the introduction and the conclusion usually. And so one of the studies she showed me, there was a long-term study of patients with cardiovascular issues of similar degree of decline. And it was a long-term study, and 50% were asked to do daily gratitude, and the other were not asked to do daily gratitude. And astonishingly, those that did the daily gratitude lived on average 15 years longer than those who didn't. Astonishing, right? And so I was saying to talk about anger and the evidence, the impact on the physical body of the thinking and the emotions that we create. So anyway, back to unconditional other acceptance. So if we're willing to consider that if any one of us had the same genetical makeup, epigenetics, the same brain chemistry, the same upbringing, were modeled the same behavior, let's say their father, when angry, was violent, and the child thinks that's what you do when you're angry, that's normal. If any one of us was brought up like that and then developed certain belief systems that were toxic, and if any one of us was thinking the way the evildoer, did you hear what I said? I didn't say the evil person, I said the evildoer. If we were thinking like that, isn't it likely we might do the same thing? That doesn't justify the behavior, but it gives us an opportunity if we choose, and it's a choice, to, over time, might take time, have compassion, forgive, at the very least, accept, and to stubbornly refuse to harbor rage and or depression or hopelessness, because those emotions don't affect the evildoer, but they may over time kill us. So an unconditional self-acceptance. How does someone who's had the message, you're useless, you're hopeless, you're a waste of oxygen, I wish you hadn't been born, had these messages, and then they're in a group, and with social media, that's how you're meant to look, and look at me, I'm disgusting, I'll never be enough, no one will love me, and all these self-torturous ways of thinking. How can someone in the habit of thinking like that develop unconditional self-acceptance? By the way, it takes time and repetition. It takes the willingness to have a philosophy of life and to reflect on the fact that anything temporary, like material possessions, looks, even our talent, even our gifts, our skills, they're temporary. They can change. And if we base our sense of worth on having any of those things, certainly enjoy them, but REBT would guard against having them define our worth, because when they change, our worth goes down. My husband wrote a book that he wanted to call Why Self-Esteem is a Sickness, but the publisher didn't like that book. It's somewhere here. Anyway, so it's called The Myth of Self-Esteem. You can get it online in paperback, and also recently it's accessible in audio version with me reading it. So the myth of self-esteem, I esteem myself because, will lead to emotional and mental and then physical sickness in all probability. So, and unconditional life acceptance, it's not about denying what is bad, denying inequality in the workplace, denying that, yeah, I have a disability. I'm going to act as if I don't. And no, it's about accepting reality, but not just focusing on what is not desired, accepting that, but making time to also see what still is good. And again, if one is alive and not in physical pain 24 hours a day, we can find things that still are good. It's a choice. So I hope that's clear, the difference between healthy, unhealthy emotions, rational, irrational thinking. With awareness, we have choice. Ongoing effort is required. Albert Ellis folded into his therapy from the get-go homework activities, that it's not enough just what happens in the session one-on-one or in group therapy. That's a start. That's a place of education and encouragement and motivating and supportiveness. But what will really maintain change is what one does in between sessions. And so the importance of homework and the benefit, of the variety of techniques which I mentioned before REBT provides. As I already mentioned, but I will again, REBT encourages actively the importance of daily gratitude. It's good to have a journal, but for some people, just recalling first thing in the morning, before going to sleep, and any and all times in between. I don't have time to go over all the tools and techniques, but I will mention one of the most empowering ones is the ABCDE of REBT. And it's, if you look at books by Albert Ellis or the one I wrote with my husband or chapters I've written in various textbooks that I believe are used in courses in India and elsewhere. But you can also look at my website, which is my three names like one, debbiejoffellis.com. And under the tab self-care sheet, and there's no charge, and it goes over the ABCD that I'm about to describe. But this is such a valuable tool for ourselves, healer, heal thyself, and for our clients and people we love. We don't just have to help people in our office, right? I'm preaching to the choir, I'm sure. So anyway, A, activating event. This is for someone who's aware they create unhealthy negative emotions and want to stop. So let's say someone suffering from anxiety, they would write down A, the activating event, what appears to create the anxiety. A negatively critical boss puts me down every day. Then we go to C, the consequence, anxiety. Then we go to B, beliefs. And specifically, we identify each irrational belief, as many as we can think of, in response to that activating event. He shouldn't act that way. I can't stand it. It's not fair. I'll never be able to be promoted while I'm working under him. I can't stand the way he treats other people. There should be equality. And you listen for the should and the must and the ought. Again, REBT encourages healthy preferences. The shoulds will get us in trouble. So when we've done that, the D is for disputing. And this is another really unique, powerful element of REBT, not so much emphasized in other approaches. Disputing, pragmatically, logically, Socratically. You see, many cognitive approaches says identify your irrational beliefs, cognitive distortions, and replace them with healthy beliefs. Of course, that's what REBT leads to. But REBT wants to root up, bring up the roots of our toxic thinking, not just cut off the toxic plant, but the roots are still there and more shoots will cross up. So the disputing allows us to see there's no truth in what I was telling myself. So those irrational beliefs lose credibility, and over time, as we keep reminding ourselves that, they won't come up automatically. So, where is the evidence that I can't stand it? I'm still alive. Where is the evidence, just because I don't like my boss treating me this way, that he shouldn't? It would be preferable, but he is, and I can stand it. Where is it getting me? Pragmatic disputing. Is it helping or hurting me to demand that things be different now? How can I remind myself of my resilience? After all, I'm still here. And so we dispute, and the answers to the disputations become our effective new beliefs. And then it's important to repeat them many times for at least a month. Neuroplasticity has proven that it takes at least 30 days, or for some of us, but to create new neural pathways. And so the brilliant visionary Albert Ellis in the 1940s, before neuroplasticity was a word, was saying to his patients, do this for 30 days. Yeah. So that's, one of the techniques. There's in vivo desensitization, exposing oneself gradually to that which we're afraid of course, if it's non-risky or dangerous. For example, my late husband, when he was a young man, was terrified of talking to women, and he wanted to overcome that because all his friends, his male friends, were asking women on dates. So he gave himself the homework, talk to 100 women over the month of August, see if anything terrible happened. And he was doing the self-talk. What's the worst that can happen? Nothing. She runs away. It won't kill me. I can do this. I can do what I'm afraid of. And so he would prepare himself, and then he would speak over the month of August in the Bronx Botanical Gardens, speak to women. He made one date and she didn't show up, but he overcame his terror in vivo desensitization. So that would work very well with people. Positive reinforcement for others who want to stop behaviors, addictive behaviors and tendencies. Shame attacking exercises where we do something that attracts attention. Again, that's not dangerous, but that gives us an opportunity when people are looking at us to remind ourselves, well, I'd love them to think I'm great. I would love their approval, but I don't need it. And a funny story
Excuse me, sorry to disturb. Just can you conclude in 5 minutes, ma'am? Then we can have few questions also. Then we'll have time for question and answer.
Perfect.
In 5 minutes. Thank you.
Thank you so much. And so will you tell me in 5 minutes? Because, see, I get on a roll. Thank you for that, Dr. Kalpana. So at a workshop, we asked our attendees who were therapists over lunchtime, do a shame attacking exercise to practice not needing approval of others. And so one of the attendees had a banana and he put a string around it and walked down Park Avenue, which in New York is a very fancy, schmancy millionaires row, right? And people were looking, he's walking, dragging a banana behind him, and he was, self-talk. So they look at me, so what? I have worth, I'm doing something funny, so what? And one woman said to him, what are you doing? And he said, well, can't you see I'm taking my banana for a walk? And she was like, pfft. And he said in that moment he felt enlightened, that it was so clear that her criticism of him had nothing to do with his worth. It was all about her opinion. So anyway, in my final minutes, I just want to mention future directions for REBT. I've mentioned some of the things that are very unique to REBT in the cognitive world. And since my husband's passing, I've very much been emphasizing the importance of daily gratitude. He would have agreed with that, but he may not have said it as much as I do. And but in other ways, you know, in his brilliance, what he created, it seems to have it all. Now, what would be good as time goes along? More research to satisfy the people that want more evidence. There is a good amount of evidence from the last 60 decades of the powerful efficacy of REBT. And also, as I indicated earlier, the huge body of CBT research supports the premises of REBT because CBT is based on those of REBT, but it would be great specifically, and my husband wanted this too, for there to be a long-term study and a short-term and an in-between on the relationship between the musts and the shoulds and the development of generalized anxiety disorder, chronic depression, and the other unhealthy negative emotions. I already mentioned it for future directions. It's already being taught in some schools, like in Australia. My colleague is doing the REBE, education. But for it to happen more, for us to practice what we preach as therapists, not only for the benefit of being healthy models to those around us, but for our own quality of life and to prevent burnout, which is so common in our profession. You know, prevention is the cure. And if we or our patients or our clients or our loved ones don't know we have a choice, don't know there are techniques, don't know there are alternatives to the things that we've habitually been doing that are self-defeating. If we don't know we have a choice, we don't have a choice. So let us, in our position of one-on-one therapy or educating many people, remind one and all and ourselves that we and only we have the power to create our own emotional destinies, and we and only we are responsible for that. Thank you so much. I'd love to hear your questions.
Thank you so much. That was a very passionate and an enriching conversation that you brought up, the discussion that you brought up also. We'll take one or two questions due to time paucity, but we'd like one or two questions if there are any. Please don't hesitate. If anybody has a question, kindly ask.
It could be a shame attacking exercise. If you're afraid, it's an opportunity to do what you're afraid of to prove nothing terrible happens.
Yeah, there is one question. Can I request you to please come so that Debbie ma'am can also see you and she'll be able to see. Please come on stage. No, no, no. She wouldn't be able to see it. Can come on the podium. Hello, Dr. Debbie.
Hey, thank you. Hi.
I mean, at the first, I think in the audience, we were all appreciating the passion and the energy you brought in at the deadly hour you're presenting us from the graveyard or from your uh, country. Very grateful that you've been able to do this for us today. My question is a little out of the entire conversation you had, but linked to it deeply. I'm in the digital mental health space, and there's a lot of conversation around CBT that is being brought in on digital mental health platforms, and AI is using CBT. What is your take on bringing in REBT, given it has wider coverage, it is less rigid as compared to CBT in many ways? And I think there is a huge opportunity for REBT also to be kind of adopted by the tech platforms that are offering mental health services.
Oh, I would love that. What is your name?
Smriti.
Shruti, thank you so much. What do I think about that? I would love it. I desire it. I envision it. I hope to meet some colleagues who can help me with that. True admission, technology is not one of my talents or gifts, but there are a number of reasons. I don't know the situation in India, but here in the USA, the health system is people have to have insurance, and some insurance companies cover mental health, but only some areas of mental health. And CBT is the main one. And why? Because of its excellent body of research. And again, I don't mean to sound like I'm criticizing CBT, as I think by the respectfulness of your question, we can have both and there are distinct things in REBT. But the reason CBT is, in my opinion, wrongly known as the gold standard is because of the research. Now, it can be gold standard, but so can others. So let's not have the gold standard. Let's say there are a number of gold standard, meaning effective, powerful, empowering. And I think people are deprived by not knowing the holism of REBT, those added dimensions. It has all the cognitive elements, changing the thinking, be aware, etc. It has behaviourism and behaviouristic techniques of doing, but that emotive component of we create our emotions, the importance of unconditional acceptance. And so it is my heartfelt wish as time goes on to be part of the times, and that REBT be respected, be known as the roots of CBT, not a branch of CBT, which some young people are taught. I would love that. Shruti, thank you for that question.
Thank you for your response, ma'am.
Thank you. Anyone else?
We'll request Professor Dr. Kalpana Srivastava ma'am to come and give the concluding remarks. Thank you so much, Dr. Devi, for joining at an oddly hour and being with us over here. We appreciate your time here.
My pleasure. Thank you. Thank you. I wish I were with you in person. Dr.
Thank you
Kalpana.
very much, Dr. Yeah, thank you very much, Dr. Devi. Well, firstly, I appreciate that you have navigated the science behind it, the art behind the whole practice of REBT. And also, you have put in a lot of passion and hard work throughout the decades of your professional experience in promoting the REBT across the world, I would say, not the country. So, here, a big round of applause for Dr. Devi, please.
Thank you. Thank you. It's really a pleasure to be with you. Thank you.
I also reiterate what has been commented and also complimented by all the professionals that training and supervision is a very important component of practice, and it should be emphasized by all the young minds, that if you take a path, be a trained practitioner of any discipline you want to really practice, process, and progress. Thank you once again for being here with us. Thank you.
Thank you. Thank you.
Thank you so much, ma'am. Ma'am, I'll request you to be around. We'll felicitate you for the chair. Can I request later? Okay. Due to, again, we are managing our time in some different forms. Here comes now the next plenary session, which is Romantic Love, Normal and Pathological Forms by Professor Dr. Salman Akhtar, sir. I am hoping that the chairperson, Dr. Vinay Kumar, sir, has joined online. If sir's there, please project, sir, IT department. Wonderful. Great. So we have with us Dr. Vinay Kumar, sir, from Patna, and just give me one. To introduce our panel speaker session, Dr. Salman Akhtar is a distinguished Indian American psychoanalyst, poet, recognized internationally for his contribution to psychiatry, psychoanalytical practice, medical education, has been from Aligarh Muslim University, then psychiatry, MD from PGIMR, Chandigarh, and then training at US with University of Virginia and later at Philadelphia. Sir has been professor of psychiatry and human behavior at Jefferson Medical College, Philadelphia. Training and supervising analyst, has authored and edited over 300 books, scientific publications. His influence extends globally. He is also celebrated for his poetry. Dr. Akhtar's legacy continues as an inspiring thinker, clinician, author who bridges psychiatry, psychoanalysis, literature, and cultural studies. We're going to be playing Sir's session, and I take the opportunity to also introduce this opportunity to introduce Dr. Vinay Kumar. So, Dr. Vinay Kumar, sir, is highly respected senior psychiatrist in India, known for his decade-long contribution to clinical psychiatry, teaching, research, professional leadership. He has served as president of Indian Psychiatric Society and held several prominent roles at different national and international associations, including secretary of Society section of World Association of Social Psychiatry. Sir has been an honorary member at various organizations, and there have been numerous publications, and Sir is known for his advocacy work and psychosocial care, specifically championing the cause of mental health promotion, caregiving support, and psychosocial rehabilitation. Sir is also a guiding academician and clinically has guided academics and clinical policies at various psychiatric societies. We welcome you, sir.
Thank you very much. I can't see Professor Akhtar online.
So, Professor Akhtar's session is going to be online. That is.
Okay, it's recorded.
Yes.
Oh. That was the reason I was a bit surprised because it's late night in US and he's not visible. So I thought that he's somewhere else. Well, anyway.
So, with
very good morning.
With your permission, can I start this?
Yes, please.
And we would like your remarks.
I'll say a few lines, then I'll request you to start the talk.
Sure, sir.
Very rightly said by, I think Rashmi ji, na? Rashmi, Dr. Rashmi.
Sonia, sir.
Hello?
Sir, Sonia this side, Dr. Sonia.
Sonia, okay. So Dr. Sonia, thank you very much for introducing me and Professor Akhtar. Professor Akhtar is truly Renaissance man, unique personality, perfect blend of science, art, poetry, cinema, music, understanding of music, I would like to say. He's a perfect man in that way. And I am honored by leading publisher of Hindi. And title of the book is Ek Baat Kehni Hai. I'd like to add one sentence about Professor Goravat's couplet. He writes that दर्द और लताफत का इम्तिजाज था उनमें, दर्द और लताफत का इम्तिजाज था उनमें, चार अगर नहीं बनते तो बताओ क्या बन. He defines a therapist as a person, charagar. What kind of person a charagar, a therapist is? The person who has perfect mixture of pain and pleasure, dard and latafat. The person should be able to empathize deeply and pleasing temperament, attitude also. So let's explain something about Professor Akhtas, and is going to talk on romantic. Be all ears. I request Sonia ji to start the video.
Sorry, sir. Just we were trying to kind of put your slide.
Okay. We keep doing. Meanwhile, romantic love is from the day this world began, human beings came in existence, emotions started playing role, and today in this century, things are much different. Romantic love, which used to be called by poet like Mirza Ghalib in a way that दायम पड़ा हुआ तेरे दर पे नहीं हूं मैं, खाक ऐसे जिंदगी की पत्थर नहीं हूं मैं. The kind of dedication, the kind of devotion in which poet says that my life is not good because I'm not a piece of stone. I'm not lying at your doorstep like a stone. For always, dayam pada hua tere dar pe nahi hu main. Another way, Ghalib used to say that ishq pe zor nahi hai. Ye wo aatish hai Ghalib. You can't control this. This is a fire. Romantic love has many dimensions. Romantic love has many dimensions. So, if you talk about romantic love, you must keep in mind the Freudian concept that it's a combination of concern and lust. In friendship, what happens? There is only concern. In only lust. Okay, you are ready? Yes. And in love, there is a perfect combination of concern, lust, and that makes the picture at psychoanalytic level. With these few words, I hand over to Dr. Sonia.
Sure, sir. Thank you so much for those introductory words. And now we are going to be playing this session, and we'll request your concluding remarks at the end, sir. Thank you.
Thank you. I will be very much here.
I think. Hello.
welcome to this conversation. I call it a conversation rather than a lecture because if I were there in person, minded if you people in the audience had interrupted and raised your hand and asked a question. But raise your mental hand, ask your questions in your mind, and one can always find a way to have some conversation. There is a possibility that I might be teaching more at your place, so we will perhaps meet. Otherwise, there's email and other methods to raise questions. What I'm going to talk to you about today is something that everybody is interested in. Everybody seems to have some idea about, and is a central element of life's experience, and if one can even call it among important emotional needs of human beings, and that is romantic love. Now, the word love, in Western societies is used in a relatively restricted way. In our country, India, from where I am also, the word love is used, प्यार, मोहब्बत, ये जो लफ्ज हैं इसके बहुत ब्रॉड मीनिंग्स भी हैं. बच्चे को माँ से प्यार है, दोस्त को दोस्त से प्यार है, हमें अपने नेबरहुड से प्यार है, मुल्क से प्यार है. सो प्यार लफ्ज जो है वो थोड़ा जेनरिक है. मोहब्बत इज कमिंग क्लोज, लेकिन मोहब्बत भी जो है थोड़ा एम्बिगुअस है, क्योंकि मोहब्बत माँ बाप को अपने बच्चों से हो सकती है, बच्चों को अपने माँ बाप से हो सकती है. उसके बाद जो है प्रेम भी इतना सरकमसाइज नहीं है. फारसी उर्दू का लफ्ज है इश्क, वो क्लियर कट है. तो इसमें हिंदी में प्रेम चलेगा, या ये कि जो लोग ज्यादा अच्छी हिंदी जानते हैं, the people who know better Hindi than me, जैसे my good friend Dr. Vinay Kumar, who's a psychiatrist and a poet, he would immediately know what word should be there. But most of you are also bilingual, English speaking, so let us just call it love and specify that we are talking of romantic love. Now, a good place to begin, in my way of thinking, is always to define something. Many of you will become psychotherapists. A large number of psychotherapies fail because it has not been clearly enunciated as to what are we here for. What are we treating, and how are we going to treat, and how would we know that things are working? These kind of clarifications, I think, are essential in the beginning of psychotherapy. Same thing applies to any talk. When we're talking about a concept, we must begin by defining that concept clearly. Now, as the talk and the subtitle of the talk says, that I'm talking about normal and pathological forms of love. So let us begin with normal romantic love. Now, Sigmund Freud, while he was at times idiosyncratic, while at times he was wrong, even sometimes silly, I think, and considerably Eurocentric, phallocentric, and not so good in observations about child development, and often wrong, and sometimes disastrously wrong about the psychology of women. But that does not mean that he was not smart. And that does not mean that he didn't say and write papers which are A class. So, as far as romantic love is concerned, I think the best definition given ever, is that of Freud in a paper in 1910. What does he say? He says that when we have concern for somebody, कहाँ है, ठीक ठाक है नहीं है, कैसे चल रहे हैं, ठीक तो हो. When we have concern for somebody, when we have respect for somebody's feelings, when we can maintain an optimal distance from them, not too far, not too remote, not too private, and also not too close, not too intimate and too intrusive. So when we have respect, when we have concern, when we have optimal distance, and when we have an ongoing sense of tenderness and affection. By tenderness, we mean capacity to enjoy and facilitate somebody else's goals, somebody else's happiness, and let them have that happiness and not grab that happiness and announce that it's I caused it. Just let it go. Make somebody happy and quietly. And in that renunciation, there is joy, there's also a little pain. ठीक है, उसका मेरा शेर भी है कि खुशी में गम के कुछ इम्कान भी हैं, खुशी में गम के कुछ इम्कान भी हैं, मोहब्बत करने के नुकसान भी। सो थोड़ा दर्द तो होता है मोहब्बत में, बगैर दर्द के तो मोहब्बत नहीं होती। अच्छा, तो ये पैकेज अगर है पूरा, क्या? कंसर्न, ऑप्टिमल डिस्टेंस, रेस्पेक्ट एंड टेंडरनेस। अगर ये चीज है तो फ्रॉइड कहता है कि देन वी मीट द कंडीशन ऑफ फ्रेंडशिप। ये तो दोस्ती की बातें हैं। Then he says, on the other hand, if we have a desire for somebody's body and to merge our body with their body and to merge the concavities and convexities of our bodies, to shed bodily shame and to help them shed bodily shame and to become bodily one with them and to enjoy their body, looking at their bodies, smelling their bodies, licking their bodies, kissing their bodies. When we have such powerful desire for somebody's body, then we have the condition of lust. And then Freud makes a very powerful statement. It is when friendship and lust can coexist. That's when we have the condition of love. In friendship, there's concern, affection, optimal distance, and tenderness, but no lust. In lust, there is the desire for somebody's body, to become one with somebody's body, to co-opt somebody's body, to penetrate and be penetrated, to shed clothes, to be naked, to see, to smell, to lick, to bite. That, but there's no affection, no tenderness, no respect, no concern. That is lust. When we have lust and friendship together, that is called love. That is called. अजीज कैसी शायर थे बंबई में, उनका शेर है कि अब तो फकत बदन की मुरव्वत है दरमियां, अब तो फकत बदन की मुरव्वत है दरमियां, था रब्ते जानो दिल तो शुरुआत ही था. So शुरुआत was better, but the poet is mistaken. शुरुआत में सिर्फ रब्ते जानो दिल नहीं चाहिए था, रब्त मीन्स रिलेशनशिप, लेकिन उस वक्त बदन की भी ख्वाहिश चाहिए थी. दोनों चीज होनी चाहिए, ए एंड बी. एक माइनर फुटनोट, what I'm talking about here is not necessarily restricted to heterosexual love. It also applies to homosexual love. अच्छा, तो दो चीजें चाहिए according to Freud's definition for normal love. A, friendship, and B, lust. ये दोनों चीज चाहिए. अब इसमें चार साइकोएनालिस्ट ने, बहुत लोगों ने लिखा है, बहुत लोगों ने लिखा है, एंड जाहिर है कि people who have written are outside psychoanalysis also, philosophers, poets, novelists, anthropologists, sociologists, general academic psychologists, and of course, but I'm more familiar with the literature of psychoanalysis and Urdu poetry, so those will be my main sources that I'll quote. Within psychoanalysis, 4 other analysts have made important contributions to the definition of normal love. The second is Mrs. Klein, or Melanie Klein, who directly and indirectly highlights the fact that in order to really love somebody, it cannot be only love. Some element of frustration, aggression, even hate, dislike and even hate has to be assimilated with the love. Pure love, 100%, is dangerous. Is dangerous. क्योंकि प्योर लव का मतलब क्या है 100% का कि वो हेट्रेड कहाँ गई हम तो इंसान है ना हमारे अंदर हेट्रेड भी है वो निकाल दी और प्योर लव कर दिया तो कल को वो एक्सप्लोड करेगी Besides psychoanalyst Freud, there are other analysts who have made some important contributions. 4, in my mind, stand out as far as the definition of normal love is concerned. With Freud, keep in mind the merger of friendship and lust in Freud. With Mrs. Klein, Melanie Klein, the importance of assimilating, integrating a certain amount of aggression in love, so that the love does not remain 100% pure. 100% pure love looks good and feels good, but it is not good. It blows up. Because we are human beings, we have in our hearts love and aggression both, and if we put the aggression aside altogether, it's going to blow up one day. So it's better that the aggression be assimilated within love. This is a very, very good idea. So some slight disappointment, some slight frustration, some slight annoyance, some slight dislike, I think is a healthy thing within love. 2, Ms. Freud, Klein. Then the third person who's very important in this, less well known in eastern part of the world, was a psychoanalyst by the name of Martin Bergman. Martin Bergman says a very interesting thing, that in love, one should be able to find old objects. Now, object is a bad word in psychoanalysis. It only means what is not self. So, mother is an object, father is an object, brother is an object, etc. Object, ये इन्होंने depersonify कर दिया, बात है human being की. So, one should be able to find old objects. But not exactly. Not exactly. Resembling old objects, कि आपके महबूब में कुछ आपकी माँ हो, कुछ आपके बाप हो, कुछ आपके पड़ोसन हो या पड़ोसी हो बचपन में, कुछ बचपन का कोई गहरा दोस्त हो, कुछ कॉलेज की टीचर हो. अब हमारी थी जैसे हम किंडरगार्टन में मिसेस जॉर्डन ना हो तो कुछ क्या मजा आएगा किसी महबूबा में. मिसेस जॉर्डन की झलक दिखनी चाहिए, पड़ोसन थी उसकी झलक दिखनी चाहिए, माँ की बात. So what he says is, 1, that there should be the presence of old object. Resemblance with mother, father, and other loved people of childhood should be there, but not exactly and not too much. There should be some newness also. Oldness and newness in the person. That's one thing which is very interesting and important. Second, he says, the more people we can find, अगर आपके हस्बैंड या आपके जो बॉयफ्रेंड है उनमें सिर्फ आपका भाई है या सिर्फ आपके फादर है तो ये मुश्किल हो जाएगी, क्योंकि फिर वो माँ को कहाँ ढूंढेंगी आप और बहन को कहाँ ढूंढेंगी. वो भी उनके अंदर होने चाहिए. जितने ज्यादा लव ऑब्जेक्ट एक आदमी के अंदर हो वो बेटर है. तो ये बात जो है मार्टिन बर्गमन साहब ने कही, और ये भी कहा कि ज्यादा मैसोकिस्टिक नहीं होना चाहिए, कि अब आप जो है इतनी मुसीबत ना मोल लें मोहब्बत में, ज्यादा मुसीबत ना मोल. तो ये 2 बातें और उसके बाद आखिरी बात जो है, एक फ्रांस में साइकोएनालिस्ट है, इनका नाम प्रोनाउंस करना थोड़ा मुश्किल है, इनका नाम है जनीन शाशिगे इस्मेरजेल। इन्होंने एक बड़ी अच्छी बात कही। इन्होंने कहा कि वैल्यू सिस्टम क्या चीज अच्छी है, क्या चीज बुरी है, क्या करना चाहिए, क्या नहीं करना चाहिए, कहाँ जिंदगी जानी चाहिए, कहाँ जिंदगी नहीं जाना चाहिए, कौन अच्छे लोग हैं, कौन बुरे लोग हैं, ये अगर एक हो तो बहुत अच्छा लव होता है। तो अब इन पांचों चीजों को मिला लें कि एक डेफिनेशन बनाना चाहें, वी ट्राई टू कंबाइन these elements, we will come back with the following characteristics of normal, and by normal here we mean desirable, mature, healthy love, romantic love. One, that there should be concern, affection, respect, optimal distance, but also there should be sexual desire. There should be erotic excitement. There should be love, but it should be able to assimilate some disagreement, some dislike, some frustration. That one should find shadows and echoes of old relationships, but with newness, with some new change in them. And one should be able to find many shadows, not only one, many replicas, not only one. That it should not be too difficult to begin with the relationship. And finally, the value system should be the same. This is the baseline of a good and solid and healthy love relationship. Now, being a doctor, I'm a MD, psychiatrist, psychoanalyst, we know. And you don't have to be a doctor. We know in real life, nothing fits everything. So that of these 6 or 7 criteria, affection, sexual desire, old objects improved, many objects, same value system, assimilation of some aggression. Out of all these 6 things, if 4 or 5 are present most of the times, I think that's pretty good. Also, please remember, being in love, especially, I'll go into difference between falling in love and remaining in love in a minute. Being in love does not mean 24/7. There are times that we don't even think about the person that we are in love with. We have other things to do. जिंदगी सिर्फ मोहब्बत तो नहीं है अंजुम। ये मेरे फादर का 1900 मेरे ख्याल से 30 का लिखा हुआ लाइन है, 30 या 32 की लिखी हुई लाइन। मेरे ख्याल 17-18 साल के थे तब। फैज अहमद फैज ने क्या कहा है, अब भी दिलकश है तेरा हुस्न मगर क्या कीजिए, और भी गम है जमाने में मोहब्बत के सिवा। सो बीइंग इन लव डज नॉट मीन कि कोई आदमी 24 घंटे 7 दिन मोहब्बत में, वो तो दैट पर्सन नीड्स मेडिकेशन, उसको तो कोई काम ही नहीं है, और दुनिया में और काम है भाई। तो अब क्या है, अक्सर वो मोहब्बत जो है कॉन्शियस से प्री कॉन्शियस में चली जाती है। जैसे हमारे बच्चों के नाम, जैसे हमारा पोस्टल एड्रेस, जैसे हमारा फोन नंबर, जैसे हमारे गाड़ी का रंग, ये सब बातें हम हर वक्त तो नहीं सोच रहे हैं, लेकिन हम सोच सकते हैं। उसी तरह से कॉन्शियस से प्री कॉन्शियस में लव जो है, ऑन गोइंग लव इज मोस्टली इन द प्री कॉन्शियस। एक बात। दूसरी बात कि ये होना चाहिए कैपेसिटी कि जो बढ़िया था, जो सबसे अच्छा लव था, वो बार बार ढूंढ सके आदमी अपने दिल के अंदर। तो अब देखिए, पहले तो मैंने आपको आई टोल्ड यू 6 or 7 कंपोनेंट्स, then I tempered it by 3 things. One, all 7 are not present all the time. Most of them should be present most of the times. 2, they are not present in the conscious mind all the time. They are present in the pre-conscious. just like your postal address, just like your son's name, just like your mother's name. They're not present in your conscious, they're present in your pre-conscious. That means they can be readily brought to mind. And three, that the best love that you experience with this person, that should be recoverable from time to time. वो कमरा कभी उस पे पूरा ताला नहीं पड़ना चाहिए उस कमरे पे, उस कमरे में भी मुलाकात होनी चाहिए बार बार. ये कमाल है. अगर ये बातें हैं, so that is normal, healthy, good love. Now let us go to the pathology. There are 5 kinds of pathological syndromes of love. I don't know how many in the audience, how many syndromes exist in this audience, but I'm sure that 1 or 2 or 3 may exist. We'll see. और जिसके दिल में है उसको तो पता है कि मैं किसकी बात कर रहा हूं. अब इसमें 5 pathologies हैं. So let's begin with the most severe pathology, which is really, really very, very problematic. And that is number 1 pathology is complete and total inability to fall in love. Complete and total inability to fall in love. There are people who say that they have not been in love. Many of them are, just saying it. Many of them want to hide the frustrations of love they had. Many of them will fall in love. Many of them have fallen in love but not recognized. But all that skepticism aside, there are some people who do not ever fall in love. That is a very painful and sad condition. उर्दू के शायर हैं क्या अच्छे, मजे के शायर थे. और हमारी उर्दू में एक अजीब चीज है, when we call somebody मजे का शायर, तो that's not a compliment by the way. इसका मतलब है कि इससे इंटरटेनमेंट हो जाता है लेकिन गहरे नहीं है. नहीं, खैर वो अच्छे भी थे. चलिए, अब मैं बुराई नहीं करना चाहता बेचारे की. बशीर बद्र मजे के भी थे और अच्छे भी थे. तो मजे के शायर तो जरूर थे. क्या अच्छा शेर है कि उसे किसी की मोहब्बत का एतबार नहीं, उसे किसी की मोहब्बत का एतबार नहीं, उसे जमाने ने शायद बहुत सताया. उसे किसी की मोहब्बत का एतबार नहीं, उसे जमाने ने शायद बहुत सताया. What happens is that when we are babies, when we are little infants, consider our body as a remote village in which the government is trying to put electricity and plumbing. When our mother holds us, pulls our cheeks, plays with our nose, kisses us, pulls our hands, plays with our fingers, as the mother touches our body when we are babies, it's like a government going in a remote village and putting electric poles. लाइट जलती है, उसी तरह से बॉडी अवेक होती है, उसी तरह से दिल अवेक होता है. Oh, I know somebody is happy. Oh, somebody is smiling. The mother goes in the child and flags, identifies emotions and puts little flags on. So 2 years later, the child says, I'm happy. Wow, how does he know he's happy? Because he was told when he looked happy by the mother. This labeling of the internal affects and drives and this libidinal ministration and awakening of the sensual potential of the body lays the groundwork first to feel love. Sexuality has not entered in the mind yet, but sensuality has. The feeling of one's hands, the feelings of one's face, the feeling of one's shoulders, bodies, legs, that has already entered. The body has been awakened. The village now has electricity. वो foundation is necessary. उसके बाद trust is necessary, which will be established by regular, predictable cycles of care. The child will have a need, the parents will meet the need, and child will enter quiescence. Then the child will have another need, the child will make appeal, the appeal will be granted and satisfied, and child will enter quiescence. This thing is called the appeal cycle. If the appeal cycle is gratified, say 70-80% of the times, if the body and mind is awakened and properly attended and labeled empathically, if the appeal cycle is gratified, and ordinary provisions of respect and empathy are there, the capacity to idealize will begin. The child will say, my mother is the best, my father is the best, I am. And parents will tell the child, you are the best. When we raise children, we need to do two things. First, tell them you are the best. Then after 2 years, I start telling them, don't act as if you are the best. That's दोनों चीज चाहिए, illusion and disillusion. दोनों चीज चाहिए. बगैर illusion के confidence नहीं है, बगैर disillusion के humility नहीं है. दोनों चीज चाहिए ना पढ़े लिखे आदमी में और mature आदमी में. So, all this creates the capacity to feel and to project love and to idealize. Now, we lose idealization of our mothers and fathers. We lose idealization of our teachers. We lose idealizations of our beloved also. But we start with idealization. मोहब्बत बगैर ब्लाइंडनेस के नहीं होती है. मोहब्बत ऐसे होती है ना, ए देखो अरे यार कितनी हसीन औरत, इससे तो दुनिया में अच्छी लड़की है देखी नहीं मैंने कभी. ऐसे करके जब देखते हैं तब लगता है कि बहुत बढ़िया है. उसके बाद हल्के हल्के खुलता है हाथ तो पता चलती हैं कहानियां. बट दिस फेज इज एसेंशियल. दिस आइडियलाइजेशन इज एसेंशियल फॉर फॉलिंग इन लव. इट ब्रिंग्स पीपल टुगेदर. सिंपल बात है, रेस्टोरेंट में जाइए, आपको फौरन पता चल जाएगा विच आर द पीपल हु आर फॉलिंग इन लव, which are the people remaining in love, and which are the people who have fallen out of love. Most of them are married, but that's a joke aside. Falling in love जो होंगे, रेस्टोरेंट में देखिए कपल बैठे हुए हैं, तो falling in love का immediate पता चलेगा आपको. Both of them are looking in each other's eyes. And बातें कर रहे हैं, आधा घंटा हो गया, आंखें ऐसे locked. That is the infant mother gaze. That's the bonding that's being made. Remaining in love कैसे पता चलेगा? दोनों लव में हैं कि दोनों एक ही चीज को देख रहे हैं. वो चार आंखें जो हैं वो पंखे पे हैं, या वो चार आंखें उधर के पेंटिंग पे हैं. चारों आंखें उधर ही. और शादीशुदा कैसे पता चलेंगे? मियाँ देख रहे हैं सेलफोन, बीवी देख रही है किसी की साड़ी, या मियाँ देख रहे हैं मोस्ट लाइकली किसी की साड़ी. ये भी हो सकता है. ज्यादा लाइकली मेरे ख्याल से सेकंड फिनोमेना है. अच्छा, so in order to fall in love, we need idealization. We need a near worshipping idealization, the beginning of love. उसके लिए चाइल्डहुड में का प्रेपरेशन जरूरी है, जिसमें कि बॉडी की अवेकनिंग हो, माइंड की नॉलेज हो, और ट्रस्ट हो लोगों पे, और तमन्ना हो लोगों से, और भरोसा हो के अच्छे लोग भी हो सकते हैं. मेरा एक शेर है कि कभी कभी मतलब की खातिर जान के धोखा खाना तुम, अच्छे लोग भी हैं दुनिया में लेकिन भूल ना जाना तुम. अच्छे लोग भी. सो दैट इज द इम्पोर्टेंट पार्ट. वो अच्छे लोग दुनिया में हैं जो मैंने लिखा है, उसके लिए पहले अच्छे लोग बचपन में होने चाहिए, तभी तो ये भरोसा होगा. सो द मोस्ट ट्रेजिक कंडीशन, अगर आपको डायग्नोसिस का शौक है, सो आई थिंक इन एंटी सोशल पर्सनैलिटी, I think in severe narcissistic personality, I think in some schizotypal personalities, I think in paranoid personalities, this capacity is damaged. The And we have the first syndrome, the syndrome of inability to fall in love. इसका ट्रीटमेंट डिफिकल्ट है. जैसे सेक्स में भी, अगर सिर्फ सेक्स में जाइए, आई एम नॉट टॉकिंग अबाउट सेक्स, बट अगर सेक्स में जाइए तो वहां भी 4 चीजें हैं. क्या? डिजायर, फ्रीक्वेंसी, परफॉर्मेंस एंड ऑर्गेज्म. इसमें सबसे ज्यादा डिफिकल्ट ट्रीटमेंट जो है वो डिजायर का है. जब डिजायर ना हो सेक्स की, दैट्स अ डिफिकल्ट थिंग टू ट्रीट. फ्रीक्वेंसी, performance and orgasm are easier to treat. Same thing in love. This is a difficult condition to treat. This will require long-term, deep psychotherapy in which early frustrations, early trauma, early withdrawals will have to be unfolded and discussed, and that wound will have to be debrided and cleaned up and healed. So, syndrome number 1, inability to fall in love. Syndrome number 2, inability to remain in love. बहुत से लोग they can fall in love, लेकिन वो लव जो है उनसे निकल जाता, हाथ से, दिल से उतर जाता है. क्या निदा फाजली का शेर है, नियते शौक भर न जाए कहीं, नियते शौक भर न जाए कहीं, तू भी दिल से उतर न जाए कहीं. तो ये डर है, लेकिन डर के पीछे तो उनको पता है, नॉलेज अपनी नॉलेज पता है. और कुछ शायर तो फिर उसी डिफेक्ट को भी खूबी बना सकते हैं. शायरों का तो खेल है कि ये हमसे न होगा कि फकत एक को चाहें, ये हमसे न होगा कि फकत एक को चाहें, ऐ इश्क हमारी न तेरे साथ निभेगी. तो यहां पे अपनी वीकनेस को वर्च्यू बना दिया. ये तो शायरों के खेल है. ये शायर, देखिए 3 ग्रेड है शायर, उसके बाद मैजिशियन, उसके बाद गुरु. तो इसमें अगर चॉइस है तो मैं आपसे कहूंगा शायरी के साथ रहिए, ये मैजिशियन और गुरुओं से बचिए. खैर, तो ये हुआ चक्कर. ये हमसे ना होगा कि फकत एक को चाहे, ऐ इश्क हमारी ना तेरे साथ निभेगी. Why we are psychologists, we are psychotherapists, we have to be curious. Why? ये क्या है कि एक बार इश्क हुआ फिर खत्म, फिर इश्क हुआ फिर खत्म, फिर इश्क हुआ फिर खत्म. क्यों? होते ना सीरियल किलर, ये लोग हैं सीरियल लवर. तो ये क्या चक्कर है? इसके बहुत से कारण हैं, इसका एक कारण नहीं है. इसके डिफरेंट कारण डिफरेंट साइको एनालिसिस से मिलते हैं. एक, अगर फ्रॉइड को पढ़े आप, उनमें गलतियां थी, मैं नहीं कह रहा हूं, फ्रॉइड को कोई गुरु बनाने की जरूरत नहीं है, लेकिन बढ़िया बातें भी हैं. तो क्या होता है कि जब रिश्ता गहरा होता जाता है, जितना गहरा होता जाता है, the deeper the relationship happens, the more of our internal objects are put in the others. अब मेरी प्रेमिका हो, आपके प्रेमी हो, तो अभी नए नए मिले हैं, फ्रेश, तो वो आदमी अलग है आपसे, वो औरत आपसे अलग है, आप दोनों अलग अलग. हल्के हल्के उसके अंदर आपको अपना बाप देखने लगता है, आपको अपनी माँ देखने लगती है, बहन देखने लगती है, भाई देखने लगता है, चाचा देखने लगते हैं, स्कूल टीचर देखने लगते हैं. इसी तरह से इनको भी, इनका जो इंटरनल फर्नीचर है वो भी आपके लिविंग रूम में दाखिल, दिल के लिविंग रूम में रखा जा चुका है. तो हल्के हल्के रिश्तेदार हो जाते हैं, चाहे शादी हुई हो ना हुई हो. हमें शादी में तो रिश्तेदार हैं, आपके मियाँ आपके रिश्तेदार नहीं है क्या? आपके रिश्तेदार हैं, इज योर रिलेटिव. तो जब रिलेटिव हो जाता है, और खास तौर पे अगर बच्चे हों, तब तो और ही ज्यादा है. सो इसमें क्या है कि इंसेस्टुअस एंजाइटीज पैदा हो जाती है, कि क्लोजनेस में शैडो पड़ती है बचपन के ऑब्जेक्ट्स की. पढ़नी चाहिए, अच्छी चीज है. इसीलिए एक बात जो पहले नहीं कही थी वो अब कह देता हूं. पहली मोहब्बत जो होती है, पहली आप भी सोच लीजिए अपनी, मैं भी सोच रहा हूं इस वजह बोल रहा हूं. तो पहली मोहब्बत जो होती है ना, उससे स्वीट नहीं है कोई, लेकिन वो हमेशा टूटती है. वो टूटती है क्योंकि उसके अंदर बहुत शैडो है माँ बाप की, बहुत ज्यादा. खैर, तो अगर इंसेस्टुअस एंजाइटी पैदा हो जाए रिलेशनशिप में, तो वो रिलेशनशिप टूटेगी. एक ये वजह है, लेकिन ये वजह वीक है और छोटी है. ये बड़ी वजह नहीं है बार बार मोहब्बत करने की, ये बड़ी वजह नहीं है। बड़ी वजह है जो अब मैं बताता हूं आपको। ये तो फ्रॉइड साहब के काम से निकाली, बड़ी वजह ये नहीं है। दिस इज रेयर। बिगर problems are caused by the following. One, by what Mrs. Klein said, Melanie Klein, that if you have idealized a person and if you have ignored noticing their weaknesses and your feelings about their weaknesses तो सब में होंगी, आप में भी हैं, but if you have tried to sequester, split off, compartmentalize, push aside your own feelings of critical nature, they will accumulate. And one day, an explosion will happen. The too much idealization and too much sequestering of aggression can lead to an explosion of aggression. And even if not an explosion, just a mere accruing of an accumulation of dislike, bit by bit by bit. जिस जगह कदम रखिए कोई संगे मील है, राई के पहाड़ पर पत्थरों की आंसुओं की झील है। That's what happens. राई के पहाड़ पर आंसुओं की झील। ये नैनीताल को याद करके लिखा था, उसकी भी कुछ कहानियां हैं, खैर वो जाने दीजिए। तो अब ये है कि the accumulation of aggression can mess up the relationship. So it is better to voice the aggression and the dislike and disagreements politely and nicely. That's the second reason. The third reason is that sometimes when we are falling in love, we oversell ourselves. We pretend to be so well-mannered. A man will go around the car and open the door. शुरू में अब कितने दिन करेगा कमबख्त, एक ना एक दिन तो थक जाएगा। अब उसे चिढ़ाने लगेगी, या तो चिढ़ाने लगेगी मैं क्यों करूं ये, तो तूने तो शुरू किया था हरामजादे। एक तो ये, दूसरी बात क्या है कि उसको डर लगेगा कि इसको पता चल जाएगा मैं इतना वेल मैनर्ड नहीं हूं। If a person sells a fake bill of goods of extraordinary nice manners, to open the door, to open the car door, to never eat with hand, ये बहुत कुत्ती चीज है, इसको समझिए आप। To never eat rice with hand in front of one's boyfriend or girlfriend, that's a dangerous sign. That's going to lead to problems. ये तो होना चाहिए, ये जो है ना मोहब्बत में, इट्स ऑल थोड़ी गड़बड़ भी होनी चाहिए। मेरा क्या शेर है कि थोड़ी दुश्वारी से, दुश्वारी मीनिंग डिफिकल्टी, थोड़ी दुश्वारी से नुकसान नहीं होता है, थोड़ी दुश्वारी से नुकसान नहीं होता है। प्यार सच्चा हो तो आसान नहीं होता है, प्यार सच्चा हो तो आसान नहीं होता है। तो ये सब तो करना पड़ेगा टेस्ट, मोहब्बत को, अपने आप को, दूसरे को टेस्ट करने के लिए। सो द सेकंड थिंग इज दैट वन हैज सोल्ड ए फेक बिल ऑफ गुड्स and therefore one is getting tired of the relationship and one then creates something that the other will reject one. That's another thing. Yet another thing is that if the identity is weak, then closeness makes one feel that one will be eaten up, one will be cannibalized, one will become nobody and nothing, one will become a puppy, or one will sell one's soul and lose one's identity. So this dread of cannibalism appears both as a projection of one's own hunger as well as a statement about weak boundary walls of the self. ये वजह से the person goes in love and comes out of love, goes in love, comes out of love. Why? One, because some incestuous anxiety gets activated. Two, because the narcissistic idealization of the object falls apart and one cannot tolerate their weaknesses. Three, that one has observed weaknesses but kept one's feelings compartmentalized, and they accrue and create too much aggression. 4, that that one has oversold one's own goodness, and one begins to be fatigued and irritated. And 5, one is afraid of being cannibalized and merged. These are the various reasons why people go in love, come out of love, go in love, come out of love. है खूब से तलाश कि है खूब तर कहाँ, अब देखिए ठहरती है जाकर नजर कहाँ. Same thing. A constant pursuit of an idealized object. I have bad news for you, young people. There is no Mr. Right and there's no Miss Right. There's no such thing. There's Mr. Right enough and Miss Right enough. That's how life is. There's no such thing as pure anything. Everything is amalgam. Everything is mixed up. Everything. What we call Indian food. First of all, I hate this phrase Indian food. It's a foreign word. It's not my word. I don't use it. But what we eat, tomatoes didn't exist in India. They were brought from outside. Potatoes did not exist in India. They were brought from outside. Everything is hybrid. Everything is hybrid. Purity is an illusion. Is an illusion created by religion, by gurus, by Bollywood, by children's fantasies and science fiction. There's no such thing as purity. Life is hybrid and mixed up and impure, and so is love. Love is not so beautiful. Love is just like water. We need it, we want it, we enjoy it. But it's not so glorious thing. It sustains us. It's the glue of ourself and of life. But it's not dramatic. 2, inability to fall in love, inability to remain in love. 3rd, falling in love with wrong kinds of people. Now, the word wrong is not a very good word in this context because wrong kind of conveys a moral value. So let's say falling in love with unsuitable people, falling in love with people with whom a relationship will sooner or later cause interpersonal and intrapsychic problems. What does that mean? But what group are we talking about? I think we are talking about 3 kinds of wrong people, or 3 kinds of people with whom developing a love relationship would lead to difficulty. One is morally prohibited people. Now, every religion of the world, Judaism, Christianity, Islam, Hinduism, Sikhism, Buddhism, any religion of the world, has some limits and some prohibitions, especially about sexual consummation. They may differ. Some may say this is okay, some may say that is okay. Some may say this is wrong, some may say that is wrong. But there's always some prohibition. When we go across those prohibitions, then there'll be a problem. Which means falling in love. In Bible, there's a list of 22 people. 22 is true that one should never have sex with. वो 22 हैं, मैं उसमें और ऐड कर सकता हूँ. What are the 22 people? Mother, father, brother, sister, grandfather, grandmother, uncle, aunt. So like that. अच्छा चलो वो तो हो गए. लेकिन उसके dilute versions भी तो हैं, displaced versions भी हैं. students, teachers, patients, doctors. When a relationship is directly or more commonly indirectly, explicitly or more commonly implicitly and subtly incestuous, like between a professor and a student. There's a professor and she falls in love with she's 50 years old, she falls in love with a 22-year-old, first year uh, mm, master student. That is what I'm talking about. Now, please understand, it is not that such things will not happen in our heart. They will. Of course they will. We are human beings. We start our life with unrequited love. We want to marry mommy and daddy. That's unrequited love anyway. Unrequited love is a part of human existence. So it is not, I'm not saying that it will not happen to us. It will happen to all of us. We fall in love with people. But we have to have a corrective part of our mind कि बेटा ऐसा काम मत करो. So first group of people is prohibited people. Whether they are morally prohibited or religiously prohibited or culturally prohibited or legally prohibited. किसी की शादी हुई है, आपको उनसे इश्क हो गया. कोई आपके टीचर हैं, आपको उनसे इश्क हो गया. कोई आपके डॉक्टर हैं, उनसे इश्क हो गया आपको. कोई आपके चाचा हैं, उनसे इश्क हो गया. कोई आपकी बेस्ट फ्रेंड के फादर हैं या बेस्ट फ्रेंड के मदर हैं, उनसे इश्क हो गया. ये सब तो खतरनाक काम है. This is dangerous stuff. So one group is this morally, legally, religiously, culturally, ethically, ethnically prohibited people. One. Second is people who are too far in age, where the age difference is too great. Because not only the age difference is likely to create an incestuous relationship in the background of the mind, but also because the developmental tasks, the psychosocial tasks that a human being is involved in are very, very different. What a 50-year-old person is doing and what a 22-year-old person is doing and needs to do. जो उनका धर्म है और जो इनका धर्म है वो बिल्कुल अलग है. जब धर्म अलग होंगे तो रास्ता अलग हो जाएगा. That is the thing. तो पहली कंडीशन बताती है कि कोई भी आदमी जिससे आप मोहब्बत करते हैं, और मोहब्बत, रिमेंबर, अफेक्शन एंड लस्ट, दोनों चीज चाहिए, तो वो आप कॉन्ज्यूमेट करना चाहते हैं, तो वो आदमी आपके मन में कहीं भी, मन की गहराइयों में भी कहीं मां नहीं होनी चाहिए, बाप नहीं होना चाहिए, बेटा नहीं होनी चाहिए, बेटी नहीं होनी चाहिए. एक जनरेशन में होना चाहिए आदमी को, तब ठीक है. जहां दूसरी जनरेशन में गए वहां अनकॉन्शियस गिल्ट होगी और कुछ ना कुछ प्रॉब्लम होंगे. नाउ आई एम थिंकिंग कि ऑडियंस में कुछ लोग सोच रहे हैं कि एल पचीनो नाम के फिल्म एक्टर हैं, 83 के, उन्हें 29 ईयर की लड़की से शादी की हुई है. रॉबर्ट डिनीरो बड़े एक्टर हैं, वो भी 80-82 साल के हैं, उनकी भी एक महबूबा है जिनसे बच्चा भी पैदा किया उन्होंने. तो ये इसका मतलब है वो ठीक है. They are very fine actors, no doubt. They are very great masters of their art and therefore worthy of our respect. But think about it. They have produced a child who will be an orphan, knowingly. They'll be dead before the child becomes 18 years old. Is this a moral thing to do? To knowingly produce an orphan and to bribe him with money, leave him money? See, simply because मशहूर लोग कुछ काम करते हैं, इसका ये थोड़ी मतलब है कि वो काम अच्छा है. बहुत से मशहूर लोग काम करते हैं, तरह तरह के. मैं कुछ एग्जाम्पल देने वाला था, लेकिन मुझे अपना OCI कार्ड जो है सेफ रखना है, तो एग्जाम्पल दूंगा नहीं. अच्छा, बाद में बता दूंगा कल्पना जी को प्राइवेटली. सो नाउ व्हाट हैपेंस इज कि वन प्रोहिबिटेड, सेकंड टू मच एज डिफरेंस. थोड़ा बहुत एज डिफरेंस ठीक है, एज डिफरेंस इतना होना चाहिए कि डेवलपमेंटल टास्क बहुत ज्यादा अपार्ट ना हो जाए, नंबर वन. एंड नंबर टू कि आदमी दूसरी जनरेशन को ना बिलोंग करने लगे कि ये पिताजी माताजी हो गए या बेटा ये बेटी हो गए, तो वो दूसरे जनरेशन को ना बिलोंग करने लगे और बहुत ज्यादा डिफरेंस ना हो डेवलपमेंटल का टास्क में. उतना एज डिफरेंस ठीक. दो, तीसरा कि बहुत ही ज्यादा रियलिटी की डिफिकल्टी हो. अब जैसे आप रहती हैं दिल्ली में, नोएडा में, दिल्ली में, गुड़गांव में. अब आपने इश्क कर लिया किसी आदमी से जो कि रहता है तस्मेनिया में. तस्मेनिया जो है ऑस्ट्रेलिया के पास है. ये तो ना बीबी, आप वो है ना कि फिर बाद में रोएंगी. तो कबीर का दुआ सुनाऊंगा मैं आपको कि कबीरा चढ़ गए पेड़ पे और सोच सोच पछताए, बोया पेड़ बबूल का तो आम कहां से खाए. तो ये तो आप ही ने लगाई नहीं थी अपने दिल में. तस्मेनिया में क्यों ढूंढा आदमी? ज्यादा से ज्यादा चलिए आगरा तक चली जाती, बरेली चली जाती हैं, आगरा चली जाती हैं, कानपुर चली जाती. पता चला आपके आशिक रहते हैं लाइडन में. लाइडन है हॉलैंड में, तो डायरेक्ट फ्लाइट भी नहीं है. अदरवाइज तो आप एम्स्टरडेम है तो दिल्ली से एम्स्टरडेम तो फ्लाइट है, चलो एक फ्लाइट. तो ये तो गुरु आपने अपने पैरों पे कुल्हाड़ी मारी. क्या कहते हैं कि कुल्हाड़ी में लकड़ी का दस्ता ना होता तो लकड़ी के कटने का रास्ता ना होता. दिस इज सेल्फ इंड्यूस प्रॉब्लम. ये सेल्फ क्या चलेगा, कुल्हाड़ी में लकड़ी का दस्ता ना होता तो लकड़ी के कटने का रास्ता ना होता. तो सेम थिंग. अब आपने इश्क कर लिया क्या नाम है अनिदिता जी का. अनिदिता जी ने इश्क कर लिया, पता चला एक आदमी से, वो रहता है पेरू में. और फिर रो रही है बैठी हुई शाम को, हाथ में एक इनके बियर का ग्लास है, आंसू बह रहे हैं मोहम्मद रफी के गाने सुन के. फिर इनसे कहो कि भैया क्यों ढूंढा था ये पेरू में, क्या कर लेती, अपने पंजाब में हजार एक से एक उम्दा गबरू जवान बैठे हुए. नहीं, वहां जाना था पेरू, लैटिन अमेरिका में आपके महबूब रहते हैं. तो भी फिर तो रोना होगा. ये तीन तरह के लोग, टू मच रियलिटी डिफिकल्टी, prohibited morally, religiously, culturally, and too much age difference. ये कलेक्टिव चीज है. रॉन्ग काइंड ऑफ पीपल. ये ज्यादातर आता है आदमी को एडिपल गिल्ट से आता है. चलिए एडिपल जरूरी नहीं है, गिल्ट से आता है कि एक आदमी है, वो एक गाड़ी खरीदने जाता है, उसने 20,000 में खरीदी, आपने वही गाड़ी 40,000 में खरीदी, तो एक्स्ट्रा 20,000 क्यों दिए? मोहब्बत मिल रही थी आपको भटिंडा में, मोहब्बत मिल रही थी आपको अमृतसर में, मोहाली में, गुड़गांव में, फरीदाबाद में, चलिए कानपुर चली जाती, अलीगढ़, इटावा, लेकिन आप गई पेरू, तो ये 20,000 एक्स्ट्रा क्यों दिए? आपकी सहेली जो है, आपकी छोटी बहन, उसको तो आराम से मिल गया सीआर पार्क में. तो ये क्या चक्कर है? ठीक है ना. सो दैट additional suffering that you have caused yourself always is because of some guilt, some sense of unworthiness. Unworthiness that may be primary because your mother hated you, or secondary because you hate yourself because you have guilty bad thoughts. तीन सिंड्रोम हो गए. पहला सिंड्रोम inability to fall in love. दूसरा सिंड्रोम falling in love again and again, inability to remain in love. तीसरा syndrome, falling in love with wrong kinds of people. चौथा syndrome, inability to feel loved. ऐसे भी हैं लोग, आप उन्हें प्यार करिए, आप उन्हें प्यार करिए, उनको महसूस ही नहीं होता. You do all kinds of things for them, they don't feel it. आप उनका फेवरेट खाना पका दीजिए, वो दिल में सोच रहे हैं what does she want? Why is she bribing me? ये नहीं सोच रहे हैं यार ये मुझसे मोहब्बत करती है, नहीं, ये सोच रहे हैं why is she bribing me? Or what is she trying to show off? आप उनके कंधे पे हाथ रखिए, जब वो आपके कंधे पे हाथ रखें, आपसे कहें यू नो डार्लिंग यू आर लुकिंग वेरी ब्यूटीफुल, आप कहें कि ये जो है देख नहीं रहा है कि मेरे तो ऐसे में तो पुट ऑन सो मच वेट. अरे वो तारीफ को लो भैया, तारीफ को लो, खाओ, वो तारीफ की कचौरी है, ईट इट. उस कचौरी पे शक्कर डालने की जरूरत नहीं है. ये अभी बनाया, बहुत ही अच्छा नहीं बना मेटाफोर, बट ठीक है, चल जाएगा. सो द पॉइंट इज कि द इनएबिलिटी टू एक्सेप्ट लव. कुछ लोग मोहब्बत बर्दाश्त नहीं कर सकते. तो एक छोटा सा 3-4 लाइनों का एक पीस पढ़ के सुनाता हूं आपको, जिसमें यह है कि ये लुइस बेगले साहब का नॉवेल है बहुत अच्छा, द मैन हु वाज लेट. तो उसमें देयर इज अ कैरेक्टर हु कैन नॉट बी लव्ड. लिसन टू दिस. Such as Veronique was, she made me happy as no one has except Rachel. Before she began to press me to act like a normal man, she made me a good deal happier. The poor dummy actually loved me. Rachel knew better. Her idea was that for a time I could love her on a sort of live-in basis. Probably that's all I'm good for. Although for a while, with Veronique, I made progress. I was beginning to be able to bear it without wincing when she was nice to me. I was able to bear it without wincing when she was nice to me. कुछ लोग बर्दाश्त नहीं कर सकते हैं मोहब्बत. There are some people, एक होती है कंडीशन जहां पे आपके पास आईना नहीं है, यह गलत आईना है. जैसे मेरा एक शेर है पुराना कि ये कह के मैंने रखा है हर आईने का दिल, ये कह के मैंने रखा है हर आईने का दिल, अगले जन्म में रूप मिलेगा नया मुझे. तो एक हमारे दोस्त थे थोड़े सोशियोपैथिक और हाइपोमेनिक. तो जर्मत में, जो कि स्विट्जरलैंड में पहाड़ों में, स्विस आल्प्स में एक जगह है, वहां पे बैठे हुए बार में एक 18 साल की लड़की से फ्लर्ट कर रहे हैं, वेट्रेस से. उसको ये शेर सुनाया उन्होंने ट्रांसलेट करके. पहले तो किया होगा ट्रांसलेट उर्दू से अंग्रेजी, फिर अंग्रेजी से जर्मन, तो हल्के हल्के उस लड़की तक, कॉकटेल वेट्रेस तक शेर पहुंचा, जिसको मैंने जिंदगी में लड़की को नहीं देखा है. लेकिन आभारी हूं मैं उसका, आभारी हूं, क्योंकि उस लड़की ने मेरे दोस्त को जो जवाब दिया कमाल का था. शेर सुन लीजिए फिर से. ये कह के मैंने रखा है हर आईने का दिल, अगले जन्म में रूप मिलेगा नया मुझे. That 18-year-old cocktail waitress told my friend, go tell your friend he has been standing in front of wrong mirrors. उसके बड़े implication हुए, उसके काफी पैसे लगे उसके बाद. खैर वो कहानी अलग है. तो अब रही बात कि कुछ तो ये ट्रेजेडी होती है कि आईना गड़बड़ है, या आईना जो है क्रैक्ड है, या आईना नहीं है. The problem I'm talking about is not कि आईना नहीं है. The problem is what is called negative otoscopy, and that is जो कि उसको ब्रैम स्टोकर की नॉवल में ड्रैकुला को थी, कि वो आईने के सामने खड़ा होता था, आईने में कोई शक्ल ही नहीं. There are people who are mirrored, but they cannot see. आप उनसे कहिए मुझे तुमसे प्रेम है, वो कहते हैं ये डायलॉग क्यों बोल रही है. ये है every goodness they will spoil. अब इस पे शेर सुनिए. ऐसा नहीं कि हमको मोहब्बत नहीं मिली, ऐसा नहीं कि हमको मोहब्बत नहीं मिली, काफी समझते उसको ये फितरत नहीं मिली, काफी समझते उसको ये फितरत नहीं मिली। निदा साहब का भी है से मिलता जुलता शेर कि कुछ तबीयत ही मिली थी ऐसी, चैन से जीने की सूरत ना हुई। कुछ तबीयत ही मिली थी ऐसी, चैन से जीने की सूरत ना हुई, जिसको चाहा उसे अपना न सके, जो मिला उससे मोहब्बत ना हुई। तो ये सब प्रॉब्लम्स हैं। अच्छा, तो अब 4 प्रॉब्लम बता दिए मैंने आपको। फर्स्ट प्रॉब्लम इज इनएबिलिटी टू फॉल इन लव, which is the most serious one. Happens mostly in antisocial, schizoid, schizotypal, paranoid conditions. Second, falling in love again and again, meaning inability to fall in love, which happens to young boys. I'm not talking of young boys. I'm talking of grown-up people, post-adolescents, adults. In them, this reflects mostly a narcissistic personality, you know, and in men, fundamentally a women-hating personality, misogyny. Number 3, that the falling in love with wrong kinds of people. This is based on guilt, one or the other form of guilt. Sometimes, rarely, in a small proportion, it's also based on childhood Oedipal seduction and Oedipal triumph. When a parent has exaggerated a child and preferred the child over their spouse, sometimes that can also lead to it. 4, the inability to feel loved, which has to do with anxiety and paranoia. Now we come to the final condition, and that condition is called inability to fall out of love. अब fall out of love भी जरूरी है, क्योंकि अब आपको इश्क हो जाए, आपको इश्क हो गया शाहरुख खान से, अब क्या करेंगी? या आपको इश्क हो गया ये दीपिका पादुकोण से, अब क्या करेंगी? मुश्किल हो जाएगी ना। तो जो च्युइंगम आपने दिल की लगा दी है दीपिका पे या शाहरुख पे, इसको च्युइंगम को उखाड़ के वापस लाना पड़ेगा। अनरिक्विटेड लव जिंदगी का एक हिस्सा है, and we will fall in love with people who are married, who are analysts, therapists, who are our patients, who are our students, who are our teachers. ये तो होगा, ऐसा नहीं है। मन तो चंचल है, ये तो गीता में भी है, मन बड़ा चंचल है। लेकिन आदर्श, गीता में है मन बड़ा चंचल है, मगर आदर्श उससे ऊपर उठने को ललकारते हैं। सो जब अनरिक्विटेड लव होगा तो वी हैव टू पुल आवरसेल्व्स आउट ऑफ दैट लव। ये कैसे कर सकते हैं हम? तब ही कि हमारे अंदर और कुछ बातें हों, और कुछ ग्रेटिफिकेशंस, और कुछ सेटिस्फैक्शंस, और कुछ सोर्सेस ऑफ होप एंड ऑप्टिमिज्म, तब हम छोड़ सकते हैं अनरिक्विटेड लव को कि भैया अब इनसे तो हमारी शादी नहीं होगी, चलो एक किताब ही और लिख लेते हैं। तो इस तरह से होगा कि चलो हमारे इतने चाहने वाले तो हैं, इतने एडमायरर तो हैं, हमारी इतनी अच्छी बेटी तो है, हमारा इतना अच्छा बेटा तो है, फला फला। तो आदमी अपने आप को तसल्ली तब दे सकता है जबकि उसके पास कुछ और हो। जब कुछ और ना हो तो क्या करे? तब तो ये अनरिक्विटेड लव को छोड़ देना बहुत मुश्किल है, क्योंकि it creates a horrible void, an enormous suffering, an enormous pain that the person cannot accept. And the hopelessness of a particular love situation is impossible to bear. That is what makes people stalkers. Stalker कोई बुरा आदमी नहीं है या बुरी लड़की नहीं है। The problem with stalker is not that they are mean or cruel. No, not at all. The problem with the stalker is that they don't have anything else to fall back upon and accept So I will read you something, but before I read you, you know that when Ronald Reagan was president of the United States, there was a young man by the name of John Hinckley who was at the campus of Yale University, where a young woman who was a beginning film actress but also a serious student by the name of Jodie Foster was a student. And John Hinckley approached her, "Hello, how are you?" And they had a cup of tea or something. Then he said, "I'd like to be with you, talk to with you. Can we go out this weekend or something?" And she said, "I'm not interested." अब जॉन हिगली साहब जो थे वो he fell head over heels in love with her, so to speak. Infatuation, beginning phase of love, which has to be rectified by merger of assimilation of some disappointment. So he says, "I'll send you flowers, I'll send you chocolate." He wrote her letters. He would show up at her university dorm. And she said, "No, leave me alone." But he could not. He could not leave her alone. And then one day, he decides to take a drastic action to impress her, to make her fall in love. And that is to kill the President of the United States, who was going to give a speech in a Hilton hotel in Washington. And John Hinckley travels to Washington, stays in another hotel, has a gun, and goes towards where President is staying. Just before going, about almost exactly 1 hour before going, he writes a letter to Jodie Foster. And I'll read you that letter. "Dear Jodie, there is definitely a possibility that I will be killed in my attempt to get Reagan. It is for this reason that I'm writing you this letter now. As you well know by now that I love you very much. Over the past 7 months, I have left you dozen poems, letters, and love messages in the faint hope that you could develop an interest in me. We talked on phone a couple of times. I never had the nerve to simply approach you and myself. Besides my shyness, I honestly did not wish to bother you with my constant presence. The many messages left at your door in your mailbox were a nuisance, but I felt it was the least painful way for me to express my love for you. I feel very good about the fact that you at least know my name and how I feel about you. And around your dormitory, I've come to realize that I'm the topic of more than a little conversation, most of it full of ridicule, it may be. At least you know that I will always love you. Jodie, I would abandon the getting Reagan thing in a second if I could only win your heart and live out the rest of my life with you, whether it be in total obscurity or whatever. I will admit to you that the reason I'm going ahead with this attempt now is because I cannot wait any longer to impress you. I've got to do something now to make you understand in no uncertain terms that I'm doing all this for you. By sacrificing my freedom and possibly my life, I hope to change your mind about me. This letter is being written only an hour before I leave for the Hilton Hotel. Jodie, I'm asking you to please look in your heart and at least give the chance with this historical deed to me to gain your love and support, respect. I love you forever. Yours, John Hinckley. 1 hour later, he picked a gun and shot Reagan. Thank you very much for listening to me.
Thank you.
We thank Dr. Salman Akhtar sir, who has recorded this session again at an oddly hour, just on our request. And this session is specifically for the International Conference of Clinical Psychology Society of India, the International Annual Conference, third CPSI Con. We thank sir for taking that time out. We would request Dr. Vinay Kumar sir, who's joined us online, to just maybe say few concluding words, and then we'll move on to the next session of panel discussion. Over to Dr. Vinay Kumar sir.
Thank you very much. I think it's very difficult to give any remarks after a person like Professor Salman Akhtar concludes this talk. It was online, but we all must have realized that he was speaking to our mind, our heart, all of us. The way talk progressed, the way he decoded the emotional relationship between two human beings, and the way he concluded was like, I'm reminded by another Mirza Ghalib's poem, in which in a couplet he tells about ईरे नीम कश या खलिश कहाँ से होती जो दिल के पार होता. His talk is like तीरे नीम कश, an arrow entered in mind, entered in heart, and remaining there. He has left us with lots of questions. He has left us with lots of new way of thinking. And it was a very inspiring lecture, truly professorial, and also person of great wisdom to all people, especially younger generation, who are in love, who will fall in love in future, or who will be taking care of people sick of love, trying to find good love, or other kinds of psychopathologies related to that. So it was emotional, it was educational, and it was highly pedagogic and highly inspiring for younger generation. So with these few words, I would like to hand over to the organizers for
Thank you so much, sir. Thank you. Thank you for joining us online. A big round of applause for our chair, Dr. Vinay Kumar, sir, also. We will look forward to having you tomorrow with us and, felicitate you when you are in front of us physically. So we look forward to you coming to the campus tomorrow. Thank you, sir. We'll move on to the next session of panel discussion. I request Dr. Bhavna Mukund, ma'am, to take over.
Absolutely. So, now we'll move to our panel discussion. And I would like to call upon our guest for panel discussion, Professor Dr. Jamna Rajeshwaran ma'am, Dr. Jiten Nagpal sir, Dr. Maithili Hazarika ma'am, and Dr. Anuj Mittal sir. I'll be talking about it. I would like to say that Professor Jamna Rajeshwaran ma'am is Professor and Head, Department of Clinical Psychology at NIMHANS, Bangalore. And her area of interest is neuropsychological assessment and rehabilitation, pediatric neuropsychology, and forensic neuropsychology. Ma'am, we welcome you. And we have with us senior consultant psychiatrist, Moonchand Medicity and Hospital Director, Expressions India, Dr. Jiten Nagpal sir, and his area of interest is adolescent mental health. We welcome you, sir. We have with us Dr. Maithili Hazarika, who is, is from Guwahati Medical College and Hospital, Assam, and she's an associate professor of clinical psychology. Her area of interest is child and adolescent, substance use, neurocognition, and geriatric mental health. We welcome you, ma'am. And also we have Dr. Anuj Mittal sir with us, who has 30 years of experience in the field of mental health, and currently he's a senior specialist in HOD, Department of Psychiatry, chairman of Central Standing Medical Board at DDU Hospital. No, Jyoti sir is not there, sir. Now I'm speaking of Anuj Mittal sir. I'm it's not there in the display. Dr. Anuj Mittal sir. So we have Dr. Anuj Mittal sir with us, who has 30 years of experience in the field of mental health. Currently, he's a senior specialist in HOD, Department of Psychiatry, and chairman of Central Standing Medical Board at DDU Hospital. He's also the chairman of Medical Disability Board, Janakpuri, Super Speciality Hospital, New Delhi. He's MD Psychiatry and PhD in Neuroscience from Maryland University, USA. He has also worked at Maulana Azad Medical College, GB Pant Hospital, Central Jail Hospital, Bihar, and Janakpuri. Presented many papers in reputed conferences all over the world. He has multiple research publications in international and national journals, and he's also a WHO fellow at Jefferson University, USA. We welcome you, sir. Thank you. And the topic for panel discussion is the integration of adolescent mental health challenges and new education policy. And I request the moderator to please.
Thank you, Bhavna. And this is a very important session, and we have actually very distinguished panelists with us on this particular aspects of adolescent mental health. I'm sure the audience is going to benefit about this from this particular discussion. So, starting from the particular aspects of the adolescent mental health policies, government has taken a big initiative, inclusion in terms of the campus mental health, reframing the campus mental health policies, starting right from the national education policy as starting the emotional well-being is a very important component of learning and teaching, and also teachers training dimensions. So let's have the canvas of understanding, and let's speak from the person who's been involved with directly with the policy making in the mental health field. So we have champions of mental health field around us, Dr. Jamana, Dr. Jin Nagpal, Dr. Anuj Mittal, Dr. Maithili. So we'll be having very specific questions to each one of them. So let's ask Dr. Jitendra Nagpal, who has been a part of governing bodies and a policy making in many of the forums of the ministry, right from education to Ministry of Health, as to how he envisages the growth of adolescent mental health policies across the 3 decades in the country, and what are the new things which are going to be their part of the policy. Over to you, Dr.
Hello. Yeah. Very good morning. Good afternoon, actually. Yeah. Thank you so much, ma'am, Professor Kalpana ji, for inviting me and also be part of the lovely audience as well as the most erudite panel over here. Had the privilege of meeting Professor Anuj Mittal after a long time. So it's indeed a revisit of adolescence for us also. Why do we need to have adolescence on a bit isolated, separate need for a policy or a program. The country is actually coming across this question time and again now. Well, good that we heard you telling us the new national education policy, which is just about 5 years old now, which actually has been on the vintage point of two major events that have happened in the country pertinent to mental health. Well, the upcoming generation in the field of psychology, psychiatry, and psychiatric social work is actually very well conditioned and gifted to the idea that a lot of policies will be helping you. One, a lot of policies are stationed in the manner that they will be taking you forward with the work you wish to do more systematically, legitimately, and very importantly, with a large stakeholder involvement in the country. Why do we need to, as a country, we the people or we the nation as a country, do we really need to give so much of exclusive importance to adolescent mental health policy? The answer remains a delayed yes, because it had to be done about 20 years back when the national curriculum framework came in the schools. And the new education policy has brought in a revision of that curriculum. So, for students in mental health who look at a career in the setting of building a new India with the educational platform of mental health, a policy was required. Yesterday, I was interacting with some students at one of the government schools, and the most updated definition of adolescence coming from a girl of 9th standard was the beautiful period between ponytails and cocktails. I thought it was fabulous to know कि किशोर अवस्था की नई परिभाषा भी है ये सोशल मीडिया के दौरान उसके संगठन में. We have the largest adolescent population. As a population, we are the largest in the world. 30% approximately, 25 to 30% are only adolescents. Do we need a policy? Do we need to have more dialogue, discussion, conversation on them, because they are the future? They are the incoming flow of the universities in India, with about 400 million of them walking into portals of higher education within the next about 20 years. So 11 से 19 या 10 to 19 मान लीजिए, 10 to 19 की population इतनी किसी दुनिया में कहीं किसी देश में नहीं है जितने इंडिया में है. So you are the largest. And of course the biological, the psychological, social changes dramatically happening with the influences from outside. The rate of mental health data has gone up tremendously geometrically. Roughly, India says we have about 15 to 18% of our adolescents who are reeling under psychiatric morbidity. That means diagnosable mental health conditions. Dr. Anuj Mittal will be elaborating more on that, looking at the stakeholder responsibility. What I wish to tell you is from literacy to education and from education to overall human development or holistic development, education के 3 parameter develop हुए हैं. When we started India after independence, it was लिखत पढ़त बच्चे कितने होंगे घर में, literate. Then came the educational model, then came the holistic development model. Today the policy has defined 3 things for us, and hopefully in the next about 10-15 years for the adolescent, involvement of the family as a dynamic resource of education. Family as a dynamic resource of education. The peer-to-peer support as part of the policy. What a wonderful step. Adolescents for adolescents by the adolescents. They as a peer support to build up the army, the brigade, and the circle of well-being in schools, in institutions, and therefore in the higher education. So what I'm trying to tell you is the policy today, which is the uniform mental health policy for institutions of education, takes into consideration the view of the adolescent, not the view of the policymaker or you and us. So a lot of good studies have been done in the last about 7 years before the making of the NEP 2020, which all of you should actually be aware, because it will help you in your further pursuance of mental health as a specialty. So I think in the initial remarks, I have this, that a uniform mental health policy for all educational institutions is already on the anvil. The Supreme Court is going to review it in a few months' time, and hopefully by middle of next year, we'll be having it as a bill passed away from the Parliament. So it's a great achievement for the mental health professionals. And I think it's a time to generate more ideas, to do more research on this. Thank you.
Much, Dr. Nagpal, you very nicely said that new education policy, especially when you're talking about a higher institute educations, there have been I would say, roadmap of developing the policy, and there's been a beginning has already been made. In fact, at Amity University also, we have got a formulated and been a part of that particular policy making for higher institute education. So thank you very much for that. Now we have a distinguished specialist with us, especially Dr. Jamuna Rajeshwaran. Her work in the field of neuropsychology is recognized globally, not only in India. She's a very renowned neuropsychologist. So I would like to ask her a very specific question as to how the cognitive development or cognition at the age, especially adolescence, matters in terms of understanding the framework of mental health. So over to you, Dr.
Thank you, Dr. Kalpana. Thank you. I thank the organizers for including me in this panel. Well, when we talk about adolescent, it is a very critical period in the developmental trajectory. They are sandwiched between childhood and adulthood. And now it encompasses emotional, behavioral, cognitive, and psychological well being. Now, when we think of adolescents and their behavior, it is not only recognized now, time immemorial, it has been recognized. Even our grandparents would say it is their behavior is because of their age. But they did not know what was the brain development at that time. Our grandparents, if you had asked, why do they behave like this? So the brain is under construction in the adolescent period. Now, when it is under constructions, obviously, their behavior is at stake, their emotion is at stake, their cognition is at stake. Augmented with that, if we have family issues, peer issues, be it even this education, which is playing a very important role and more so in our country. I think every parent is worried about the child's education more than their emotional and behavioral competence. So, what happens when the brain is under construction? What I mean by that is the prefrontal cortex is the last to develop. Amygdala is developed. Now, when any information given to this adolescent, it directly goes to amygdala, which is an emotion center, and that is why the adolescent responds to any questions or any argument emotionally. Now, this, if the parents understand, they may handle it in a different way. But if they do not understand, they realize that the child is always answering, back answering, or very emotionally answering, or very rude to everybody. So what happens sometimes these kind of behavior gets reinforced because the child has understood only when I talk to them like this, my needs are met. So what we need to make them understand and make the policymakers also understand that you need to frame cognitively also and include cognitive scientists in the policy making decisions so that we bring out appropriate modules for these adolescents to cope with. I'll just give a simple example. A child wanted to go for a night club for some party. The parents resisted. Now, the boy was very upset and threw a tantrum and would not eat and was brought to our unit. They thought that the boy is misbehaving. And finally, when we went into the history, all his friends went, their parents agreed to send him, but this parent did not agree because they thought the fear of something might go wrong. Then what happened when we explained to the boy, see, all we need to do is have a communication with this adolescents. That's very important. And once when we do carry out these conversations and what are the merits and what are the demerits of doing this particular act, they're able to understand. So in the bargain, what are we doing? We are pulling out information from the amygdala and giving it to the prefrontal cortex. We are explaining it to them. We are telling them, you plan out, you make a decision, you understand why a parent is saying this. And once that understanding happens in an adolescent, they are able to adhere to whatever we say. But if you say no as an authority figure, I say no, you cannot do it, then their amygdala is playing a role. So what we need to also understand is there is growth spurts at different point of time. So at an adolescent period, they are fighting for autonomy also. They want to be very independent. They want to be a differentiated self. So we have to give room for all this in that growing period and also look into their developmental way. What was the childhood cognitive profile, or what was the academic profile in the childhood? Is it continuing in the adulthood, or is it come down? If it has come down, what are the causes? Is it the environmental causes, or it is a nature nurture? We have to actually tease it out and see how we can help the child. If the child has a cognitive issues, is it augmented with emotional issues and behavioral issues? We need to tease it out and start giving intervention if the child has a problem at a particular point of time. And thank you.
Thank you, Dr. Jamna, bringing out so beautifully about the developmental roles, cognitive development, and the stakeholders to be aware of the various kinds of developmental processes which are required in comprehension and execution of any policy framework. It's a very valid point which you have made. The cognitive scientists can really be a part of where they can elaborate the roles and have the checks and balances in terms of the policy making. So that's a very beautiful point. I'm sorry, I'll have to rush up to second question, Dr. Nagpal, as he's to attend a WHO meeting. So I'm taking the permission from all the experts sitting here that may I just ask second round of questions so that he can proceed. So I really wanted to know from him is that there's a new, not new, it is something which is coming up in the arena as a adolescent mental health and school mental health, where the school mental health counselors and the psychologists, so the role is emerging. I said there are a lot of the road ahead, I would say. There's a lot of scope about it. So I think that as a policy making, that also should include the professional training of school mental health, a requirement for the psychologists and the clinical psychologists in the school mental health programs. Over to you, Dr. Khan.
Okay, thank you. I'm sorry, I would have to leave in a short while, but then as the question was important to promote further discussion with our esteemed panelists over here, I just tell you in the numbers. Numbers fascinate sometimes. India needs about 4.5 lakh school counselors, and we have only 7,000. This is what the data is coming through. So, how many of you are takers on that? Because employability factor, sociability factor, and also career factors are huge. Millions coming in now. Now, why do we need this? I think the discussions have already started. You will hear more. Not because there are problems. There is a need to create a climate of well-being, happiness, learning transaction process being a little better. As Professor Jamna said right now, cognitively, effectively, if I'm in the tune of optimal living, I'll learn better, I'll imbibe better, I'll memorize better, perform better, isn't it? So a lot of ocean of opportunity for all the young psychologists here. And the first and the most important person required for being the mental health advocate and the leader in a school will be the psychologist. Whether you take on the counseling psychology or clinical psychology, your association with the baseline education system in India with 16 lakh schools, इतने तो स्विट्जरलैंड में बच्चे नहीं हैं. 16 lakh schools हैं आपके पास. The opportunity minimum required is 4 lakh counselors, and we are only 1/100th of them at the moment, right? Delhi has only about 400 attached to the schools. We need 2,000. So one factor is that constant professional development for counselors in the school, because as we heard just now, dynamics are changing. You need to be updated with the dynamics of parenting, pedagogy, the teacher and student interaction in the classroom that comes in your purview in the school. The teacher is asking you for orientations in the staff room about foundational years mental health, about middle school, high school, and adolescent well-being. How do we create more intersections and chains in the atmosphere of a non-teaching staff. Non-teaching staff in the school is almost 50%, sir. From the admin staff to the supervisors, the bus drivers, conductors. Have you not heard of the POXO? You heard of the POXO? You heard of the JJ Act, the RPWD Act applicable to schools in India? So law and mental health and schools hand in hand. The alliance and the marriage of these professions is huge, led by, again, the school counselor. Only yesterday we had a meeting, and the next meeting is on 14th or 15th. There is a huge amount of need for NCR schools to actually collaborate, cooperate between the external agencies, for example, like your university, and build up the complete platform where community linkages can be made for school mental health. So I'm just telling you the skyline which is waiting to be born and nurtured by you people who are going to be in the field. And let me tell you, the business part, emoluments are good. I know, sir, emoluments are not bad. You're going to have good money if that is the score also, and why not? Salaries are going to be good. Government salaries are good. Private school salaries are good. Best part is you have the two worlds with you. You can be a practitioner and be attached to a school. So that's a need for the time being, and also a lot of new age parenting, right from the toddlers till the middle school and the adolescent parenting. So I have not seen a counselor who is committed, passionate from 7:30 in the morning to 4 in the evening in a school, having time to have a sip of tea. They are so busy, so fascinated, and I think Abraham Maslow is feeling very happy about them. They are very self-actualized. Thank you so much.
Sorry for this interruption. It was like immediate gratification of a childlike tendency to rush into the thing. So we're coming to the very important question. That is, I would ask Professor Jerry. See, about the school mental health access and awareness about the mental health. I would like to know your thoughts about it. How to create an awareness in this schools and colleges about the mental health. So please share your thoughts.
You see that every one of us have felt at one point of time during the learning process, education process, that we are not feeling good. We are feeling stressed. We are feeling harassed. We are feeling pressed upon. And we had some solutions to it, may not be scientifically very valid, but individually. So my first suggestion would be that as now professional, you just introspect yourself. What type of problem you were feeling you were having, and what type of problem the new generation students maybe feel slightly different. You had the pressure from others' point of view. Now they are stressed with the digital pressure and the mobile pressures and all these things. Change the resource may be different, but the ultimate outcome is the same. So that is one part that once you are working with the school children or your practice, you must see, you must put yourself on the, try to empathize with the student, which is very, very important. Half of the answer would be there itself. The second thing is that once you see that how to develop a mental health literacy mission, mental health literacy, because in a school, no matter how much manpower we develop, in a school, how much manpower we trained, we would never be in a position to cater as per the ideal need. So we have to take care of this very important thing by developing some first aid type of issues, first aid type of training to among the student who could help themselves, who could help their own friends and seniors and juniors. And that would be very important. I personally feel that would be the important thing. The second, that this new education policy, which otherwise is a very, very good, very flexible, availing, providing the concept of multidisciplinary study and different subjects. But for teachers as well as for the parents of the students, there is a lot of resistance. Resistance for change is one of the human problem, but here they would tell you a lot of lot of things about that, why it is not possible, why it is not relevant, how an engineer can study the history and what is the use of it, why you are making all wastage of time and all. So this type of resistance would put your student again in the very conflicting situations. So you have to educate at every stages. So if human resources would always be crisis, but you can develop your own students, force peers who could help their peer group in solving the issues, and that is, I would suggest that mental health literacy should be introduced for the teachers, for all the teachers, and for the not only for teachers but for the support staff. Students are not only interacting with the teachers, they are interacting with the ayahs and peons and bhaiya and drivers and cleaners who would be exploiting the children, exploiting the person, and how to handle these issues as well. Dabbu hai, kamzor hai, bewkoof hai, all these words are being used not by the teacher. तुम क्या वैसे ही बात करते हो, तुम क्यों वहां जा रहे हो, तुम बात नहीं मानते हो. All these things very self demoralizing, and the children are having that stress as well. So it is not only the course which is making the children stressed, but the expectation of the parents and the system, assessment system, that has to be taken care of. This new education policy has given a lot of recommendations for assessment as well. So I think these are, if the things are practiced, some solution would be there and some relief would be there. Over to Kalpana ma'am.
Yes, sir. Thank you so much, sir. That very well pointed out that in terms of the stakeholders, parents, and teachers, everybody has to be involved. And but one very important thing which I always say is that there is no software for updating parenting skills. You know, you have a WhatsApp. Every now and then you get there. Please update your system for 15 days. It'll shut down, etc. Everywhere there's a chip available to upgrade it. So we need, as per the social fabric of the society is changing, there's a lot of transition happening around in the environment. We need that kind of an understanding. The parenting skills also need to be actually modified and trained. There's no harm in it. Nobody is born a perfect parent, neither we are achieving to be. But as a part of the changes, the sensitization of the changes in the parenting skills is a very important component. So I quite agree with you, sir. So we have next question towards, I think, the important panelists. Dr. Anuj Mittal, he has worked a lot with the forensic setting. He has worked with the prisons and he worked with the mental health of the prison, and actively involved with the community work. He does a lot of camp and community outreach programs for creating mental health awareness. So my question rather is to you, I would like to know from you as to how we can reduce the stigma around mental health in the adolescents. Secondly, how we can bring the marginalized society, the adolescents, to the mainstream where the gaps are not so huge in terms of stigma of reaching out for the help. And I still remember one of the sessions when we were taking, the child had said that if I want to say that I want to go to meet the doctor or the psychiatrist, my parents say everything is fine, you don't need one. So there is stigma which in the society, in the families about the mental illness. So it is not the adolescents who don't want to reach out. It is that they're stopped to reach out to take any kind of a mental health. So I would like to know your thoughts about it.
Thank you, Professor Kalpana ji. Guys, we all watch Bollywood movies. Most of the audiences are actually very young. You might have heard about a movie known as Tare Jami Pe. It came around, I believe, 22 years, 23 years back. And suddenly we psychiatrists and psychologists start getting more children for our assessment. Even the children with no problems came to assessment that, sir, do we have the similar symptom as the child in the movie had? So you can see how impactful it can be when a message is delivered by a media which goes into everyday's life. Those days it was movie, televisions. These days it is, of course, your internet, your mobile phone. Therefore, uh, there are many challenges we are actually favoring. I'll give you one more example. Few days back, a parent came to me. Rather, uh, uh, they their actually daughter who actually completed her engineering from Chandigarh. History is 3 year back they came to me. They said our daughter was not behaving properly, so we sent her in an engineering college in the Chandigarh. We got her admitted in the engineering college in the Chandigarh after 12th, and the poor girl was struggling there for 2 years. When they came and they took the help, then that girl settled down and she completed her engineering. She came to me a few days back. So the question is how parents are handling the mental health issues or adjustment issues or behavioral issues of their own children. This, it actually depends on their awareness of the situation, their accessibility of the services. So that will remain a very good challenge in India for some time. Now, who can help us? Only we can help us. Only mental health experts will be able to give that input to the society, to the administrators, to the politicians, to, to the common man. Now, one thing more, we are trying to start a suicide helpline for adolescents since last 5 years under the bannership of Delhi Medical Association. We are willing to give the space, we are willing to give everything, but we are not getting the enough sponsors to do that. The question is, we started it for a few days, then because of lack of fund, we have to stop it. The question is still there is something more is to be done. So it is absolutely clear to us that something more is to be done. What can be that more? That more should be done on all the levels, from the government level. So we were talking about the policies. So who who can influence the policies? Our organizations can can influence the policies, and government will only listen to your organizations. There's strong organizations who have the scientific data. So the government will only listen to that. Second, administrators. I have few senior administrators, children I am treating them, they are very aware. They come to us, they talk about mental health. But when you approach to other people, they will not. The question is, awareness is definitely lacking in all the levels. Number three, on the family level. On the family, still there are the families in India. We have nuclear families as well as the joint families is still existing. Parents will understand.
there is a problem in the child, but grandparent will say, हमारे जमाने में तो ऐसे होता था, ये तो ऐसे ही कर रहा है, दो लगाओ ठीक हो जाएगा. So, what can be the solution? The solution is to make them aware. The first thing is the parent, because a child adolescent, they interact with mainly three people, only three set of people. Number one, his or her family members. Number two, his school teachers. And number three, his friends. So these are the three people or the three set of people whom a student interacts. Therefore, the first thing is the parental education. If you want to reduce the stigma, especially in the adolescent group or in the childhood group, you have to educate the parent. Every school should have orientation classes on mental health as they admit their child. And it has to be updated with every class. Suppose a child is being admitted in your KG. See, what I have seen in Delhi is so many schools, they are keeping one clinical psychologist only. There are 1,000 children. You tell me, is it adequate? It is not adequate. 1,000 children, around 500 children, one clinical psychologist. That too part-time. How it will help? They can only help the individuals who have really gross symptoms, not the one who are going underground, not the one who are not seeking help themselves. So the most important thing is the parents. Many years back, when my daughter was very small, I went in a parent-teacher meeting in a very reputed school she was studying. So I saw a father-mother combo was sitting, a fat child who was having the Pepsi and all high calorie, junk he was eating, and they were sitting like that. And father came from a trip after one, and he said, and by not saying anything, you can figure out that the responsibility of child was only on the mother, right? And on the teacher. And he was scolding the teacher. We give so much fee, we give so many things, and you are still not looking after my child. He has such behavioral problem. His academic performance is going down. He is gaining weight and blah, blah, blah. And then when they left, when my number came, I asked them, teacher, how many times this father came to you? She said, he has come after a year. Only the mother comes, and this child does not listen to the mother because the father treats his wife very rudely, and he treats her like she's very inferior. So this adolescent child will also not listen to the mother. The question is, interpersonal dynamics among parents is also an important factor. So all the parent should be first sensitized to these kind of issues initially. So a thorough awareness classes should be taken in the schools by the professional group of people, not by one clinical psychologist, poor girl or boy sitting in a room and waiting that somebody will come and blame them for the bad behavior of the student in the school. Number two. Number three, on the school level, we are doing, I'm an advocate of the Rotary Foundation, and I've been a mental health expert to the Rotary for many years. So on the banner of the Rotary, we are going to the school teachers and trying to educate them regarding the mental health of the student, how to handle them, how to identify the early sign and symptoms of the mental health issues. There may be small issues like adjustment problem, a new child has come, or maybe the major issues like I have seen many kids with ADHD in the class 9th, 10th, 11th, and they are going on and on, and without any supervision, without any diagnosis, without any guidance or treatment. So who can identify them? A teacher, a good teacher with sharp eyes can identify them. And second thing, we also took the class of how to reduce the stress of the teachers also. Because any group of adolescents, suppose you are handling 5, 7, 10 adolescent in your house, imagine what happens. They will irritate you. They will make you angry. But it is the age where they will experiment. They do various nasty things. They are normal many times. So a teacher who's looking after a class of 30, 35 adolescent children, then her stress level will be high. So first time it happened, we focused on the mental health and how to handle the stress of these teachers so they can handle students better. Therefore, so these are the various areas which we need to help. Now this is the scenario of the adolescent in the well-to-do. I mean, families who who are financially well-to-do, who have accessibility to see various mental health facilities. What about those who are studying in the government schools, where the infrastructures are poor? Teachers are not very much interested uh, in looking after the children, and children have come from the broken homes. They have uh, various drug issues, various behavioral issues, various interpersonal issues, and nobody is there to look after them. They may go to wrong hands. So there is a challenge. So the government is also putting. I tell you, 5 years back, Delhi government has started. They they started a project in which they asked every government school to spare a room in which a doctor will visit, a clinical psychologist will visit, a social worker will visit, a psychological social worker who can identify and explain those people to those issues. So it is not that administrator or government is not aware about these things. You will be few of may might be knowing this, but you will be surprised to know that a, a cleanliness device drive was happened in Delhi in last month. It was a 15-day drive before Diwali. And one day was preserved for mental health. That awareness of the mental health, we were told, and we told everybody in the all government organization to put the posters regarding mental health, to talk about the mental health and distribution of the awareness pamphlets about the mental health. So things are moving gradually upwards. Our policymakers are realizing that without mental health, we won't be able to achieve. And adolescent, as we all know, I am not saying, I mean, nothing new. Adolescent is the time when you can build, uh, a, see, we can build a basic foundation of the good mental and physical health. So it is various areas, and we will keep on discussing. I'll emphasize on one thing more, madam. Usually, from where an adolescent gets the information, usually from an internet or from a from his phone. Many people, many parents advocate we are not going to give a phone to a child, but most of the homework come on the phone. Most of the information they get from the phone, you have to give them phone. As they are 10, 11, 12, 13, whenever required, you have to give them. Initially, you actually give them part time, then ultimately you have to give them full time phone. That is an essentiality for everybody. Therefore, the online content regarding the mental health and regarding the all over. So government has started few policies to control various online contents. Although on the pornography they have make a good control. They are trying to control. Same way on the various things like the mental health awareness. So if you click mental health things on the online, you will go to the various sites which are not as scientific as they should be. So I will emphasize on that we should encourage the individuals to interact with their teachers, at least with their parents. So encourage them to talk to them. Thank you.
Thank you very much, Dr. Mithu. I think what he has emphasized is that having the authentic sites and creating a mass awareness about the how to handle adolescent mental health, especially adolescent issues. Very important component you have addressed. With the paucity of time, I'm rushing because we'll take one question each towards the end. I would like to ask Dr. Maithili, who's sitting here, about the family aspects and how the families have handled the issues of the adolescent mental health and how we can really train them, make them aware. Family means could be inclusive family. I would like to talk about it. So please.
Thank you so much, Dr. Kalpana. And everyone had made my job very easy. So, what I would like to focus is on the movie on adolescence. If people have seen it, maybe they can learn a lot from that movie. It's the intersectionality between the teachers, parents, the cyber, digital, mental health literacy, what you can get from the movie, I guess. And this is something very deep and very critical because families, what I have seen in the last so many years of my service, families are very difficult to, the families' parenting or the way of dealing with adolescents is very difficult to change, only because of the fact that they give a lot of importance to academics and marks and the grades because of this system that we follow. But the new education policy, what we have seen, is very flexible, very holistic. Though it is very holistic, they have not given too much of importance to emotional literacy of the parents and dialogues between parents, teachers, and how to frame those. I am in the state mental health policy as well as in the central mental health. So, what we have decided is that how to bring in the parents into the context of parents leading the mental health programs in schools. Because if they do not lead and they are mere spectators, nothing is going to improve, because parents are the first identifiers of a child's mental health issue. And if they do not have any knowledge about what are the indicators and the risk factors of a child having a mental health issue, it becomes very difficult for them to acknowledge as well as do something, even if the counselors and the teachers tell them about it. Because the stigma attached to mental health is so high and large that we cannot just break that just by doing some kind of educative practices or psychoeducational forum. But we definitely have to have more discussions. And those free discussions are so important, not only by the counselors, maybe by every subject teacher. Even physics, chemistry, maths, there has to be some 10 minutes of mental health literacy among the teachers, with the peer groups, and with the students as well as parents, how to bring them into the context. And parent teacher meeting also, because of the paucity of time by the parents and the busy schedule of the parents, they don't give importance too much, thinking that this is a rebellious phase of life and this happens to everyone and just pass on. But now the things are changing. The disorders are like, every new day we see something different. And we as counselors, we do not know how to approach, because we have to also update with the digitalization that is happening, because the apps and all, when they talk about the cartoons and different kind of online gaming apps, I really have to go back and read and see what are the apps and what are the online games they are talking about, because some are very aggressive in content, and they are very hooked into that. And if we don't have any knowledge about the apps that are prevalent among the adolescents, we will not be able to treat them. So it is about the counselors updating the knowledge and digitalization, and also the different modes of, play games and whatever they're doing. And also about the online monitoring by the parents, which is not so possible. Because of yesterday, she spoke about pro-social lies and, a different kind of lies that adolescents will take. We see always, they talk about online doing some thing which is related to their subjects, but actually they are not doing that. And the parents are not aware of those also. The parents do not know what is, given by the course, by the school, and what is not given by the course in the school. So they do not know where to actually draw the boundary. So the school's authority maybe have to make the parents aware of what they are giving to in digital platform, because we the parents will not be able to they will not understand. And one group of parents are not aware how to actually use the computers, and they really have no idea. So this is what the transition is. It's a workload stress, not only for the teachers, also the parents, because they are not aware of the transition that is happening. It's an immense workload and immense change that is happening. And I think this is a transition that is happening, and we all have to pull up our sleeves to know more and more, and to always wait for the unpredictability, because we can predict the unpredictabilities now, I guess, as mental health professionals. And that is huge on us, because we get burnt out, because when we see a lot of new issues are coming in adolescence, relationship issues, cyber safety, cyber crime, so many things. So I think as professionals, we have a duty and a responsibility to how update ourselves and make tailor-made interventions. And with rural, urban, semi-urban schools, everything has to be tailor-made, because the government schools are very different, as people are saying, and convent schools are different, and they have a different, the fathers, the celestial sisters and brothers, how they treat and how they do education is very different from other schools. So I think we have to holistically see from our perspective, as well as the changes that is happening in the socio-cultural milieu. Thank you so much for the platform that you have given me, ma'am.
Thank you, Dr. Maithili. See, we all as a mental health professional are concerned that we have to deconstruct the reality for the parents, for the children, for the school mental health. That's what is the job actually. This is the work we have to do together. So, having said that, I think the one important question, we cannot close this panel discussion. So, since we are running behind the schedule, I'll request Dr. Jamana to address about the disability component in the girls and mental health. And then probably we'll have to move to one or two questions and then we'll have to close this. Thank you.
Thank you,
Over
Dr.
to
Kalpana. I'm sure all of us are hypoglycemic. I'll make it very short. I'll talk about two important components in disability. One is with IDD. Now, when we talk about IDD, we know that the onus is on the psychologist to give the certificate, be it for IQ assessment or be it for SLD. So, having said that, when we look at the policymakers, Sir said that the institution should take the onus of sending this revision in the policy making. If you look at the PWD Act, this particular for disability in IDD, the Binekama test of intelligence and Vineland's social maturity scale is being delineated. And it is an outdated test. Now, NIMHANS, from especially from my unit and my department, we've been sending it for last 7 years. When it comes to the cognitive area, it has been neglected. So, what is happening currently in IDD children because of the Flynn effect? What we see, the child behaviorally has some deficits, some disability, but the test is not picking up. Now, there's so much of injustice done to the child. Now, how do we overcome this? Unless we incorporate the newer test, which can pick up these disabilities because of the Flynn effect, I think we cannot move on. And now, when you administer any new test and give a disability certificate, the government is not accepting because the PWD Act has delineated BKT and VSMS as the test for disability. Similarly, for SLD, now the onus is on the clinical psychologist to certify whether this candidate falls under SLD. Because of the benefits that these candidates get, there are upsurge of candidates coming for assessments. Now, one candidate came who's done a PhD and wants a disability SLD certification to get into a job. Now, once we do not have tests for adult SLD. So, somewhere along, we did some cognitive assessment and we said the candidate is not falling under the bracket of SLD. They've gone to the Supreme Court now. Now, the Supreme Court has directed NIMHANS to develop SLD battery for adults. Now, we are in the pursuit of it. I'm sure Dr. Rupesh and Dr. Thomas, who are here, they are working on those things. Now, how do we overcome these kind of problems that we have unless we are, as a stakeholders, are there in the policy making body? So this is where I think all of us need to understand how do we overcome these problems. Just giving a certificate does not stop there, because that candidate can influence the entire SLD community, saying that this place gives a certificate and you can get some benefits. So these are two things that we are working on. And if anybody, I think this, we make it as a document and send it to the ministry also, saying that the stakeholders have to be in the decision making body of the PWD Act or wherever it is. Thank you.
So since this has come to, yes, sir, I would add, that's what I would ask Professor Jadi to add just two statements. And also we have a disability chair for the West Delhi, Dr. Nuj Mittal, so I'll ask him also because very important component has come up.
What Professor Jamna was saying about was the overt disability, which is visible and one can make it out. But many of our students are having invisible disabling condition. They may not be qualified, they may not be labeled as a disabled in terms of Disability Act, but they are having some limitations, and that limitation may cause them serious mental stress. For example, stammering and stuttering. I mean, it is one just visualize a child who knows the answer, but he cannot give the answer out of the fear of social laughing and teasing and all these things. Low vision cases. Low vision up to one point of time it is disability, but still if it is a high problems and all these things, not person cannot be concentrating on this. The blood related issues like hemophilia, he cannot play, he cannot enjoy the life as others are playing. So there are so many things. I'm not hard of hearing issues are this. So I'm not going to, because the time of short, I can give you full presentation on this invisible disability. But you have to address as a clinical psychologist, as a school counselor, you have to take care of the stress and stress related irritation related the impairment of their performance and their isolation and their withdrawal and their low self-esteem. And that is another very important component of mental health care of the children. Thank you very much.
So, and in this particular component of disability which has been addressed, that's a talk and a lot of conversation happening around that. The stammering, stuttering, these components of the mental health are not being addressed. Dr. Anush Mittal has been a chair of West Delhi Disability Board, and he says he's done more than 2,000 disability assessments. So please, over to you.
I'll take only 2 minutes. Since you all will be doing at some point of other time the disability assessment, various kinds, let's say IQ assessment or SLD or whatever. There are many problems occur when you do it practically. There will be external forces. There are so many fake disabilities has been discovered. So a very influential person will call you, say, इसको 30 से 40% कर दीजिए because 40% is the benchmark. Then number two, the problem comes with the IQ and the SLD is when an individual has borderline intelligence, you will give them 25% disability. But as you go for SLD, after a level you just give them 40%. Suppose if you read this act, there are so many things as to be upgraded. So we are trying to tell the government about it. We are actually pushing that in the next guidelines we'll get it corrected. There are few things they need to be addressed. Please be careful about giving the SLDs because this is the area in which from the private they get many time see more than 40% and you will find that person has nothing. There's no disability. So these are the areas which we have to be very careful. Thank you.
See, this is taken to such an interesting discussion. Over to you because see, we want you to know
I'll just
what is
take a
happening.
minute.
Yeah, please.
I definitely would appreciate if this guidelines has been will be reviewed and then give it in the center so that the entire country reviews this disability guidelines. And now many of the clinical conditions is brain based, which was thought to be functional, not only IDD or not only SLD. Now, even in childhood disorders and adolescent problems, they want a cognitive profile because once a brain is involved, cognition becomes the integral part of the disease. So, when that becomes an important component, we have to do a cognitive assessment. At NIMHANS, for the adults, we have come up with a disability. So, which again, we have been sending it for the last 6 years. We have not been able to put it in the Disability Act. So if these things are addressed from the policy making bodies, I'm sure we will be able to help many individuals. Thank you.
And one more thing, just wanted to add about the parental, acceptance of disabled children in the classroom of healthy children. So that is one thing I have come across. The parents of, children who are healthy do not like that inclusivity in education. So that is another area maybe we have to work upon because a lot of bullying that is happening because of the parents' ignorance and how they see disability, and that gets generalized among their own children. and those children comes and bullies the children with disability. It could be a SLD, it could be anything. So I think we have to really work on that area. Another one area is type 1 diabetes. I am doing some work on type 1 diabetes in children and their mental health issues. This is one very under researched area in children. So that is another input. Thank you so much, ma'am.
So, thank you very much. And I really would appreciate that so much of work is going around and the leaders have taken some initiative, the thought leaders. But any participants, one question, two questions? Yes, please. Come fast, quickly. Get the mic.
Hi, my name is Saiba, and I'm a trauma informed therapist and also a co founder of a preschool and a daycare. So, one of the challenges that we have been facing very frequently is quite learning disability related symptoms are being observed in the kids who are part of daycare and preschool. So, my question is whether introducing special educators at that level would, in a way, redefine the educating system in the first place. And secondly, another gap that I'm experiencing is communicating it with the parents, as you all already addressed. But the parents' concerns are like, no, like, I mean, the child is just delayed, it's just late. And that is something that acceptance is not there. And because of that, I feel the kids, again, if this is not addressed, and it may start impacting their self esteem and other related issues in the future. Just wanted to take from everybody. Thank you.
Thank you for your question. So, early identification is very, very important, as you have rightly pointed out. Whether a remedial trainer and a special educator is required, definitely, if you find anything wrong and which is not according to the norms of the child, then some special input will be required. Coming to the second question of yours about family not accepting, that is what we have to all work upon. How to change the mindset of these parents, which is not an easy task though, but we have to keep the parents in the loop while trying to understand the child. Not label the child as a disabled child, but how to find out other ways of talking to the parents. The communication between you and the parent is very sensitive, to make them to come to their level. And because you have to be an empathetic listener and understand from the parents' point of view what they are passing through. They are going through denial, all those loss, denial, anger, bargaining, as you know. So definitely you have to see that that is a defense. The denial of not that accepting the child as a disabled will never happen so easily, right? So I think that is the therapeutic alliance that you have to form with the parents to make them understand. And slowly, if we make it very open and destigmatize, then I think every parent will change, and the teacher's role is very, very important here also. Okay, so this is one parent you're talking about. There are other parents who are very accepting. They come forward with even little minor issues with their children, right? So things are changing, but definitely we have to keep our pace with the change, right?
I think very well deliberated where everybody has contributed. So these are some of the bullet points, I would say. So you'll have to dwell on it and really read a lot of literature and then update yourself. So the bullet points for updating in the field of adults and mental health. That is what I would like to say, because we are behind the schedule. I would not speak much. And I really thank hugely all the panelists. Please give a big round of applause. You are hearing from the experts in the field who are the thought leaders. So on today on this panel, you had all the thought leaders who are involved with the policies. So I'm sure whatever has been said has gone into the wisdom across the generations, and we're sitting here, especially they'll be benefiting from this. Thank you very
Really, thank you for such an insightful discussion. Now I would request Dr. Kalpana ma'am, not taking much time, to please felicitate Dr. Anuj Mittal sir. Anuj Mittal sir. Like, like would again request Kalpana ma'am to felicitate Professor Jayadi sir. I would request Kalpana ma'am to please felicitate Jamna Rajeshwaran ma'am. And again, I would request Kalpana ma'am to please felicitate Dr. Maithili Hazarika ma'am. And I would request Dr. Chinu Agarwal ma'am to please come up and felicitate Dr. Kalpana Srivastava ma'am. What? Give it to ma'am. To Kalpana. Now it's lunchtime, the lunch break, and we will resume the session post 20 minutes. Thank you.
We're very pleased to start with the invited lecture, Adolescents' Mental Health and Artificial Intelligence, a Strategic Approach by Ms. Smriti Joshi, ma'am. I request Ms. Smriti Joshi, ma'am, to kindly join us on the stage here. And the chairperson for this is going to be Dr. Kriti Pai. I request ma'am to join on the stage also. A big round of applause for our invited speaker and the chairperson. To introduce the invited speaker, Ms. Smriti Joshi, ma'am, is a chief clinical psychologist at Chief Clinical Psychologist International at WISA, Vice President North Zone Council's Council of India, licensed clinical psychologist, digital mental health expert, AI ethics expert, and WPA contributor. Ma'am's professional background ranges over last 2 decades with experience spanning in clinical service, delivery operations, training, to just name few. She's pioneer in digital mental health, and we have seen her accolades over social media as well as in other platforms. We are very glad to have Ms. Smriti Joshi, ma'am, with us over here today. Her areas of interest are adolescent mental health, AI ethics, and trauma-informed digital care. And just to name few of her awards, she has won Ethics in Tech Leadership Award recently and has been invited keynote speaker at American Association of Psychology, American Psychological Association, Council of India, as well as CPSI, and many other international conferences. Ma'am is also on the advisory board of many committees like WPA, APA, ISCPA, CPSI, and is helping develop national and global guidelines for digital and mobile mental health. We welcome you. Over to you, ma'am. Your president.
Very good afternoon to you all. Have you all had your lunch? Yes? How do I know? Is there some energy? Can we all stand up once? Now that we have stood up, people on the back, can you come in front? थोड़ा trick तो करना पड़ता है ना. We have to trick a bit. Come. I promise I'll try and keep you guys awake. I have to be awake, so I need people here. Otherwise, I'll fall asleep. I'm not wearing my right glasses, so I will not be able to see the faces of people at the back. Come in front, please. Thank you. All right. Thank you for those who obliged. So we are going to talk about, at the first outset, I think I would like to express my gratitude to the organizing committee, to Amity, to the organizers, Chairperson ma'am, for being here, students who are present here, colleagues, peers. And we are not going to talk about just technology. I know tech and AI and digital is all very in and trending, and we all want to learn about it, and we all want to know how it's being done, which is one of the things we'll be talking. But why it's so relevant is because we are going to talk about the 1.2 billion residents of this earth, the adolescents. Right now, this is the largest cohort of individuals who are being kind of captured by wide variety of people in the organizations and industries in the world, be it advertising, education, sports, different kind of app, etc. So our focus is going to be this 1.2 billion cohort that is being affected by the attention economy at large, right? We all know that adolescence is a remarkable and fragile phase at the same time. A lot of exciting things happen, but also we know it's a stage of storm and stress as people in the old, if you read old books or earlier books on adolescent child mental health, you will read this, line quite a bit, storm and stress, and a lot of turmoil that happens in this age. But it's also a lot of exciting because your emotions are kind of nearing maturity, but your prefrontal cortex still is kind of worried about how do I make the judgment, what I'm experiencing, what I'm feeling, and what do I have to do now. That is where the concern comes, and that's what makes them the most vulnerable, because things that excite them, things that make them happy, things that capture their attention, their decisions on what they will do next with whatever is holding their attention is where the risk lies, right? And we need to know what are the things happening in the mental health space, in the guideline space, in the guardrail space that can help. If we are aware about them as clinicians, as parents, as stakeholders in the community, what can we do to protect them? And if we are builders of these apps, what do we need to keep in mind when we are building these products or these apps? 95% of 13 to 17-year-old use social media daily, and prolonged use is linked with mental health concerns. We all know that. Meta research, Meta is, it means Facebook, WhatsApp, Instagram, all of it together, Meta, the org. They say 32% of teen girls who had already felt bad said Instagram made it worse, but we're still there. We're still there on all our social media platforms. In India, with about 250 million adolescents, there are districts where fewer than one psychiatrist serves a population of 100. And where do you think these adolescents are turning for support? Chat GPT. And there is enough research to say that Chat GPT, which is not built for mental health, is being used largely for relationship and mental health conversations, right? It's not built for that. You have to remember that term. It's not built for that. So where do these adolescents turn for support? Increasingly to digital spaces, not just chatbot, but it could be social media platforms like Instagram. And we all know how there are these influencers, come psychologists, not psychologists by qualification, but by the content they produce and they put, and the impact it can have on young minds. Our task then is not only to provide care, but to ensure that these first points of contact, wherever they are first going, wherever they are looking for help on their own, which they think is the right place or their friends tell them is the right place, are places which can be safer, as safe as we can make them. They're evidence-based and they're also trauma-informed. We have to understand AI for adolescent mental health. If we look at just AI, of course, there are promises and perils. What are the promises? We all know. Oh. I really apologize to the online audience. It seems because we were running late and we were in a hurry to start the session, we forgot to share the deck online. Were they also being able to? Okay, I'm hoping that you were able to hear what I said. And you can always reach out to me for the PPT, I can share it. There's no problem. So, there are a lot of promises that the AI and the digital space brings in. Of course, there is most common thing you will hear from any organization that is promoting digital modalities for mental health is bridging access gap, right? We all know there is access gap. More psychiatrists, clinical psychologists in urban areas, fewer in rural areas. And on top of that, there's a limited trade professional capacity that's available in the country for people to access. Multiple other reasons, money, travel, etc., which impact their access. It enables early screening, daily emotional support and resilience building. something which is available at the quick tip of a finger, and you say, am I depressed? Or it says, can you check, do you want to check if you have anxiety? And it's a quick screening that happens, and people can come to know whether they have a certain condition or not. Most of these are not to diagnose, but only to screen. Okay. And offer safe space that reduces stigma. We all know stigma is something that has always been present around acknowledging or being acknowledged with having mental health concerns, and people find it hard to even step out in schools and go to a school counselor's room unless there's a fun group session that's happening, being organized by the counselor. And it can complement a question which I've answered in multiple platforms is, will AI replace humans? The idea is not that at all. The idea is that it will complement existing services and not replace them, given it is artificial intelligence. It will be artificial intelligence. But the key word is when designed safely, when designed with thought. And of course, the perils are, how many of you know the case of Adam Rain, ChatGPT? So there are a couple of, right now ChatGPT is being, and ChatGPT is not the only AI which is being used. Gemini, Claude, all of these are places, but because ChatGPT is more into the news, given that it has 7 litigations right now, active ones that are being kind of fought in the court because of the impact it has had on mental health of people using it, where at least 2 to 3 individuals have lost their life. Because it is safe, because it is anonymous in the mind of individuals who are using it, because the identity, they know that, that nobody can see you, you don't have to put in your real name, you can start talking, but you don't know how and where that data is going. And because it is not trained for mental health, when somebody asked, and just stating that I'm going to talk about a suicidal case, so if there's any concerns, we are all here for you to reach out to. I'm not going to go in details, but what people said, or what one individual asked ChatGPT was, I've lost my job, or I'm not feeling good, I've had a fight with my friend, which is the tallest building in X state in the US. And it actually gave them the name of the state. And then ChatGPT said, no, this is, and then the voice of the specific voices, people voices, advocates in the society, they kind of raised an alarm. There were litigation. They said, okay, we are going to make it safer. We are going to have an advisory board of mental health clinicians, and they will tell us what to do. So what happened was, they are now able to detect if somebody is saying something which is sounding like a high risk scenario. For example, somebody says, I want to harm myself in certain ways, or I'm looking for a rope to do something to myself. It will say, oh, it seems like you're experiencing this. These are the numbers. But if there is another question added still to these statements, for example, I'm not feeling well, I feel like I have to harm myself, where can I find a knife? It will raise an alarm for the first two, and then it will tell you where to find the knife. Right? Why? Again, because it is not written, trained, being governed by clinicians, not trained on data which is meant for mental health. It has access to large amounts of data, in fact, a lot of data. But what it does best is garbage in, garbage out. Sorry, no offense to ChatGPT, but just chunking, clunking data based on information that is being asked and producing that out, right? So there's no clinician oversight. There is bias in inclusion. There is vulnerability risk. Current risk and regulatory requirements are important to understand, because it's not that there are no regulations or no guardrails at all. The regulatory climate is really warming up. In fact, it's most heated at this point in time. In US, both FDA as well as the US government has said that any chatbot company or any product in digital mental health space says that their AI is meant, or their product is meant as a treatment for X mental health concern, unless it is a prescribed digital treatment which is approved by the FDA. Any other in the space, say tomorrow, for example, Visa, the org which I belong to, says it is a therapy chatbot, or you don't need to see a therapist after you start talking to Visa, then it will be considered an offense. And it has been banned in at least 3 states as of today. And FDA has just recently also gotten regulation out that it's going to screen now these apps and platforms very carefully. There's an APA policy guidance on AI and psychology, which says AI must advance population health, reduce inequities with specific informed consent. There are the World Psychiatry Association and mobile health guidance being written as we speak, and I'm a part of the advisory committee where we are trying to create a lot of guardrails and guidelines for clinicians and professionals, because there is a big knowledge gap, right? How many of you have used mental health apps here? Okay. How many of you have recommended mental health apps to your patients or friends? Okay, only one out of the two. And then, and how many of you knew what that mental health app did before you used it or recommended it? All right. So usually when we hear things, we see advertisements. There are a lot of them that pop up on Facebook, on Twitter, on Instagram, and from the look of it, from the hear of it, the minute they claim HIPAA GDPR compliant, HIPAA compliant is a popular term people use. What does it mean to us here in India? What does a HIPAA compliance means? Do we know what HIPAA stands for? But we know it's a compliance. It is a compliance around the data or that the patient is sharing, but it does not have too many pointers around clinical safety. So great, you are HIPAA compliant, but what about your clinical safety? What guardrails, what guidelines have you followed there? Is there a clinician in your team? Those are the questions to ask. So ICMR guidelines for AI and healthcare, which is our very own India guidelines, and a big move that has happened yesterday is that the government of India has taken out AI governance guidebook, which is still broad, not specific to mental health, but it is a good start. And there are gold standards like these which exist. We can always begin from here. And then we can continue to see how we have to adapt it to a country or a geography we are working in which doesn't have guardrails. But it doesn't mean there are no guardrails. A lot of people I've met in the system who have said, but India mein to kuch nahi hai. India doesn't have many guardrails. But there are guardrails, there are guidelines that exist. The ICMR guideline says that mental health applications classified as high ethics risk require human sight. There has to be accountability, there has to be privacy by design. Those are principles we will talk about. Then there is the EU AI Act, which is also released in 23. EU is your European Union. It says high risk mental health AI, if it is high risk, requires human oversight and impact assessment. So what is the impact when it is being used? FENSA is a public, it says if the product is built for public good, conflict-free engagement for global health partners is allowed, but there needs to be strong parameters around who are the population they are being given to, what kind of conversations are they having, what is the use case, what are the claims the product or the app is making, and they have to meet certain standards of care. There are AI uses for adolescent mental health beyond chatbots as well. Largely, our focus is usually chatbots because of the open AI conversations happening globally. It is used for screening and triage, language-based mood and risk screening. It is used for guided self-help. There are a lot of apps that exist, Calm, Headspace, Finch, which is a productivity app, but there are more which help with just you using it for your own productivity and well-being. But is it being used only by people who have just well-being needs, do you think? A lot of people are just using it because the app says either emotional health or mental health, right? So there are people with mental health concerns who could actually be using it. Say, for example, if it's a screening and triage app, where are they triaging it to? Who is the professional at the end? Who is going to then respond to these screenings are important questions to ponder over. There are monitoring and follow-up apps. These are largely used by clinicians or in clinical systems where therapists or hospital systems can set nudges. For example, it's a product being used in de-addiction setup. Then somebody who has just moved out of the recovery or the treatment phase is in recovery can be sent nudges. Hope you're doing good today. How is it going? Have you, and something more motivational around, we hope you did your activity that was, that they have practiced over there. So nudges around, and any relapse flags, for example, there can be many relapse flags. Something could be observed in the way they are using the app. For example, they were using the app twice a day and just twice a day in the entire week, or have they been using every single day of the week? And if every single day of the week drops to 2 days a week, it could be an indicator. something is wrong. Now this person hasn't picked up their phone. These are called digital phenotyping. And then there is the actual content that people may be feeding in where they may say, I'm not doing good. I went back to my smoking today. So those are relapse flags and people can pick up, and these can then be communicated to school counselors, or it can be communicated to their treating physicians. There are many blended interventions as well, where there is an app and it also has therapists on it. So people can use the app, they're doing certain activities, and the reports from those activities are being sent to the clinicians. So clinicians can see how they are performing on those activities, those screenings, and then they can kind of, come in maybe once a week or once a month, whatever the duration that has been agreed upon. Something really important is to understand that trauma-informed design is a must. Adolescents, I just shared in the beginning, right? Adolescents have developing judgment. Their emotional maturity, the limbic system is mature by the time they are between 16 to 18 or 15 to 18, but the prefrontal cortex is still developing at that point in time. So the decision making is where they lack, and which is where the vulnerability lies. So consent must be age appropriate. Who is giving the consent for app use? And the definition of adolescence and child may vary from country to country. In certain countries, it's considered okay, at 13 you can give consent. In certain countries, it is that at 18 you can, give consent. So what is the age of consent? That has to be age appropriate. If not, then some authority like parent or a guardian is that person available to offer consent. Must name limits of AI. For example, a lot of companies or a lot of these organizations that are building these digital mental health apps or AI say human-like empathy, right? You will not miss a human. You will not miss a therapist. So it will feel like you're speaking to your therapist or the AI therapist. These are the terms that have created a lot of controversy and have had negative impact already. So must name the limits. For example, when you log in, it must give this disclosure that I am an AI and I will not be able to help here and I will not be able to help there. For example, on Wisely, if somebody mentions suicidal ideations, they're often the bot responds by saying, I am a bot. What you need most at this point in time is warmth that comes from a human. And then they connect them with a human counselor on the other end, or whether it's a helpline. So that acknowledgement, that disclosure is really important. Safety, so predictable interaction and clear crisis pathways. What happens with, so when we started Visa 10 years ago, and I'm an employee at Visa, I'm not the founder. Many people confuse. I had somebody ask, yeah, what were you doing before you found Visa? But I didn't find Visa. Visa found me. And we have to remember my first job was to write scripts for the chatbot because it was rule based. We had to write what the chatbot would say, every part of the script. OpenAI did not exist 10 years ago when we started with Live. So we knew whatever the person says, the bot will say this. So even if the bot is not really helpful, it will not do any harm. Now, these are the basic principles of biomedical ethics or ethics of medical practice. Do no harm. Even if you're attempting to do good, if it is not good, it should at least not cause any safety risk or any harm. So safety for trauma-informed principles means predictable interaction and clear crisis pathways, trust, honesty about what AI can do and not do, choice, giving adolescents control to pause or stop anytime. That is not given in a lot of these AIs or these products that you see these days. In fact, they're encouraged. There's a lot of gamification where they're encouraged to continue to use. They get stickers, they get medals, they get all sorts of things, which encourages them to continue to use the app, right? There is no option to pause unless the adolescent has this great judgment where they decide, I don't need this app anymore, and they stop. And that is the reason in the past, if you remember the blue whale challenge and all the other kind of these harmful things that were happening on the apps were happening because the individual lacks the decision-making ability or judgment to stop and pull back. They can get pulled in very easily with the kind of, my daughter speaks to character AI. Character AI recently, and she's 13 years old. She signed up for it when she was 11, she ticked 13. It's as easy. That's the risk, right? If you know how to read the language in which the terms and conditions are, and you can see easy check boxes, it's as easy as that. No parental consent needed. You just click 13. And she's building stories with character.ai, and it is great, but also some of the stories were a little risky when I read through them. And this is what happens when, children have access to these. And I agree with some previous speakers who were saying that children may tell you that they are doing their homework, given so much is online these days, right? You don't know what window they have opened, what site they are accessing. So, as parents or as psychologists or as just community members, literacy is very important. And the first thing I did with her and some of her classmates who visited our home was to talk about these things in a general way, to tell them how harmful all of these things could be, and where to stop and where to bring in your parents, and where to confide. If not parents, maybe school teachers, anyone else. Collaboration, co-designing with young users. Who is the app meant for? Who is the user? I am designing an app thinking the clinician needs to see this report, but I am not concerned about what the patient would go through when they will see this 100 worded terms and condition or privacy policy. Will they go through it? Are they literate enough to read? Are they able to use the devices well? But I've created something and just given it to them. Now use it, right? That is why so many scams also happened initially when Paytms and all GPays and all of these things were launched, and we flooded the planes with these. Everybody has to use it now in some way because this is the demand. Now you have to use it. But did they really know how to use it? Were the literacy campaigns around how to get them to be aware about how to use these digital things? Similarly, for our mental health apps and services. Empowerment, building confidence and coping skill and not dependence. A big worry that is always there is, will my child get dependent on your app? Will my child be using it? Oh, another app. So when we have worked with governments and we went to the government and shared our app, and they say, oh, we don't want another app. Can this be something else? Because children are anyways on phone most of the day, so this is another one. So is this app built for dependence, or is this app only going to do limited certain amount of conversation which is required at that point in particular time? It should be empowering and not kind of getting individuals, users to get dependent. Replica, how many of you have heard of Replica? Have you heard of Replica? So Replica was an app which was built outside of India, and it encouraged users to talk to it continuously. Again, like I said, rewarded. There was a lot of gamification to a level where it started having romantic relationships with the user. Now imagine if this user is a 13-year-old or a 14-year-old, right? So you can imagine the risk. So when we talk about strategy, we usually adopt a 4-pillar approach, and you would have understood it in various ways from so far what I have talked. Basic 4-pillar approaches: prevention and literacy. You integrate emotional and AI literacy into school curriculums or in community conversations that we have via different programs. Equip young people to understand technology, emotions, and help seeking. Early identification, use AI tools for validated age appropriate screening to flag distress early, because this is a fantastic tool that we have at our hands. You don't need a professional to go and do it. If done in the right way, AI can very quickly pick up high risk scenarios and quickly do screenings. When it comes to population level, 3 people, 4 people, 5 people I can see in my clinic, 10 people I can see in my clinic, and over a period of time, maybe 100 in a month. But and this is something that motivated me to enter the digital mental health space, is because I can reach to many millions at the same time with the same tool without tweaking it much. When it comes to something like a screening, you put a PhD and a G87, 1 million people can do it at the same time. That's the power of AI. But when delivered safely and in a thoughtfully devised way. Workforce and practice, we can train teachers, counselors, and community well-being workers in blended trauma-informed care using AI tools responsibly. We know we cannot be everywhere, but there are champions in the communities like ASHA workers, postmen, retired school teachers who are anyways doing a lot of other things like polio vaccines and election duties and all of that. But we could identify them or some other individuals who could then who could be trained and then taking these screenings in rural areas and getting them completed, or using them to create AI literacy, or using them to actually help individuals do practice some tools on AI to build their emotional resilience. Governance and procurement, ensure all tools meet ethical and technical standards set by so far APA, WPA, and ICMR. System level strategy where AI fits, like I said, in prevention, in detection, in response, and in recovery. It can actually fit in all these stages. And this is a recent, like something I can share from my example is, and I'll put the user problem as it's a rural area. Young girls, tribal families, they don't have access to phones. Phone is owned by maybe the father or the mother, or mostly the father, the male in the family has the phone. They don't want to give it to their children for long. Again, the fear is building dependence of who they will talk to and what apps will they use. And they said that we can bring something like this in, but it cannot be an app. So we got down, uh, sat with the girls, the young children who we were going to work with. We did co-design sessions. We asked them कि अगर कुछ ऐसा हो तो वो कैसा होगा तुम्हारे लिए, कैसे उसको तुम इस्तेमाल करोगे, वो तुमको क्या सिखाएगा, क्या सीखना चाहते हो. We had some mock-ups from what WISA already does in terms of some tools and techniques, mindfulness, sleep tools, CBT, reframing tools, self-compassion activities. And they selected a few, and we understood that they wanted to do less of mindfulness. Of course, it's boring. Who wants to do it? You have to sit for a long time. But can we tweak it to shorter mindfulness sessions? And kids loved it. Why? Because it was giving them a break from their whatever routines they were into. And we designed these activities with them. And multiple iterations have happened since then. And we created this workbook, which we called Dream Kit. And it has a QR code on each of its page, the worksheets. And kids are able to now, without having an app, school, do it in school, the workbook piece. Our team of community psychologists, currently we run that operations as well. We train these community psychologists and community well-being workers who are from the communities and not psychologists. But community psychologists are psychologists, well-being workers are from the communities, young people who are willing to volunteer or retired professionals. And to have more sustainability in the system because it's expensive. Psychologists cannot visit every day. They can visit once a month. And they combine, in a combined effort, they have taken this to the village. The girls are using it. They're scanning the QR code. And what is in the QR code? What happens when they scan the QR code? They are taken to a widget or a browser setting where whatever activity is there on the worksheet, they can practice it with the AI on the browser. Nobody minding it anymore. The stigma is still taken away. Yes, it is not a mental health conversation they are having with a bot, but there is some support, some skilling, some learning that is happening in that particular way. So sometimes to be in the systems, to work safely, we may compromise on the some aspects of what product would be an ideal product for you. Maybe when one day 5G reaches villages and everybody has a phone and there's less stigma and more trust building efforts from both sides, the organization and the community stakeholders, it could be a chatbot that could be given to these young girls. But today this is working beautifully. And we've almost reached 20,000 girls with this. So implementation pathway, add AI safety plus adolescent mental health modules, use WHA AI for health principles, youth onboarding, disclose limits and privacy clearly, monitor harms, keep away from unsafe advice, design AI with adolescents, not just for them. And yeah, that's it. Evaluate the impact, not by usage, but by well-being. Does the intervention make adolescents feel safer, more empowered, and more heard? Is the question that we all need to answer before we introduce something to them for their mental health via digital mental health platforms. Thank you.
Thank you, Dr. Smriti. Very well elaborated. I think this is a topic which we can keep deliberating on. Thank you. It was very well explained. If there are any questions, I think we can take one or two questions quickly. I feel when we look at human intelligence and artificial intelligence also is there here to stay. So as much as it helps, it also has its boon and the ban. Yes. Any questions? Can the mic be passed on?
I just have one comment. So I just heard of a company called Mercor, and they have started recruiting specialists, so psychotherapists, psychologists, and they are feeding the information. They're helping them to feed the information into, the AI systems, so that way the AI can become more intelligent. So I don't know. I mean, if there is any information or update into the awareness regarding to such companies who are recruiting specialists.
So it is a very it's not nascent anymore, I would say. It's a new field, but it's a very rapidly growing field. It's a great job market opportunity for psychologists. You must learn and get trained and build your understandings in how these things work. It is really important to question these people as to how are you going to use the information that you're taking from us. What is the kind of information they're taking from the specialists is a thing to know. So if they're only asking you to write down CBT scripts like modules, that is fine. It's available in public space, right? But if they're asking you to feed information from your, say, conversations with your patients. So what has happened is a lot of times people are selling their own therapy data to these third party providers, and they are using those third party that data to train their models. Did we take consent from the patients? Did we ask the users that this is how I'm going to use the conversations? So those are things that you need to kind of look into. Where is the data being stored? Is it on, is it with a third party? How are they using it? Whose data is it? If it's as simple as just clinical modules, as psychotherapists, that's great. If there are mock sessions where you're simulating a mock session with somebody else as a patient and a therapist, it's still fine. So I think those are some things that you would need to be aware of.
Thanks, Smriti ma'am. Thank you for the session. I just wanted to ask that in this economy, I'm seeing a lot of psychotherapists, psychologists going into more and more of their private practice. And I can see a trend of companies building up a online therapist client interface to manage information, session booking, journaling, and whatnot. Everything will be online, and they are providing that to the therapist as a subscription, and the therapist can use it for all the information. However, there is a lack of, I am feeling that there is a lack of proper training programs around the maintaining the data confidentiality on such kind of, as you answered in the previous question also. So maybe you could provide some resources into that. I mean, how can a person be more adequately trained into maintaining data confidentiality on such interfaces when you're thinking of building one or subscribing into one, working with someone who's building a program like that or something?
I think the most basic course that you could do on it is on information security management and privacy management. I was lucky enough to get an insight into it via my org because we're ISO certified. And ISO does this elaborate audit every year for us, check all our platforms, all our documents, who has access to it. Even if it's a presentation that I have made and if it's on my Google Drive, on my associated with my company Gmail, it will be tagged confidential, and there has to be, we have to see who is it being shared with. So shared access, who all have access to it, right? And why do they have access to it is a reason. So for example, if your therapy software that you're using has the data stored somewhere, all that data, who all have access to it and why, right? For example, I have access to conversations that are happening on my platform because I do quality analysis and quality checks. So I need to see if my therapists are following certain protocols. I need to see. So I have set those permissions like that only two people will have access because they're doing QA checks, not everybody else. Otherwise, each therapist has access to their own data. What will happen when you leave the system? What will happen to that data? How are they going to use it? Will it get deleted? Will the patient still stay? Ultimately, the data rights should reside with the patient. Now, this is something that GDPR, the regulations that are there in the UK, says the owner of the data is the patient or the client, So for example, on Visa, if you click reset my data, all your data goes, nothing stays on the server. So all of these things are something that you could learn. There are free courses on HIPAA, on information security and privacy management, which is available on Cybrary and some other platforms, YouTube, etc. Shorter courses be available, and there are small short courses as well. You could do these to get just a basic insight into what kind of questions you have to ask, or if you're building your own, then what do you have to keep in mind. We cannot be perfect from day one. There will be some compromises, and we all know there are some risks that cannot be foolproof. But we should be able to list the risks, and we should be able to see which risks are tolerable and which are not. For example, I'm okay with my bot to break and say, I can't help. But I'm not okay with it saying jump from that building which is next door or next to that, right? So what is the risk I'm willing to take, and what is the risk I can't tolerate?
Thank you so much for such an insightful session, Smriti ma'am. I now would request Kritipai ma'am to, Dr. Kritipai, to felicitate Smriti ma'am with a token of gratitude, please. Can you come in front so that the photographs are nicer? Please be in front. Thank you so much. Can I request Dr. Deepika Srivastav ma'am to come and felicitate our chairperson for the session, Dr. Kirti Pai? And then I'll request her to stay for her session also. Thank you so much. Now I request Dr. Deepika Srivastav and Ms. Preeti Pandey to come on the stage for their lecture on trauma healing through relationship attachment informed approaches in psychotherapy. And I graciously welcome Dr. Chinu ma'am to come and chair the session along with Dr. Smriti Joshi ma'am for the chair of the session. Can I request both the chairpersons to kindly be on the stage? Yeah. So we've been kind of, circulating the CRE forms and the feedback forms, question forms. Also, kindly keep filling them as they are shared in the participant group. I request all the participants to keep a track of that. To share our chairperson, ma'am, Dr. Chinu Agarwal, psychologist, psychotherapist, director of Feeling and Mind, trustee, HEMA Foundation, research head as well. Ma'am is director and adolescent mental health, Wheels Global Foundation USA, professor at Department of Psychology, SAM Global University, Bhopal, as well as founder president of Indian International Society for Mental Health Advocacy and Action. Ma'am is international affiliate member of American Psychological Association, internationally listed as ECT therapist, and many more accolades to ma'am's name. To name, just for name few, she's also Gottman licensed assessor and other associations, life members, and prominent associations life member. Ma'am's experience ranges from being a researcher to writer to TED speaker to being a trustee of and research head of NGOs versus being a founder president of an association that is involved in mental health advocacy. Also, the interest lies in advocacy, strengthening organization, and corporate mental health work, also, along with promoting child and mental health, adolescents' well being. And men's mental health. Later, we are going to hear from ma'am on men's mental health, a topic that's not been talked much about. As well as ma'am has received various leadership awards along with other awards that have been there. If I start naming them, I would be using a lot of time. We welcome you, ma'am, with us. Thank you. A big round of applause for ma'am, please. And our other chairperson, I have already shared few minutes ago, but just to do the honors again, Ms. Smriti Joshi, ma'am, the international chief clinical psychologist at WISA, vice president, Council of India. And her interest, I think she gave a wonderful talk on adolescent mental health and AI. So we all know where digital mental health revolutions are going to come in India from. We welcome you, ma'am, as well. Now I request Dr. Deepika Srivastava, ma'am, who is assistant professor at IBHAS with many years of experience as well as numerous publications, to take over the session. We welcome Ms. Priti Pandey as well. Dr. Deepika.
Good afternoon, dear delegates. I'm Dr. Deepika Srivastava. Me and Ms. P.D. Pandey will be talking about individual and collective trauma in the relationship. So we'll be discussing attachment. We also will be discussing types of trauma and what all the therapeutic interventions those are applicable in this process. So presentation, we would like to start with the introduction and the process of trauma. How does it affect oneself and how does it convert into the psychopathology? And then what is the process involved in the psychotherapeutic relationship? So the topic will be started with Ms. Preeti Pandey. Hello, everyone. So, as the topic says, individual and collective trauma in relationship, healing through attachment-informed psychotherapeutic practices. Second part is going to be about psychotherapeutic practices. First part is going to be all about introducing trauma, about introducing attachment, what happens when there is an attachment rupture, and the clients, or I mean, in general, whenever there is an attachment ruptures, how is it shown in someone's personality? So a very simple definition by the APA dictionary of trauma: any disturbing experience that results in significant fear, helplessness, dissociation, confusion, or other disruptive feelings. It is intense enough to have a long-lasting negative effect on on person's attitudes, behaviors, and other aspects of functioning. So, when we are saying trauma, so if like we are humans and every single day we go through different experiences,
there are some good experiences and then there are some bad experiences. Not every single bad experience can be called trauma. Only that experience where there was significant fear, helplessness, dissociation. It's like a disintegration happened. Disintegration maybe between emotion and body sensation, disintegration between thought and emotion, or everything led to confusion and other disruptive feelings. So, if there is an experience and one had to go through such psychological processes, then we will term it trauma. Understanding trauma beyond the event. So, this is a wonderful statement by Dr. Gabor Mate, where he says trauma is not what happens to you. Trauma is what happens inside you as a result of what happened to you. So again, it's not the event itself. It's what happened within me because of that event. Again, trauma can be acute. It's a one time, a big T. It can be it's a single yet overwhelming incident. It can be an accident or any other experience where which was too much for a person. It can be chronic or also called complex. So, if there has been a prolonged exposure to a certain difficult experience, then it becomes chronic in nature. For example, so when we talk about chronic trauma, it's like small paper cuts. It's not just one cut. Every single day or like for a longer time, there were so many paper cuts that it really bleeds. It really pains us. And most of the time, it's seen in relations. That is why relational exposure. So, what does it do to us? Or when we say relational, it occurs within relations. For example, a child has to, in his relationship, a child is seeing a lot of neglect, not once or twice, but has been seeing neglect for like years. So it becomes a part of the child personality, and that is its relational. It's cumulative. It's again, it builds over time. It's not a one-time event, and it's developmental. But like it's like a trauma can happen at any time of a life. But if it is happening in our childhood, then it has a developmental connotation too, which would mean that it affects our emotional as well as psychological growth. And why I wanted to focus more on the relational aspect here. So imagine, and because we are talking about attachment, so imagine a person already has a insecure attachment style. We'll be talking about insecure, attachment styles later on. But just to give an idea, imagine a person is already having an insecure attachment style, which would mean that they might not be able to trust the world. They might not be able to have full confidence in their own selves. Imagine that person has to go through a troublesome experience, and now, because there were already seeds of attachment ruptures, or maybe like the kind of attachment processes which have already built, because of that, that will become a risk factor for that person to be more vulnerable for seeing it as like experiencing it as a traumatic experience. At the same time, if there is a human being or a child who is going through like back to back experiences of again neglect or abuse or anything which is confused and creating or threatening for that individual, this percolates in each and every part of the relationship, not just as a child, but like when they are adults, in different relationships, in their career choices, everywhere. So it's again like a circle. Individual trauma and development, like chronic trauma coming together. Now, let's talk about individual and collectivistic trauma. Individual trauma, it's the single person is going through that experience, it's personal experiences of threat, loss, or violation. When we talk about collectivistic trauma, it's like it's community going through the similar threatening experience. It can be war, displacement, pandemics,
anything, again, when there's a group of people going through the same experience, both have common threats: loss of safety, power, and control. Both save the collective psyche and individual experience of self and others. So now coming to, the main heading of our today's presentation, which is attachment. And again, how attachment is linked to trauma, how they further shape someone's personality. So what is attachment? Then we'll be talking about types of attachment, what early ruptures do to an individual, then how do early relational ruptures shape the internal world and increase vulnerable to trauma in later life. So three definitions. First, attachment is a lasting psychological connectedness between human beings. By Ainsworth, it is attachment refers to an affectional tie that one person forms to another specific person, binding them together in space and enduring over time. And then the last, which seems to be more comprehensive than the other two, attachment is a behavioral and emotional system that promotes safety, security, regulation through close relationships with others. And in my words, attachment is like a survival strategy. So it's like when we were born, and again, we were born in a world where we are trying to find our own safety. So our caregivers become our first line of safety. Okay, so when we are hungry, when we are, going through anything that is difficult as an experience, we tend to move towards a caregiver. So that survival instinct is attachment. Let's talk about the types of attachment. So that two main type of attachment. One is the secure one, and one is the insecure one. The other one is the insecure one. Again, secure one would mean that we are comfortable with intimacy and autonomy. So let me talk about secure attachment in there. So imagine there is again a child who is with their caregivers, and they know that their caregiver is going to be there to protect them, to take care of them when they are in distress. At the same time, because they are knowing they have that confidence in their caregiver, they are free to experience their environment. So they won't cling to them. They won't feel as if there is no one and they have to look after themselves. It's like they're independent, they're enjoying, yet they know whenever they are going to be in distress, their caregiver will be there. Coming to the insecure attachment, there are three kinds. One is the dismissive avoidant, second is the preoccupied, and third is the fearful avoidant. Let's talk about preoccupied attachment first. In the presentation, is the second in the yellow boxes. Preoccupied would mean that they cling to others, they fear rejection. So now going to the same kid again. That kid doesn't fear their caregiver, but they're not sure whether their presence is going to be consistent in their life or not. There may be the caregiver, they need them and their caregivers are there. But then there are times when they need their caregivers, but they are not there. So it creates a lot of confusion. At the same time, it creates anxiety. And that is why they want to cling on to their caregivers, and they would want to do anything which could mean that their caregivers are not going to leave them. So this is how a preoccupied attachment is formed. Let's talk about the dismissive avoidant. So as it says, dismissive and avoidant. So taking to the same scenario again, the caregiver, the child has learned very early in life that nobody is going to protect you. You have to protect your own self, or nobody is going to take care of your emotions. It is completely on you. And again, in such children have been somehow scolded for showing their emotions. And when they were kind of stoic, when they were when outside, words thought that they are so courageous and they are able to take care of themselves, it was rewarded. As a result of which, this kid learned that it's good to keep my emotions to myself, because this is the only way I can survive or I will be regarded, which ultimately leads to an emotionally distant, a person who values independence a lot. And so you know what the research says, even if these people do not show their emotions, but they still have similar kind of physiological arousal within them, which would mean that imagine inside it's complete physiological arousal going, but outside nobody knows what's going within them. Coming to the next, which is so there's one more, which is the fearful avoidant. The fearful avoidant kind of, again, taking to the same scenario, it's like caregivers are the one who have to protect us. But imagine if the same giver, caregiver becomes the object of threat or humiliation. Now there is kind of an approach avoidance conflict that happens, which says that I want to go there, but it's threatening, which ultimately creates a lot of confusion and ultimately results in the disorganized attachment style. Impact of early ruptures. So imagine if early ruptures are happened, what would happen? The inconsistent, neglectful, frightening patterns are going to lead to insecure attachment style. And attachment is like a stress regulator. So imagine if someone had an insecure attachment style, then stress regulation is going to be very, very difficult. So it's going to, they may have intense emotions, they may have poor impulse control, they may get numb at times, they fear intimacy, they fear abandonment. If it is an avoidant one, he would say, I must not need anything. And the clinging one, the preoccupied one, would say, I must hold on to survive. And then they have the internal working models like I'm unworthy, I'm unsafe. And again, the point to note here is, and again, what attachment based psychotherapeutic practice say, it's not psychopathology. It actually is a survival strategy. It's a behavior which actually, or this is a response which actually helped them to survive this world, this dangerous world. Somehow now they have grown up, but the nervous system still behaves the same way. So this is a case vignette in which there is this girl who is okay. So skipping that case vignette for now. So let's talk about the kind of assessment which should be done when we are trying to figure out things from an attachment informed lens. It should be about exploring their attachment histories, their relationship patterns, their early caregiver dynamics, attachment ruptures with their experiences. So, for example, if our client comes to us, we are not just going to ask them about their symptoms and in their life in general. We'll ask them more about, so the things that come in the personal history part, the family history part. If they were in distress, who would they like to go to? We would ask them particularly about their relationship with their father, their mother, and not just a simple question about their relation. We might ask them about examples from their childhood, about how would their father behave, how would their mother behave with them, how would their siblings behave with them, etc., etc. And we have to identify defenses like avoidance, mistrust, dependency, understand how protective strategies develop to maintain safety and control. So view symptoms and adaptive responses to relational wounds, because again, if the person has fear of abandonment, if they are hopping relationship, it is coming, it's like a survival strategy for them. Maybe they cannot trust someone. For them, dating a stranger, maybe stretching for just few days is more safe than being in the same relation for years, because then the fear of judgment, fear of being rejected, fear of abandonment, all that sweeps in. Better is to hop. Step from what's wrong with you to what happened to you. Okay, so what happened to you because of which these strategies are Dr. Deepika will be talking about the intervention part, so let's leave it to her. The final words, trauma occurs within relationships, healing must also occur within relationship. Yeah, because relationships were the reasons behind this trauma. It means that uh, healing should also be like the mechanism behind healing should also be in relationships. Therapeutic relationship offers safety for re-experiencing trust. Healing is not about erasing the past. It is about creating new relational experiences of safety. Trauma reshapes self, emotion, and connection. Early attachment disruptions amplify vulnerability. Healing happens through safety, attunement, and repair. The therapist's presence becomes the secure base for integration. So, what was broken in connection must be healed in connection. So, with this, I would like to end my presentation here. And I would request Deepika ma'am to please come and continue from here.
Thank you, Preeti Pandey, for enlightening us about the trauma and types of trauma. Let us understand the mechanism of therapeutic process in relation with the trauma and attachment. So, all of us are mental health professionals, and the moment we are with our client, we go into the deep process. And this deep process is quite sensitive as well as very important because we are dealing with a human being and we are dealing with the deep level emotional processing which affect their cognitions as well as their interpersonal relations. So, what comes when we are sitting in the therapeutic sessions, when we are starting the therapeutic process? So, as we understand that trauma is basically a disconnection from safety and attunement. So, every time there is a threat, every time there is a danger, and the re-experiencing with the painful emotions is really very difficult and quite problematic for an individual, right? So, what is the first job and role of a clinical psychologist when a client is coming to them? Obviously, the bond with your patient. Now, this bond, why is this bond important? Because the healing starts from the first meeting and the connection should be quite strong enough so that your client will feel safe. So, what all the processes involved in this? When I'm talking about the relational healing is a connection between therapeutic relationship, which is the foundation of healing, and it takes to us to healing through lived experiencing. Because when I am meeting you and when you are meeting me, we are somewhere communicating to each other. And I have some prior experiences. And all those prior experiences are giving me certain kind of feelings. And the moment I am experiencing or I am thinking that I am being judged, then what happens? Then somewhere connection gets broken. So here a therapist has to take to a point, therapist has to be mindful that therapeutic bond should be, it should go in a positive manner. Yeah. So this therapeutic bond is not only psychological, somewhere connection goes into our neurons as well. So somewhere chemicals also responds. As we all know that psychotherapy does affect on our brain. Hence, mind-body connection occur. So mind-body connection is not only important in other psychopathology. In trauma, it plays the main role. So therapist works like a prefrontal cortex in the therapeutic situation. Why? Because an individual is sharing their experience with you, an individual is expressing themselves to you, and you are somewhere being a receptor. And you're somewhere giving the feeling that the individual is being accepted in a non judgmental environment. Hence, they experience the feeling of being safe. Hence, the safe environment is being created.
And the moment safe environment is being created, obviously your brain is also working in a protected manner and it is giving you the feeling of safety. Therefore, the nurturance feelings come up. Right. So, as we all of us are aware about the attachment, the internal working model of attachment comes into the picture when we are dealing with the traumatic experiences, right? So, it talks about unconscious relational blueprints that shape our perception, our intimacy, our relationship, our separation, and trust throughout the life. Because most of you must have experienced the moment they are sitting with a client who has gone through traumatic experiences, the most difficult part for them to deal with interpersonal relationship. And why? Internal working model comes into the picture over here. So what to do about it? How the journey should begin, how the journey of healing should begin, and what all domains should come in between so that the healing journey can be completed. So it's a long way process. Now, let us understand the domains those comes in between the therapeutic bond and how does it make it a secure base. So it helps us to establish the consistency. How? By building the relationship. Then it also offers empathy, right? And then it helps us to attune to emotion. And the moment you are getting attuned to the emotion, it works on the internalization because internalization is the main domain that deal with the psychopathology, right? So the moment client is experiencing safeness in the environment, the painful emotions get a shield, right? An individual is experiencing painful emotions, but the effect of that painful emotions are not being externalized, right? So then what happened? Emotional risk comes in between and client develops new pattern of response. So I don't have much time, so I'm gonna skip this slide. I'll just summarize this thing so that all of us get the understanding how the process takes place during the therapy session. So what do we need to keep in our mind when we are sitting with our client? Obviously they are coming with some perspectives, and perspectives is what their unresolved emotional situation. So they are having expectations to get safe environment wherein they are again re-experiencing. And what does therapist do? Therapists respond with empathy, hence safely trust and connection grow. And then it works on the affective regulation as well as the emotional integration part. I'm going to skip the case weakness. So I'm just going to talk about the rupture and repair. So rupture is something that has been broken, right? And from rupture to repair, so many things come in between. But the gist of this process is we deal with the fear of abandonment and trust to build the resilience so that tolerance can build up and trust in the relationship can take place. So these are the some techniques. I'm just going to summarize these techniques because of the limitation of the time. The first point is reflective dialogue. Second one is naming dynamics. Then the goal of these two techniques over here is to transform implicit relational memory through lived safe connection. When I'm talking about the implicit relational memory, that means what? You are re-experiencing the traumatic uh, memory, the traumatic experience. Here again, you have it in your memory, you are memorizing it again and again. And when you are memorizing it again and again, then what is happening? Then psychopathology somewhere increasing. So a break has to be there. But how to use this break, and when this break is coming, how to go ahead? This is very sensitive part, and here therapist has to be very mindful. So what does it do? It helps us to promote self-awareness and emotional regulation. It helps to enhance the secure attachment as well.
Now the naming dynamics. What is the naming dynamics? Basically to put words into the underlying emotional and therapeutic encounter. Yeah. So these are some of the techniques, some of the therapeutic approaches, those I'm just going to summarize, I'm not going to go into the detail. Emotionally focused therapy, all of us are aware, it works on the emotional regulation. Internal family system therapy, it works on the system, that family is a part of the system, and broken parts has to be joined in a collective manner. So therapy works from that perspective. Attachment focused EMDR, obviously, it works tremendously on such population. And again, the relationship is it has to be strong. And these are some types of therapy, those are divided into 4 domains, and all of us are aware about it. Later on, we can discuss in detail after the presentation is over. Thank you so much.
Thank you so much. Due to paucity of time, we are not going to be taking questions. We are just going to take one concluding remarks from the chairperson, and then we'll conclude this session because we would like to start the next session on time, and we are already running late actually. So, just one concluding remark, please.
Congratulations, Dr. Preeti Pandey and Dr. Deepika Srivastav. It was a very informative and a fantastic presentation from both of you. I would not even call it a symposium. It was a mini workshop in itself where you covered the whole range of what is trauma, and in detail you covered the psychopathology of trauma and also went up to the interventions. I have only one reservation that let's not or be cautious while using quoting people like Gabermate in our presentations, because when there are students sitting, they might feel that it is evidence based while it is not. So, a little reservation over there. Thank you so much.
Congratulations and thank you for this beautiful, very informative and insightful talk from both of you. I think I agree with ma'am. It was a little more than the symposium. We learned quite a bit. For me, I think I was revisiting it academically after many years. So I learned quite a lot, and I'm just thinking in my mind how it fits well with the trauma-informed principles I was talking earlier with regards to even how we have to be so careful when we are presenting artificial intelligence based agents to assist individuals with their mental health, and how we have to be careful of the boundaries. Because, like, what I'm taking away is that relationship is not the vehicle for therapy. It is therapy which is really leading to it. So it is a very sanct space and needs to be dealt that way. So thank you so much.
Thank you so much. I would request both the chairperson to felicitate our speakers. Momentos, please. Can you please come forward for a photograph? And I'll request Dr. Bhavna to felicitate both the chairperson with a token of gratitude from our end for taking out time. Please. The tea is served, so would request everyone to kindly return back as quickly as possible. We're going to start the session in 5 minutes. A big round of applause and thank you to both the chairperson and the speakers. Uh, Kindly return back within 10 minutes. We are going to start within 10 minutes.
A very good evening to all of you here. Now we have an invited lecture by Dr. Reenu Agrawal ma'am on the topic men's mental health. And I would like to introduce Dr. Reenu Agrawal as psychologist and a psychotherapist. She's the director of Feeling Minds, and she's a trustee and research head of HEMA Foundation. She has been the director of Adolescent Mental Health, Wheels Global Foundation, USA. Ma'am has been Professor Department of Psychology, SAM Global University, Bhopal, founder president of International Society of Mental Health Advocacy and Action. She's been affiliated to international affiliate of APA, American Psychological Association, internationally listed ACT therapist, and a professional international membership of the prestigious Association of Contextual Behavioral Sciences. Ma'am, I request you to please join the dais for your topic, men's mental health. Please give a round of applause for ma'am. The chairperson for the invited lecture session for Chino Agrawal ma'am is Dr. Sunil Mittal, sir. We welcome you, sir. And sir, the information about sir is that sir is the consultant psychiatrist and a psychotherapist. Sir has been the chairperson of Cosmos Institute of Mental Health and Behavioral Sciences. Sir has been a secretary in Caring Foundation, NGO for Health, Education and Community Empowerment. He has been the vice president of World Federation for Mental Health. He's been the president of Indian Association of Biological Psychiatry, co-founder and past president of Indian Association of Private Psychiatry. There has been an expert member on various committees in the government, non-government organization, and international multilateral agencies on clinical research policy matters. There has been a former national consultant at ILO. There has been a principal investigator over 30 major studies founded by ASP, UNODC, ILO, and Government of India. Sir's work includes cognitive science, neuromodulation, addiction, bipolar disorder, OCD, innovative models of service delivery, mental health advocacy, policy, technology, and AI. Sir has conducted and presented more than 600 CME papers, workshops, and lectures, and he has received numerous awards. Engaged with print and electronic media, theatre, TV, OTT, and mainstream Indian cinema, and he has been an award-winning photographer and author. I really welcome you, sir, on the dais. And the second chairperson with us is Dr. S.K. Srivastava, sir. And bio. Okay. Yeah. And to introduce sir, sir has been a mentor to ABBA's departments and has been senior director, vice president or AFTD, and advisor to FPO. Sir is the area of interest prominently lies in the area of disability. Sir has been the member secretary of RCI and a well-known figure in the country in the area of disability. And he has spent his entire career of more than 35 years on various senior positions in this field. We welcome you, sir. And I request Chinu ma'am to please start up with her presentation.
Thank you so much. It's a great privilege to be presenting a topic which is very close to my heart, that is men's mental health, and doing it in the presence of two chairmen. And we never mention, but I have two very important men in my life sitting over here, my husband and my son. So, friends, if you have come to this auditorium right now to slide on your chairs and enjoy the air conditioner for a while, you'll not be able to do it during this 1 hour. I request all of you who are sitting back in the chairs to please come forward, because we are going to have an interactive session and not just a presentation. Because I have been an advocate of experiential learning, and my PhD research has been on an experiential learning. I'm a proud student of Dr. David Polk, who gave the world the theory of experiential learning and who said, थिएट्रिकल लर्निंग जैसे अभी हम लोग बैठे हैं, एक थिएटर बना हुआ है, ऊपर बालकनी भी बनी हुई है, मुझे दिख रही है, where the presenter is supposed to know everything. जब क्लास में टीचर आती है, we expect the teacher knows everything, and the children are just passive recipients of some information and knowledge. And the teacher comes and says, बच्चों आज हम मेंस मेंटल हेल्थ पढ़ेंगे, एंड बच्चे आंख बंद करके सो जाते हैं. कभी कभी बच्चे आंख बंद करके नहीं सोते, आंखें खुली रख के जब भी टीचर उनकी तरफ देखते तो जोर जोर से मुंडी हिलाने लगता है. But they are mentally absent from the class. Friends, experiential learning tells us that if you really want to gain anything from any talk, any lecture, you have to be involved as a learner. And if the learner is looking at their mobile phones, I don't think learning can happen. So to begin with, I want to ask one question to all of you. Do you think that this topic is relevant? How many of you think that this topic is relevant? Please raise your hands. So most of you think that this topic is relevant. Now the next question is, why do you think that this topic is relevant? Anyone? क्या जरूरत पड़ी हमें इस कॉन्फ्रेंस में 1 घंटा इस टॉपिक के लिए डिवोट करने के लिए? And why are we selectively talking about men's mental health? Why not mental health in general? Men's mental health की टॉपिक की छेड़ने की क्या जरूरत पड़ी? Anyone? Yeah. Ma'am, yes? Gender differences are there. Do you know, my dear friends, the NCRB data on suicide gives us an important insight and a very, very startling one, that 74.29% of all deaths by suicide in our country are by men. And this ratio is almost the same worldwide. And so, this is not just any fancy topic that we are talking about. This is the need of the hour. And we, being mental health professionals, must talk about men's mental health if we want to talk about suicide prevention. Because they are the ones who are dying by suicide. And now, my next question to all of you. Why do you think that this gender difference exists? And why do you think that men's mental health is taking a beating? Not only in our country, but the world over. Why? Can we have the mic, please?
The social construct and the expectations from men.
Very good. Exactly so. The social constructs, the stereotyping, the cultural conditioning. What is the cultural conditioning and the stereotyping telling us? What is it telling us? Yes, Simran.
Men are supposed to be strong.
Men are supposed to be strong.
Men don't cry.
Men don't cry. Yeah. And who's telling us this?
The population, obviously, but I differ slightly because we want to put men in a box nowadays. चाहे वो कोई भी extreme perspective से क्यों ना आए. कि why do we want to see men cry in the first place? I would ask the question. Why do I want him not to smile? Yeah. Why do I want not him to share emotions? That's it. Why cry?
Probably they want to say that men don't show their vulnerability. That's the emotion that they want to express when they say men don't cry. And that's the expression which also tells us that boys were told in their boyhood, अरे लड़का होके रोता है, तुम कोई लड़की थोड़ी ना हो. You know, that's not just about the behavior of crying. That's telling a lot of many other things. What are we telling boys when we tell them this? Anyone? That you are not allowed to show your weaknesses and vulnerability. But there is one emotion that is allowed for men. And what is that? Anger. You can be irritable. You can be angry. You can throw things around. You can shout. So, they show that what they are allowed to. And they hide what they are not allowed to. So, friends, what happens when your father or your brother or your partner or your friend or your son is going through low mood? What do they do? What behaviors do you see? She wants to say. Yeah.
So what I have seen is that they close off. Even if you try to talk, they are like, "नहीं बात करनी है बारे में. It's okay, I'll be fine."
Yeah.
All these behaviors. So they basically shut themselves down.
Correct. And she wants to say something. She wants.
I think maybe suppression of emotions.
Yeah. And they'll go and hit the gym maybe. Or they'll go and do something which boys are allowed to do. And so, my dear friends, now researchers recognizing that men report distress differently. And there is something called as masked depression and male salient features in mental health issues, where we are not able to see the features or the classical symptoms that are written down in ICD or DSM, and they report them differently. So what are the masculinity pressures that they feel? They want to conform to the traditional masculine norms, which are self-reliance. Don't share your troubles with everyone. Emotional control or stoicism, they are taught that, अपना किसी को कमजोरी नहीं बताने का है. And also, you have to be tough. You have to be brave. You are a boy. Which research is saying actually predicts poorer mental health in them. And what do they do to cope? Substance abuse. A cigarette in my hand, I feel like a man. And go and bottoms up. That's the way to cope that they have found out. So a man who is able to hold his flowers, his claws, and they have found glory and glamour in substance abuse, but that's how they cope. Also, self-stigma, where they stigmatize themselves if they are, and what the lady wanted to say about crying is, even if they find a person to go and share their troubles with, and they allow themselves to be vulnerable, so often, what does the lady do?
Shut them down.
And they don't like it. And sometimes they will hear something like, अरे मैं तो स्ट्रेंथ के लिए तुम्हारे पास आती, तुम खुद ही इतने कमजोर हो तो मुझे क्या संभालोगे? And they might go and tell this to other people. And so, which actually increases the negative attitude towards showing their vulnerability. And of course, we have researchers which is talking about the intersectional risks that we have. Male depression phenotype, please go and read about it. There is a delay in detection of depression and mood disturbances in men because the classical presentation is absent. Also, she has given me this chit, so that's why I started moving on in my presentation. And we have got something called as alexithymia. Have you heard about this? Friends, there is an emotional difficulty that is known more in men than in women, and that is to recognize and identify their own feelings and being able to express them correctly. So sometimes in relationships, in love, and in marriages, the females feel very, upset with the fact that आप मुझे प्यार करते हो या नहीं करते हो, तो उसको पता ही नहीं है कि प्यार अंदर से कैसा फील होता है and how to put it in words. Females have got such flowery language and communication skills. They can write so much and they can say so much, but he knows and he says and he wants to express through his action. But there are some things we call it as emotional restriction. So that is also one of the factors. Suicide rate, I've already told you, globally, males die by suicide at higher rates than females, although suicidal ideation is reported more by females. And persistent male excess being reported by WHO. All this data is available. Please go and look at that. Look at the India snapshot, what the NCRB is telling. Continuously over the years, male suicides are more. The age of the suicide, we all know that the age of the suicide is 15 to 49. And these are the common causes. So family-related issues. My dear friends, when you practice family therapy in India, you have to understand the complex family dynamics that we have in our country. The man in the family is pressurized from so many corners. And illness, then we have got marriage and relationship concerns. And so we want more and more people who are able to practice evidence-based family therapy and couple therapy in our country. And of course, we have alcohol and substance abuse and debt, poverty, and unemployment. So there was a surge in suicide, deaths by suicide during the COVID period, where when people lost their jobs, and you have heard cases where they couldn't find another job or they had death, the only thing that they thought about is, so Dr. Edward Schnidman, who is the father of suicidology, talks about suicide as a problem-solving strategy because they think that this is the way to solve their problem. And there is a lot of research on help-seeking behavior in men. What do you predict? How is the help-seeking behavior in men, and what is the difference between men and women when we are talking about help-seeking behaviors? What do you predict?
I see men saying कि अरे चलना बाहर जाते हैं, थोड़ा घूम के आते हैं. I see those kind of things, behaviors in my friends, and they are very sad.
Yes. And let's say their girlfriend or their partner brings them into therapy. What do they think about therapy?
So I am a therapist and I am a male therapist. So I'll tell you something that most of the men who come to me in the therapy room, they are for two reasons mostly. There are very less men who seek therapy just for their own progress or their own growth. Mostly either they have been pushed to therapy by their partners or somebody told them, chalo ek baar milke aate hain. And they are very uninterested when they come because they also have this perception, preconceived notion that it is not innate to me to ask for help because they feel that it makes them project themselves as weaker. So that is one thing. And that's why I think they also avoid seeking help directly. Indirect ways, definitely, they cope in many different ways, but just by communicating, it's very difficult for them.
Correct. And also, we need more male therapists because I've seen male clients, they do feel less confident with female therapists. And sometimes they directly ask that, ma'am, do you have a male therapist on board? Because I'll feel safer with a male therapist. So, of course, help seeking behavior in men is being researched. We have reviews which say that, dropout rates and lower help seeking. Women are more proactive, even in couple difficulties. They would like them to have therapy. But men, on the other hand, have a negative attitude towards help seeking due to perceived notions, as we are already talking about. And masculine norms and self stigma are being linked to help seeking attitudes, even in Indian men. Of course, men are at higher risk because of all of these things that we have talked about. And when they will present either for substance abuse. So, how many of you think that motivational interviewing and such therapeutic models which directly deal with substance addiction or gadget addiction or internet addiction or porn addiction should be a major part of your training in clinical psychology? Because male clients you're going to see are going to present with these issues. So you need to be trained in those modalities. Only then you'll be able to offer them those therapies. And also, as I said, that the risk is under-recognized because it is less talked about. So now what do we do about it? So research is saying that we need to really learn how men present their difficulties, one. Second, we also need to have interventions tailored to men. And research is also pointing out to one very, very interesting thing, that instead of waiting for men to come to your offices to seek help, maybe you should go to their offices to offer help. And so, employee assistance programs and employee wellness programs have to be well thought of. And they have to be offered in complete confidentiality, not just as an eye wash, but as a real remedy. And also, research is also telling us one thing. How many of you have used ChatGPT for therapy already? किसने अपना problem डाल के ChatGPT को बोला become my therapist? One male hand is up already. To test. Friends, we will choose anonymity. And so they are more likely to go to AI tools than people, actual people. So here, digital tools which produce improvements can be a very good area to explore when we are talking about helping men. And of course, detection and engagement have to be improved. We have to tailor the pitch to males, where we have to, what do you mean when we say tailor the pitch? Like she said in the beginning, why do you have to have this pitch on social media all the time? Men don't cry, men don't cry, men don't cry. You don't have to have that pitch. You can have the pitch which actually appeals to them, which helps them to identify and come to you. So, and of course, they are not going to sustain in therapy for a longer time. पहले तो उनको लाना ही मुश्किल है और फिर उनको रखना मुश्किल है therapy. So, I hope you have heard about Dr. Wendy Dryden, who is originally an REBT practitioner and who started something called as single session therapy, SST. He has written books also on single session therapy, which you should refer. And do you know which is the world's oldest single session therapy? The Bhagavad Gita. वहां पर ऐसी सेटिंग है कि मुश्किल से आधा घंटा 1 घंटा मिल रहा है. जो अर्जुन हथियार डाल चुका है कि भैया मैं नहीं लड़ूंगा, उसको उसी सेशन में कृष्णा डजंट हैव द अपॉर्चुनिटी कि अब इसके आगे अगली बार कंटिन्यू करें. So we have to explore briefer forms of therapy for men, and we have to provide training. As I was saying, short courses should be included in our formal as well as informal trainings, keeping men in mind, keeping their problems in mind. And of course, we have to do a lot of gatekeeping training. You all know that our institutions of national importance like IITs have been struggling with lots of deaths by suicide of male students. So we have to uh, go ahead and say that everyone has to be a gatekeeper. So gatekeeper training has to become more popular, more widespread, and suicide prevention specific techniques have to be taught to whether it is the schools, whether it is the universities, the colleges, the hospitals, not only mental health professionals, but everyone, including parents. And of course, I talked about the workplace programs, gatekeeping. India focus steps. We have to look at the state-wise data. We have got NCRB who is showcasing these suicides, but I believe that all that is very underreported. And so we have to strengthen our crisis lines, our helplines. We have got Telemanas, but Telemanas has to really do a better job than what we are doing right now. And we have to also run male-focused campaigns. So these are the evidence-based therapies that are being recommended for, and of course, we have to use substance use integration for this. At Feeling Minds, we have made a specially dedicated forum for men's mental health that is called as Feeling Minds Men's Mental Health Forum. We have a podcast called as Men Ki Baat, where we run these awareness campaigns. And here I have explained exactly why men don't cry. So, and these are some of the misconceptions that we have, and we can use it in our awareness campaigns. So, thank you so much.
Thank you, Dr. Chinudama. I think this has been a very insightful presentation and very, very relevant topical, because at a time when women's mental health has been spoken about a lot over the last 3 decades, and for good reason. There's a good reason for focusing on women's mental health, pregnancies, lactation, even perinatal facts. Yeah. So the menopause and so on, men's mental health has been widely ignored. And I compliment and congratulate Dr. Chino Agarwal for bringing this into focus. And for the Psychologist Society of India, the clinical CPSI, to actually take this up. Because this is something which is missing by and large. And like has been, like Dr. Chino said, that a huge part comes from masculinity norms, which are both psychosocial learning and also biologically driven, because there are a lot of hormonal influences. The muscle mass, a lot of work has been done. The muscle mass, the alpha sort of alpha male, the whole issue of dominance. Even if you look at animals, not just humans, if you look at dogs and other animals, look at a pack of lions, and you have the alpha male.
I also wanted to mention that patriarchy affects men also.
Sure. Obviously, it does. It brings in the whole issue of who wears the crown.
Yeah.
Nobody wants to, because with it comes responsibilities. And this is sort of forced on the high suicide rate in men. In India, it's about 3/4, like she pointed out. Completed suicides are more in men. Attempted suicide may be more in women. And then, of course, there's a whole issue of the comorbid conditions, alcohol and substance use. And I'll just come back to that. If it's seen that alcohol and substance use is less in women, but you'll find that prescription drug use may be higher. And they get prescribed antidepressants or sedatives. Men use them on their own. And if you take figures of substance use and alcohol dependence, and you say it's about general population 5% or 20% of men use them, not addicted. But if you take incidence of depression, 1 in 5 women is likely to suffer a depressive episode in their lifetime. But if you equate, if 1 in 5 women suffers from depression and 1 in 10 from depression, you put in figures of substance and alcohol use, and you come to equal figures. So like what she said, the masked depression, and that requires pathways to care, creating those pathways, being aware, we're interviewing, being aware. I would suggest that if people are coming in, men are coming in for a consultation, routinely asking for substance use and alcohol use. In today's time, of course, with role blurring, you have to ask women too. You can't take it as an assumption.
Exactly.
And then
family function recently, I was asked whether you drink, I was offered. And when I declined, I was made to feel as if I'm so old-fashioned.
Right. So those remain personal choices. But then the figures are changing. The whole question of interpersonal violence, that's linked to men's mental health. Just saying that, well, men are violent and there's domestic violence, well, women are also violent. That's one. It is underreported. It's somehow assumed that is a man who's violent. But then let's also understand, why is the man violent? Is it depression? Is it substance, alcohol use? Because those are very often the underlying factors. And then, of course, if you look at the, as has been now, I'll refer back to some other clinical models. We use ICD-10, 11 today. We use DSM-5. But if you look at the new research diagnostic models, I take a minute to digress, because if people who are clinical psychologists here, if there are other psychologists too, I assume all are, very often, is it depression? Is it anxiety? Is it psychosis? Is it bipolar? So you're looking at diagnostic criteria which cut across all diagnoses. They're transdiagnostic. So you have 2 sets of criteria, and one of them is called HITOP, hierarchical taxonomy of psychopathology. And that actually divides behavior into 2, internalizing and externalizing behaviors. So internalizing psychopathology and externalizing psychopathology.
Especially in children and adolescents, we use
In children and adolescents, we are using it, but it's all across the lifespan. So they say, don't talk about depression, talk about internalizing psychopathology, and then you come to the various disorders which follow internalizing psychopathology. And what's found is women more often use internalizing mechanisms, and men use externalizing mechanisms, and they're not just psychosocial, they are biologically driven too. So you have a complex mix of biopsychosocial factors, and it's a complete complete textbook there. The other is, like what was brought up, the gender of the therapist, and like ma'am also brought up. And research is showing that a lot of men, especially in the Indian setting, may be more comfortable with male therapists, and there is a paucity of male therapists. If it comes to directive psychotherapy, then men very often find it difficult to take directive sort of messages from women therapists. Yeah. So it becomes difficult to treat also. It's a double whammy. Difficult to diagnose, difficult to treat, and men continue to suffer. So once again, I congratulate you for this.
Aspect of that is, in couples therapy, it's a great challenge to win the confidence of the man. Because as a female therapist, they always believe that the female therapist is going to be biased towards the female. While that's not the case. For a female therapist, the relationship is the client and not the male or the female or the wife or the husband. So that's again a challenge.
So, and with a small thing, and pass it on to Dr. Srivastava, we were joking outside. We were talking outside, and Dr. Kalpana Srivastava mentioned that whether we should have had women chairpersons for this session. So whether men understand women better or women do, and I feel women understand men better. And well, I can back it up with data and studies, but suffice to say, with men in a way, and men, it's competition. It's the psychosocial masculinity norm that comes in. And women therapists often can be better, like what she said. And perhaps we all know it, women understand us better. Yeah. So I also refer back to, because this is a young audience, in 1992, Raymond's ran an advertisement campaign. You may not be aware, maybe she'd recollect, or other people my age would. It was called The Complete Man. And it actually moved away from the macho image of masculinity. And it showed men being gentle, emotionally bonding, men crying, and celebrated that in this. And they said, that's a complete man. So I think that's a message which we need to understand. Something which was in 92, 33 years ago, predates today's time. And with Gen Z here, maybe something new would be happening.
Thank
you very much. With your permission, let me share our very funny and kiddings. Out of the record, ma'am, somebody told that men are in the boxes. Then I told her, no, men are in the blue drums also.
Oh my God.
So, you know, my perception and majority of them, the perception towards the society has tremendously changed. Because, mutual expectations are not fulfilling the desire of each other. I have noticed that the young generation has become so horrible, so frightened, fear. That they are not ready to go to marry. They are not ready to marry. The marriages are become very late because of the fear component that I have realized. I don't go far. I take examples of my family members. So we, at our time, when we crossed the age of 25, we declared that now we'll not marry this too much. And now I'm noticing that even they cross 35, they don't bother. No, let me settle. What is the time they will settle? I don't know. So what is the reason behind this? There may be one of the reason, the fear conscious, or race with the society to meet all the challenges, all the expectations, the requirement that is endless.
We are calling it commitment phobia nowadays.
Yeah, maybe that technical persons you all can define. But what is my realistic experiences that what do they are aspiring, we as a guardian don't understand. Even the young generation, that includes men, women, both. So sometimes I also joke that we have to revisit some of the dictionary words that dominant towards manpower, manhandling, and many more. So it has to be now genderless. So words has to be invented, sir. Or it may be now for few more years, woman power and something like that. So it is a very serious concern. I remember another very good joke of one of my friend in 90s when I was serving a UP government, and there was a new department of women welfare, Mahila Kalyan Nigam. So one of my young friend commented that comment. Now I remember. He told, no, sir, it is not the creation of Mahila Kalyan Nigam. It is the first step in creating the Purush Kalyan Nigam. So I think the time has now come to consider the men also a person in need, a person to be heard. And I believe that if you are able to express yourself, in my initial remarks also, I very firmly believe that if anybody, including men or women, whatever, if he is able to express, the distress definitely reduces, tension definitely reduces. And many times the societal tendency comes for a moment And if expressed, if thought, then it diverts. I was listening to Ram Kinkarji Maharaj, sir, retired High Court Justice. He told his story. He was fed up with his family and went on a tila, which is very famous for societal. That is societal point. He went there. And he just for a while, sat for a while. And that was the reason he could not commit to suicide. And during that time, when he was thinking that I'm going to leave this world, he saw a Jugnu passing from his. Ram Kinkarji Maharaj is very. Then he saw and noticed that Jugnu is challenging this entire darkness by his own illumination. So if this small insect can survive in this dark world, so why should I not survive? Maybe I should seek my survival somewhere else. So he did not go back to his family and he came to some ashram, whatever it is, and became the Ram Kinkarji Maharaj. He was a retired High Court Justice. So age that 49 has to be added because retired justice means 60 plus. And then he tried to commit suicide because of the family unrest, his own disturbances, whatever it is, was not able to express. And he told, sir, I was listening, he told that he now expresses his problems in the common lecture, common addresses with the common people, and ask them to solve it because he has faced the problem which he could not solve and was bound to leave the family. So this is a mutual responsibility. And I'm very happy that men's mental health is being heard by majority of the opposite gender, women. So if this is extrapolated, the problem will be resolved. Thank you, and very nice presentation, very rich and very informative. Thank you.
Thank you.
Thank you, ma'am. It was very informative and very much needed topic. And I would request Dr. Mittal sir and Dr. S.K. Srivastava sir to facilitate Dr. Chinu Agrawal ma'am. Please. Felicitate. Please, ma'am, please come to the front. Please give a round of applause. And I would request Professor Jayadi sir to please, please stay, to felicitate Dr. Srivastava sir and Dr. Sunil Mittal sir. Thank you. Thank you, sir.
Thank you so much for such wonderful discussion on men's mental health. We'll move forward to the next round of presentation, which is the prestigious Dr. Kalpana Srivastav Young Scientist Award presentation, where we have shortlisted participants who have given the papers for this award. And the chair for this session, this award session, is going to be Professor Dr. Zevi, sir, and Pratibha ma'am. We'll request you to come on the dais. I thank all the participants who sent their papers for this presentation. I will request the participants to come one by one when I call your name. You will be given, earlier we had thought of giving 10 minutes. We are going to cut short that time. So there's going to be about 7 minutes time that's going to be there, and then one question that will be asked. So let's please try and keep it to that. Can I request Hiya Sharma? Is Hiya Sharma around here? Yes, please. So, Hiya Sharma is presenting on cognition of QCOGS, a nonverbal cognitive function screening tool for older adults. Hiya Sharma is an independent neuropsychologist, and her co-guide is Dr. Sudipta Roy. I request Hiya Sharma to come on the stage.
Just a short briefing to presenter. As we have compulsive conditions has compelled us to cut down your presentation time by 3 minutes. So we are giving you the liberty to reduce your presentation size as well. You can directly shift to from the objective, name of the paper, objective, methodology, and the result.
Can I request?
Summary.
Sorry.
Yes, fine. 3 things: topic, objective, methodology, result, conclusion. That's all. And that can be covered by 7 minutes time. 2 minutes, 5 plus 2.
Can I request the rest of the participants to kindly meet me near the stage to have the presentation loaded in the pen drive so that we won't waste time in making these transitions.
remember your serial number because result sheet is not having any name, only serial number, presentations number. So the first presentation is a Megha Jain. Somebody serial sequence. Megha Jain is there? Where is she? Okay. Hea Sharma is number 2. And Paul, Onedrita Paul, number 3. And Bhargav, number 4. And Apurv, 5. As she has already uploaded and she is here, so I will give her first chance, Hea Sharma, and I will be putting it accordingly. Okay. So now this Megha Jain would be number 2.
Namaskar everyone, a very good evening. My name is Hia Sharma and today I'll be presenting QCOG's quick cognitive screening tool. So why QCOG? So a lot of times we have seen whenever we do assessments for older generation above 60, we often find that they get agitated when it's a very long tool. They often find difficulties in staying there for the whole assessment and then they feel like ending the assessment in between. Secondly, there are a lot of times where we get illiterate population and it is difficult to cater to them when it comes to assessments like 1+2 or doing reverse counting when we are doing assessment for cognitive impairment. And that is why QCOGs came in picture. Me and Dr. Sudipta Roy, my mentor, we worked on it, and there are existing screening tools like MMSE, MOCA, Ray figure test, which are either verbal or are time consuming and motor dependent. And that is why we chose a non-verbal test, and it is quick to assess. It just takes 10 minutes of time, and it is culturally fair tool. It has 4 tasks, that is recognition, episodic memory, processing speed, and executive function, which includes planning and organizing, cognitive flexibility, and problem solving. These are the domains which we are covering. I'll be skipping on the literature review because we have less time. One thing I'd like to mention is that domain accuracy and cognitive validity for this was seen by 2 psychology experts, and we asked an artist to make the illustrations of the images of different tasks which will be coming forward. The first task is recognition and episodic memory, where if you see task 1.1, we show that image for a minute, and then we have an intervention task where the participant has to sort either colors or shapes by the different rules we tell them. That is where processing speed and cognitive flexibility come in picture, because they have to complete the task in 30 seconds. So they have to sort as many shapes and colors they can in 30 seconds. Once this intervention task is done, we show them the second one, the task 1.2 image, where they have to recognize the images and they have to tell what all they saw earlier in task 1.1. Once that is done, we have planning and organization, where we have 2 tasks where they have to sequentially arrange these images. One where they have to make a house, and second one where seed germination is being shown. The 4th task is where problem solving comes in place, and we have inspired from MMSE judgment task when we ask questions. The first is like, what will you do if it's raining and you have to go out for work? The second task is about fire in the kitchen. What will you do if there is fire in the kitchen? And the third task is, if a man is left with no money, what should he do? Pilot testing was done for this on a small group of older adults to understand how the participant is able to do it or not, and to understand the time efficiency, what time should be given to each task. And here, higher score meant better performance and less impairment. So 73 older adults sample collection was done, And the data was taken from old age homes and wellness centers in Surat. And the inclusion criteria was individuals above 60 years and consenting participants. 5 were excluded because of technical errors or not meeting the age criteria when we talked to them again. So yeah, earlier it was 78. And gold standard comparison was done using Montreal Cognitive Assessment, MOCA, and all data was collected face to face. The data was cleaned and coded, and non-parametric tests were used to for analysis because it was not it was non-normative. And then reliability for when we did item correlation, recognition and episodic memory had 0.474, processing speed was 0.600, and executive function was 0.60. We retained all the items, and Cronbach alpha was 0.413 and standardized was 0.743, which was acceptable internal consistency. And we did further assessments to ensure that it was concurrently valid, and it was construct validity was also there. For convergent validity, we had a positive strong correlation with MOCA, that was 0.740. And for discriminant validity, when we did negative correlation with impairment ratings, it was 0.943 negative. And we did ROC curves to have the cutoffs, and for that we got score range of severe impairment, moderate impairment, mild, and no impairment was there. There's some issue in the table, it's not shown completely, but severe impairment was 0 to 22 range, moderate was 23 to 43, mild was 44 to 70, and no impairment was 70 to 113, 71 to 113. Measure of agreement was also there with MOCA, which shows that there is a fair agreement that both of them are measuring what they need to measure. But at the same time, QCOGs also have a unique cognitive nuance to it. The key findings were that it is a reliable tool, and it is we can make it take it forward. It is non-verbal, culturally fair, and time efficient, as it just takes 10 minutes. And when it comes to limitations, our data was very less. And for that, for future, we are doing data collection right now, and we are planning to collect at least data of 400 people, both rural and urban, because it was done on urban population. Rural population data collection is going on as we speak. And yes, we plan to standardize it, make normative, make norms for it, and digital adaptation for broader accessibility is also what we are planning in future, and also confirmatory factor analysis, which we could not do right now because of the sample size. Thank you.
One or two questions, please. Please ask questions so that I am not in fix, because there is a marks for question answer as well. The clarity of answer. That marks can only be given if you raise the question. Otherwise, I have to give some common marks to everybody as a constant marks. Yes.
Hello. You said that the test is culturally fair. What do you exactly mean, like culturally fair? Because the population is Indian population only. So is it applicable to diverse population?
Yes. So if we
How?
see culturally fair, why? Because even if we go from state to state, there are different norms which they follow and everything. So when we are talking about culturally fair, this was one question which I was asked in poster presentation also, whether can we do it on South population? This was the question I was asked, because the second paper for the same I have done for poster presentation what I mean by culturally fair is this is a test which can be done on rural population, urban population, and from all the people of India also and abroad also.
That's what, how
Yeah.
abroad? Like, what are, how you have stated that it is cultural, what are the norms or what are the precautions taken to be it's culturally fair? Because when you say urban population, rural population, it is the Indian population. So how it is different for which culture you are actually, like, what, how, what precautions, limitations is being taken or methods used to make it a culturally fair test? If at all it has been done or it is need to be done.
Yeah. So for in the first task, if you saw, there was this village scene which was seen earlier. Can you see the task 1.1? So similarly, for a broad population, we have created another image so that if a person from abroad sees this, let's say if a person from UK sees it, they won't be able to recognize or recall a lot of images.
We'll call the next presenter, Ms. Megha Jain.
Good afternoon, everyone. First of all, thank you for the platform. Um, Thank you in advance for listening to me, Zeddy Sir, Kirti ma'am. And I'd like to start my presentation. Today, I'll be presenting my study titled Development of a Diagnostic Tool for Conduct Disorder based on Jain Theory of Consciousness. And the paper is going to be purely conceptualization and construction phase oriented. Let's begin with a little bit of introduction. So, why conduct disorder and why this topic is because of the rapid prevalence in the global arena as well as the Indian situation. The global prevalence is 9.5% of children and adolescents, while in India, 2 to 4%. So it's definitely not a chunk that can be ignored. And while at the same time, as per the literature review that we have done, there are not many tools which would address the clinical presentation of conduct disorder in a especially in an indigenous manner. They are not based in a way that they could cater to the presentation which is more culturally, which is looked with a cultural lens of the Indian population. Jain theory of consciousness is basically derived from the Jain philosophy. I have been studying it for over 5 years now. And it is driven from an ancient text called Tattvad Sutra, where they have said that quality of consciousness is directly proportional to the psychological well-being, that the more heightened the level of consciousness a person has, the more their psychological well-being. I would have gone more.
Megha, sorry to interrupt. Can you we've seen the
Peter.
introduction. Can you quickly go to?
So the objectives of my study were to find the commonalities and the differences between the signs and symptoms of conduct disorder in ICD-11 and the theory, and to develop this tool to assess the sensitivity and specificity of the tool, to establish the preliminary validity of the tool and the cutoff of the tool score. We are yet to achieve other objectives in phase 2, which would be about standardization of the tool and further norm development. The methods, the research design that was adopted was mixed methods, of course, because it is ingrained in the Indian theory. So we had to adopt qualitative research methods to bring out the features of conduct disorder from this theory, and of course, to do the statistical analysis required by the quantitative methods. The sample size estimation was done to find out that the required sample was 173, approximately 58 per group. Inclusion criteria for children were 8 to 16 years of age who were diagnosed with conduct disorder, the clinical other groups of ADHD and learning difficulty. Exclusion criteria was beyond this age group or any comorbid psychotic disorders. It is a parent rating tool. So the inclusion criteria for parents was that they were a primary caregiver and could understand Hindi or English and could give a written informed consent. The flow chart in detail would explain the entire process of and the procedure of the study. However, I would not go in detail of that. The result of the tool. So in the theory, we found out that there were 4 temperamental qualities: Krodh, Man, Maya, Lobh. Krodh was anger, Man was pride or ego, Maya was deceit or duplicity, Lobh was greed. So according to the Krodh, we found out the core psychological drive, and the corresponding conduct disorder domains that we finalized for the tool were violence, abusive language, destruction of property. For Man, we found out manipulativeness, lack of remorse, bullying behavior. In Maya, we found lying, stealing, truancy, violation of social norms. And in Greed, we found out cruel pranking, so sexually inappropriate behavior, and use of addictive substances. We did the ROC curve analysis to see the area under the curve and to find out the sensitivity and specificity of the tool. And the area under the curve was 0.903, and the cutoff score according to the Uden index was 112. Sensitivity was found to be 0.71. Specificity was found to be 0.97, where accuracy was 0.93, which shows optimal discrimination power, minimal false positives, minimal false negatives, with a slight scope of refinement for increasing the sensitivity, high negative predictive values, balanced diagnostic power, strong preliminary validity, and clinical applicability. The limitations of the study was, of course, because it is phase 1, so incomplete psychometric validation, which we are going to complete in the phase 2. Limited geographic representation, because it was done mostly from Delhi NCR, and it is yet to be forwarded and replicated in other populations of India. And absence of multi-informant data, because the tool was parent rated. So maybe in the future it would open scope for clinician rated and teacher rated. And I would like to thank you for giving me the stage again.
Question, please.
just one. I just asked you one more question. In your inclusion criteria, you have mentioned that you are studying conduct disorder, but at the same time, you have also included ADHD and learning disorder. Why? Like, what is the relevance?
Yes,
Because
yes.
what I understand is learning disorder and ADHD is more of neurodevelopmental disorder.
Yes, yes, absolutely.
And you have combined conduct with ADHD and learning.
Yes, yes, absolutely. Thank you for the question. Because of lack of time, I couldn't have the time to sort of take you through the study. But to answer the question in brief, we took the sample in 3 groups just to find out the discrimination power of the tool. One was purely conduct disorder, one was purely non-psychiatric, the normal population, and one was other developmental problems like ADHD and learning difficulty according to what we could find based on the other tool. We used Minikid, we used
my question is, what is the relevance? Why?
to be
What
able
is the
to-
need?
to
Like,
be
because
able
you
to
are
discriminate, to be able to discriminate this conduct disorder from other clinical the developmental problems in the child population. That's why we took it.
but you are doing the therapy, like you are already comparing conduct disorder intervention with a gen modification Indian therapy, Indian
It's not
setup, no?
intervention. No, it's not intervention.
Creating a tool.
Yes.
Come on, ma'am, it's okay.
Good presentation. I think you've done a lot of research, and I wanted to understand, are the items in Hindi or English and Hindi?
Yes.
Okay.
Translated in Hindi.
Huh.
We did the focus group discussions with Gen philosophy
I read that.
and
Yes.
psychology
Yes.
experts. And we did the validity in both English and Hindi. So
Okay.
that's translated in both words.
How long is the questionnaire?
It has 168 actually.
Okay.
On a Likert scale of 0 to 4.
Okay. And this was generated after inter-rater reliability.
Yes.
Yes, okay. And I also wanted to understand, because conduct disorder is very prevalent and there are quite a few scales which are available. Why would you want to add the Jain philosophy in that? And I wanted to understand the relevance of how Jain philosophy inclusion, the 2 questions here. Relevance of Jain philosophy inclusion in finding out a new scale. And number 2 is generalizability, which you've also mentioned as a limitation. How would you take this to people who are not following that philosophy?
Thank you for the question. First of all, there definitely are many tools already, and specifically extending my heartiest respect to Malvika Kapoor ma'am, who has devised CPCL, which has been my inspiration also for this tool. However, one point is that it's not a diagnostic tool. It covers and it is based on the another Indian theory, the Sattvic and Tamasic, वो वाला theory पे based है. My aspect of it is again to introduce temperamental qualities also. That there are 9 dimensions that we have taken in this tool. And conduct disorder criteria that we found from ICD and DSM were only 6 or 7. So we have included 1 or 2 extra also. And further work I also want to do to make it into a temperamental as well as a diagnostic tool, both comprehensive. And how to, the second part was how to take it to a person who does not follow the philosophy. Because it does not matter what the philosophy of it is or what the roots of it is, as long as we are able to understand the temperament of the child and the clinical picture of the child in a more holistic manner and include it in the intervention properly. The origin does not matter if it comes from Hindu philosophy, Jain philosophy, Indian philosophy, Western. It needs to be more culturally engaged and it needs to be more useful in the intervention. That's all. Thank you. Thank you.
Next.
Thank you, Megha. I'd like to request next presenter, Ms. Andrella Paul, to come to the stage.
No, sir, this was part of my elephant dissertation. Very good evening to all the members present in the audience and respected chairpersons and ma'am. My topic is development of bibliotherapy intervention module and its impact on mental health of parents of intellectually disabled children, a novel approach to enhance accessibility. So I'll just keep the introduction very short. So parents of children with intellectual disability face significant psychological challenges like prolonged despair, guilt, shame, fatigue, hopelessness, and social isolation. Now, this is exacerbated by lack of awareness, myths, misconceptions, and social stigma. Individuals from less privileged sections struggle to access mental health services due to financial issues, time constraints, and lack of resources. Thus, a need was felt to develop a remote intervention that is flexible, time and cost effective, inclusive, and accessible to all. Bibliotherapy is one such intervention, and coupled with online counseling, it may be quite impactful and beneficial. So, what is bibliotherapy? It refers to the systematic use of reading materials to promote knowledge, self-awareness, emotional processing, and behavioral modification in individuals experiencing psychological or situational challenges. The purpose being to provide education and enhance knowledge and awareness about specific concerns, to foster motivation and adaptive coping strategies, and to facilitate self-reflection, catharsis, and skill development. There can be various formats of delivering the intervention, like self-administered, minimal contact, guided bibliotherapy, and an integrated approach. Keeping the review of literature. So the objective of this study was to develop a bibliotherapy module in the form of an information-intensive, universally applicable self-help guidebook, and to evaluate its efficacy by assessing its impact on mental health parameters like general health, perceived stress, and quality of life. This quasi-experimental cross-sectional study was conducted at RINPAS over a period of 6 months. The tools used were pre-intervention interview schedule via VSMS, DST, GHQ-28, perceived stress scale, WHO quality of life scale, and the post-intervention interview schedule. 60 participants were selected. The technique was purposive sampling. Inclusion criteria being parents of children within 5 to 18 years of age with mild to profound intellectual disability. The participants had to have a working knowledge of English or Hindi, accessible via telephone, and willing for online sessions. Parents of children with global developmental delay, which is below 5 years, or borderline ID were excluded, and participants with a history of psychiatric illness or substance dependence were also excluded. Now, the entire study was conducted in 2 parts. First was the development of the intervention, and then administering it and evaluating the efficacy. So in the first part, there were 6 steps. First, we identified the knowledge gap using unstructured interviews with 20 parents to explore the awareness, misconceptions, and FAQs which are there related to ID and RPWD Act. Then the first draft of the module was developed, which had a detailed description of various aspects of ID, RPWD, stress management, acceptance, and mindfulness techniques. Then the entire module was translated into Hindi using Google Translate and then proofread by 2 Hindi experts. The language was kept formal, simple, and lucid. The pilot study was done, which was administered to 6 parents. Feedback was collected on clarity, relevance, ease of understanding, and applicability of the techniques. Content validation was done. Therapy was evaluated by 10 experts using Google Forms and assessing the appropriateness, adequacy, feasibility, and comprehensibility. And then the feedback from both experts and participants were incorporated to finalize the final guidebook, and the total development duration was approximately 2 months. Now comes the second step, application and efficacy evaluation. The children coming to RINPAS OPD were screened using the VSMS and DST. Then their parents were identified and enrolled as per the inclusion and exclusion criteria. Written informed consent was obtained in English or Hindi. Then the baseline assessment was done, where the pre-intervention interview was taken. These were all semi-structured interviews, followed by administration of the GHQ, PSS, and the WHO quality of life. Then the bibliotherapy module was provided to the participants, and the contents were explained thoroughly. Any doubts or queries were clarified. Then the first online counseling session happened on the 15th day after giving the intervention. It was of 10 to 15 minutes. The focus was on clarifying the doubts, discussing practical challenges, resolving implementation difficulties, and ensuring adherence. The second telecounseling session was on the 45th day. It was of 8 to 10 minutes,
And the idea was to review the progress, provide support and motivation, and encouraging them to adopt the stress management techniques into their daily life after the intervention as well. And finally, the end-line assessment was done the 60th day, where they were interviewed again, reassessed using the same tools, and then scoring and the appropriate analysis was done. Coming to the results, the Bipotherapy intervention module prepared in the study was titled Mental Health Guidebook for Parents of Children with Intellectual Disability. In Hindi, the title was बौद्धिक विकलांगता वाले बच्चों के माता पिता के लिए मानसिक स्वास्थ्य मार्गदर्शिका. It consists of total 8 chapters. So the first chapter provide comprehensive information on ID, definition, prevalence, classification, diagnostic criteria, symptoms, causes, consequences, prognosis, and management, all in very lucid, simple layman terms, just to convey the information. Based on ICD-10, DSM-5, and standard child psychiatry books, it's offered the parents a clear and concise understanding of ID. Then the second chapter focused on acts and policies related to ID, especially the RPWD Act. It covered disability assessment, certification, legal rights, and special provisions. Benefits like reservation, inclusive education, healthcare, insurance, guardianship, social support, all of this were explained in this chapter. Then the third chapter contained answers to frequently asked questions that we collected during the pilot study. So some common ones were whether ID is infectious, whether it is curable, are there any dietary restrictions, how to obtain a disability card, can my child ever get married, will they ever be able to live independently? So such FAQs were answered. Then the fourth chapter explained home-based management of children with ID, training them to perform basic self-care activities, handling how to handle emotional outbursts and social withdrawal of the child. It emphasized the role of patience, empathy, sensitivity, and consistency in the parents' daily interactions with the child. The next chapter focused on stress management of the parents themselves. The effects of stress, long and short term, the symptoms and the benefits of stress management was all explained. It included techniques like balanced diet, exercise, meditation, relaxation, sleep hygiene, behavior management, humor, and social support for maintaining mental health. Then the next chapter was to introduce the concept of acceptance, again in a very lucid, easy way. Acceptance as a way to reduce psychological pain, integrating Indian and Western perspectives like the yoga philosophy or the ACT philosophy of highest. Then the techniques included were gratitude, affirmations, psychological flexibility, cognitive diffusion, and values clarification. Then the next chapter focused on mindfulness, being present and non-judgmental towards one's thoughts and emotions. So subjective information feedback about the intervention was quite positive. Even the sessions made them feel highly valued, they feel heard, supported, and understood. This is just subjective feedback about the intervention. And then coming to the PET samples T-test, which was done, which revealed that there was a significant difference in the levels of general health, perceived stress, physical health, psychological health, social health, and environmental health before and after applying the module. To conclude, this module demonstrates promising efficacy in improving mental health. Its self-help format bridges the treatment gap by allowing greater accessibility and overcoming barriers related to geography, cost, and resource limitations. Moreover, its flexible nature supports cultural and linguistic diversity, making it adaptable to varied populations and enabling inclusive intervention across different communities. Future direction would be to include diverse samples to enhance the ecological validity, adapt the module into regional languages, and using audiobook formats to support low literacy populations. Its application can also be extended to caregivers of individuals with other neurodevelopmental disorders. That's all. Thank you.
Query, any question, please?
Just one question. You have said that you have taken a range of intellectual disability from mild to profound. So, does the bibliotherapy has specific, techniques for catering the needs of mild people having mild IQ and people having severe, profound, moderate? So, does your intervention has catered into those structured activities and needs from mild to profound? Because your 50 ID children is from the category from mild to profound.
the intervention was being done on the parents of the children having ID. So it chose mild to profound because as per research, parents of these categories of intellectual disability, they undergo a lot of stress. So the our sample was for the parents, not the children.
For the parents, the child who is having the parents who are parents of a mild intellectual disorder towards the higher end, like 65, 67 IQ, and somebody is like 19, 20, profound. So, what is the bibliotherapy has specific activities for those ranges, likewise, to teach to the parents also.
Yeah. Right. So, in the beginning of the bibliotherapy, firstly, the concepts of the various severity levels and the concept of which child is educable, who is trainable, all of this has been covered, and such, and hence the amount of interaction that the child needs, the kind of involvement from the parent they need, that has been described as per the levels. Like when a child is educable, so this is how you can do it. When he's trainable, this is how you can do it. For children who have profound ID, they will not be able to do certain things. So that is something it was covered with the parents in the guide.
Good presentation, Andrila. I have a doubt. The book is in e format or in reading rough, like a draft.
Ma'am, we used to hand over the hard copy to the participants. Those who requested for an additional e-format, that was also provided. It is available in both formats.
Right. And what was how was the decision made to have interventions? Because in one of the slides you have mentioned you had tele counseling. So what was the the reason why you went on to telecounseling when everything was done in person, and how did that help?
So, ma'am, the idea of the study is that most of these parents who were coming to Renpas, they were from very faraway places. So, for the post assessment and also for follow up, it was not really practical and possible for them to come to Renpas OPD every time. That's why we used telecounseling. Firstly, for follow up, and secondly, when going through the intervention in detail, what if they had any doubts? If there is any word which they are not able to understand, or any concept they are having difficulty following. So, for that reason, we had done these sessions.
Very good, very well thought of, wonderful. Is this available in other languages or because I'm looking at South? That would be excellent if you could give us in English or in other languages.
It's there in English and Hindi, ma'am. That is a maximum I can make it in Bengali also, but others.
Hopefully it comes in more languages.
Yes, ma'am, definitely.
Do you have like a trademark on it?
No, it is just a part of my MPhil dissertation. Yes, I have not published it yet.
Yeah. Wonderful study.
Thank you.
Thank you, Ms. Andrila. Next, I'll call upon Mr. Abudhya Bhargav. The presentation.
Good evening, panel members and members of the audience. I am Abhyuday Bhargav. I am a PhD scholar from Rashtriya Raksha University, and the topic and the title of my presentation is Effectiveness of Indigenous Model of Intervention on Reducing Distress Among Personnel Involved in Counterinsurgency Operations. It's a pilot study. It's part of my ongoing PhD work. So quickly going over through the introduction as well as the review of literature. So India's counter-insurgency forces have evolved over decades in response to separatist movements in Kashmir, Northeast, and Maoist regions. The troops that actually serve in these counter-insurgency areas face significant psychological strain, not only due to operational stress that they have, but due to the long deployments, the family separation, financial pressures, and isolation in general. So these issues often lead to issues such as anxiety, depression, post-traumatic stress disorder, and the way they cope up with it generally through substance dependence. And they also sometimes have adjustment difficulties, especially the new recruits that join the counterinsurgency forces. Although the military has taken a lot of steps, there is still a lot of stigma and there's a limited access uh, of these professional mental health services to these personnel in general. However, the various indigenous approaches such as yoga, mindfulness, vipassana have been tried and incorporated into their schedule, but then again, there is not a structured intervention module based on these indigenous approaches that can actually be employed or used with these personal post-credit counter-insurgency areas. So, skipping on the review of literature, the methodology, the aim of the study was to measure the effectiveness of indigenous model of intervention in decreasing psychological distress in troops posted in counter-insurgency areas. The main objectives was first to develop such a structured indigenous model of intervention, and second to assess the effectiveness of this structured indigenous model. There were two hypotheses. First, there will be no significant reduction in psychological distress in the levels before and after the intervention. And the second one, there will be no significant effect of intervention on psychological distress experienced by the troop. The pilot study included 30 participants, which were collected through purposive sampling. 100 participants were initially screened using DAS-21, the depression, anxiety, and stress scale. The individuals showing only mild to moderate levels of stress, anxiety, and depression were included in the study. Inclusion criteria, the age range was from 18 to 45 years of age, and individuals who were willing and were available for the intervention were considered for participation. Exclusion criteria out of the age range were not included. Those who were not willing or not available for the intervention program were not included, as well as those with severe physical or mental illnesses were not included in the study. The tools used in the pre-test and the post-test were HAMI, KDI tools, satisfaction with life scale, WHO quality of life scale, this psychological well-being scale. Reintervention. The intervention program actually draws inspiration from the medicine wheel, as you can see in the diagram. So it is a fundamental indigenous symbol representing holistic health and healing. It has been used for thousands of years in the North American indigenous cultures. It is divided into 4 parts, representing the 4 directions, or it can also represent the physical, emotional, mental, and spiritual aspects of a person's well-being, and emphasizing that harmony and balance of these 4 domains is necessary for well-being. So based on this approach, various practices from yoga, Ayurveda, Buddhism were integrated into a structured intervention program. The program consisted of 12 sessions, each lasting 45 to 60 minutes. Sessions were conducted 3 times a week, resulting in a month-long intervention program. Procedure quasi-experimental research design that included a pre-test and a post-test was implemented for the purpose of the pilot research. Participants' pre- and post-intervention levels of anxiety, depression, life satisfaction, quality of life, and psychological well-being were assessed to see the effectiveness of the intervention. SPSS and Excel were used for analysis of data. Both descriptive and inferential statistics were calculated. Paired sample t-tests were used because the sample fit the criteria for normality, and Cohen's d was used to measure the effect size. Certain more links were also taken out between distress and well-being through the use of Pearson correlation coefficient. Descriptive statistics showed that initially the troops reported higher levels of anxiety and depression with HAMA and BDS scores in the mild to moderate range. Afterwards, the intervention, these scores significantly reduced and most well-being measures improved significantly, with reductions in worrying and depression as well. The study also found significant reductions in anxiety, depression between the scores of pre-test and post-test, along with improvements in life satisfaction, quality of life, and mental well-being. Effect sizes calculated by Cohen's t showed moderate to substantial. The effect sizes were moderate to substantial, confirming that the intervention was not only statistically but also practically effective. Overall, the culturally adapted interventionist program successfully decreased psychological distress, enhanced well-being among counter-insurgency persons. Additional findings. So prior to the intervention, anxiety and depression were strongly correlated, indicating that higher anxiety was linked to higher depressive symptoms. Both variables showed negative association with life satisfaction and well-being. Overall, the pre-test results highlighted that distress variables had the greatest impact in lowering life satisfaction and psychological well-being. Post-test correlation revealed substantial changes after the intervention. Life satisfaction became less influenced by distress, while positive association strengthened among well-being measures. Overall, negative association between psychological health and social environmental dimensions decreased, suggesting that the intervention reduced distress, fostered more adaptive, balanced relations across well-being characteristics. The discussion, the findings revealed significant improvements in mental health and overall well-being with strong effect sizes across most measures. The intervention was also safe, it was well tolerated and produced no adverse effects. Improvements were observed in autonomy, personal growth, mastery of environment, reduced painful experiences, and resilience and coping strategies were strengthened. These results also align with earlier research on mindfulness and yoga therapies, and which have demonstrated reductions in distress and enhanced adaptive function. The study concludes that culturally adaptive influence therapies can effectively reduce depression and anxiety. This is the last slide. Anxiety while enhancing resilience, self-control, and life satisfaction. The limitations were, of course, a small sample size and only one group with the pre-test and post-test design and no control group. So, of course, there are problems with causal inference and generalizability. Despite these constraints, the use of validated tools and effect sizes do show some positive findings through this intervention. Future research should employ larger randomized control trials, which is the plan, longitudinal follow-ups, and a diverse participant to confirm these results. Overall, this intervention is not a therapeutic intervention, but provides a preventive intervention to improve the coping skills and improve the resilience among such personnel. Thank you so much. I've also included the tables if you would like to see.
2, 3 small short questions. The first is that why you took taken the null hypothesis? Why not the directional hypothesis?
Okay. So I have taken both the hypotheses. I just mentioned the null hypothesis. Of course, in the word, the null hypothesis is not proved, and the alternative hypothesis was proved. So I've just not written it. I've taken all 4. I thought it would be too long to put all of them and explaining all of them.
The second is that you have not done follow-up so far.
Yes.
So and you claim that it is the efficient efficacy and all these things, even for the prevention. You
Yes,
very safely and very, diplomatically have mentioned that it's not for the intervention, it is for the prevention.
Yes, sir.
But even for preventive point of view, this follow-up is important.
Yes, sir. I totally agree, sir. I actually came back this month after finishing the first year of intervention. The follow-up is lined up in the month 2. So next month, I'm going back to take the follow-up of this intervention. So in December, first week, I'm going back to see if the effect of this intervention were long-lasting or not. So a 1-month follow-up and a 6-month follow-up will be taken off after the research is done, after the intervention is implemented.
Any other question from audience?
My question is, why specifically the counter-insurgency troops and why not armed forces in general?
Yes, so armed forces in general do face a lot of mental distress and psychological problems, but counter-insurgency forces are kind of unique in terms of their geographical locations. They're located in places where there is almost no network. They're away from family, and for 30 months, they're in an isolated space. Whereas in other cantonments which are present in civil areas, there's still some sort of movement. You can keep your family with yourself. There is more access to medical services. So the hardships have increased in the counter-insurgency area especially. The future plan is to expand it to other forces such as BSF, CRPF, and for making changes and moving it from the civilian armed forces also.
good presentation. The interventions were done. Oh, okay. Just a small question. You have used handmade for measuring anxiety and BDI for measuring depression. So one is clinician rated, other is self-report. So any specific reason for that?
So BDI was used because HAM-D gives more somatic symptoms. The answer for more somatic symptoms, which I was not so much concerned with. I wanted to know more about the subjective experience of depression that they had. Therefore, I used BDI-2 for this intervention.
Okay. I wanted to understand when you did the intervention, was it in person?
Yes, ma'am.
And
It was in person.
individual?
Individual session.
Not a group session.
Not a group session.
So, how much? Maybe this could also be taken up as variable later on.
Yes.
The psychologist variable, because you are the only one who's doing for so many.
Yes, yes.
So, how much is the psychologist variable in contributing to the?
Yes,
You know,
yes.
yeah.
ma'am. I will surely look into this
Yeah,
aspect.
yeah.
as well.
I would be interested in
Yes,
that.
yes.
Yeah.
Thank you so much.
Thank you.
Apurva.
Respected chairpersons and the audience, I am Apurva. I have done my MPhil in clinical psychology from MIT University, Punjab. The topic of my presentation is cognitive fusion, metacognition, and mindfulness in individuals with depression disorder. So, as we all know, depression remains one of the most debilitating mental health conditions, and it is characterized by maladaptive cognitive processes like rumination, cognitive fusion, and dysfunctional metacognitive beliefs. Cognitive fusion is over identification with one's own thoughts. Dysfunctional metacognitive beliefs. Apurva, can you move to the objectives? So, my objectives of my study was to assess and compare the level of metacognition, mindfulness, and cognitive fusion in mild, moderate, and severe depressive episodes. And aim of the study was to explore the interplay between these constructs in patients with depression disorder. So, coming to methods, 50 participants were recruited by using a cross sectional design via purposive sampling. It was conducted at Department of Psychiatry at the AIMS Mohali. Inclusion criteria were individual meeting ICD-11 diagnostic criteria for depressive episode, 18 to 16 years of age, and they must have ability to read, write, and comprehend. Exclusion criteria were comorbid psychiatric illness, cognitive impairment, organic conditions, and substance abuse. These were my data collection tools that are back depression inventory media 21, the metacognition questionnaire MCQ 30, cognitive fusion questionnaires CFQ 7, and mindful attention awareness scale. So procedure started after getting the approval by institutional ethical committee. Then participants received comprehensive information about studies purpose. Written informed consent were taken from them. Socio-demographic data were collected by socio-demographic sheet. Clinical details like age of onset of depression, etc., were collected by clinical data sheet. Preliminary screening was done by General Health Questionnaire GHQ 12 to assess psychological distress. Then comprehensive assessments were conducted. Statistical analysis was done by SPSS version 24. Descriptive statistics summarized participant characteristics. One-way ANOVA tested group differences in different constructs. Pearson's coefficient correlation and linear regression analysis assessed relationships between constructs. So this table represent the participant characteristics across different variables like age, sex, severity of depression, and education. This table represents the median score of every questionnaire with their respective ranges. This table represent the correlation between different variables through Spearman's correlation coefficients. The strongest correlation, the strongest positive correlation was obtained between cognitive fusion and BDI2, that was 0.808, and the second strong was between metacognition and BDI2. This scatter plot represents the relationship between metacognition and depression. As the level of depression increases, the level of dysfunctional metacognitive thoughts also increased, as seen by the scatter plot. There is positive correlation. But in this scatter plot, there is a negative relationship between mindfulness and depression. When a person is more depressed, he or she is less mindful, and when he or she is more mindful, he is less depressed. There is negative relationship, and this is a relationship between metacognition and fusion. There is a positive relationship between these variables. So our studies are comparable to these studies, and the limitations of our study was that it was small sample size, which limited subgroup analysis on the basis of different variables, which includes sampling error. Purposive single site sampling restricts generalizability, and self-report bias that can occur in the form of social desirability, as questionnaires were always so self-reported. And so the takeaway home message is that role of psychological even flexibility exists in the phenomenology of depression. So we have to focus on increasing mindfulness and decreasing cognitive fusion and the dysfunctional metacognitive beliefs. And this is consistent with acceptance and commitment therapy, metacognitive therapy, and mindfulness-based cognitive therapy. The future research directions are there is need for more randomized controlled trials comparing ACT, MCT, and MBCT, and longitudinal cohorts are necessary to clarify the cause and effect and temporal precedence over a period of 12 to 18 months. Thank you.
Any query from anybody? Please.
In general, depressive disorders are generally have a lot of comorbid conditions, such as anxiety one is very common. As well as in ICD, there are different types of depressive disorders, one with somatic symptoms, not without somatic symptoms, with psychotic episodes also. So do these things also have an effect on your conclusions of the study? Or were they included or were they excluded in the study?
Like, yes, anxiety and depression are usually they occur commonly. But we see if the anxiety is in the level, इतनी anxiety थी कि वो diagnosable थी या फिर इतनी नहीं थी कि वो उसको diagnose कर पाए, तो उस में देखा था
and mainly without psychotic features. We didn't include psychotic features to exclude it. Thank you.
All right. Thank you for your presentation. I'm interested to know what are the implications of the study?
Implications, how can we apply? We can, as we say, the main focus of treatment is CBT for depression. But if we integrate ACT, it is acceptance and commitment therapy, which focus on cognitive fusion and on being on the present moment, and like metacognitive therapy, which focus on dysfunctional metacognitive beliefs, and mindfulness-based cognitive therapy. If we focus on all these therapies, so there will be more improvement, as there are depression relapse rates occur very commonly after antidepressants or CBT.
All right. And is there any research implication that you would like to highlight?
Means my study is comparable to other study.
How can this be used to further any researches?
Yes, more randomized controlled trials are needed for it.
Anything apart from what you mentioned here?
Anything apart? It's more, the bigger group.
Oh, thank you. It's a good study. I wanted to ask you this. So I understand the whole study is based on the ACT paradigm, right? Okay. Was the when you looked at the treatment sample, when you looked at the intervention, did you also look at ACT and mindfulness as intervention, or you were only looking at the finding the data, metacognitions and cognitive fusion and all that? Were you planning to take it forward for intervention?
Well, in my this study, I have only with the relationship between the constructs, but as it was my dissertation, but yes, I can do it
Further
further
take
in
it,
my
yes,
PhD.
wonderful.
I'm sure it is.
Yes, wonderful. Yes, yes, okay. I think that would be helpful. Yes, okay. And I wanted to understand, was there anything specific taken to understand cognitive fusion
Yeah,
as a factor?
apart from
How did you analyze cognitive fusion?
ma'am, for it, cognitive fusion question, the CFQ7 was used. There are questions like I'm more attached to my thoughts. I act on my thoughts. There are 7 questions and 7 rating items. Well, 1 to 7 you have to rate. So it is a very small questionnaire and it is very
Yeah.
good question.
So that's in English, right? So
Yeah.
was there anything? That was my question. So because people who answered, were they well versed in English, or were you also looking at language?
Yes, ma'am.
Because cognitive fusion as a concept, when we do in therapy also, it becomes difficult for people to understand it when you give it in English vis-a-vis in a vernacular language.
Yes, ma'am. Yes, ma'am. You're right. I translated all the questionnaires in Hindi too, but whenever who are doing it in Hindi, थोड़ा मतलब उसका बदल सकते तो I make them understand each question and if there has any doubts.
So translation was more in-person translation, not as a iterator. वो उतना डिटेल में नहीं गए.
No, ma'am. Actually, it was
Right,
time constraint.
Yes, no worries, no worries. Yes, good presentation.
Thank you, ma'am.
Well, all the 5 presentations was really good, very good attempt. One and after, as usual, difficult to judge and to differentiate, but still, the ultimate goal is to find out the, if not the significant, maybe the insignificant difference. But there is a difference. That has to be different. There is that no 2 things are the same equal. So, with all sincere efforts, myself and my colleague, Dr. Kirti, has tried to rate you, and the result would be declared tomorrow in the validity program. The only thing which I would say that all of you have done good. However, in some of the cases, the presentation needed some practice before. and somebody was fully confident, and some required was somehow or the other completing the presentation. So that is always there. After all, young scientist, there would be a lot of opportunities to improve, to make it more explanatory, and would be a good answers. Few of you could give very good answers, queries. Some tried but could not convince to great extent. And these are the very small. Otherwise, content-wise, originality-wise, utility-wise, all the studies have been very good. Over to my colleague.
All the presentations were very good. As Sir said, some of you needed a little more skills and time management, I think. So if you could, as a researcher myself, I would request each of you to do a time check when you do the presentations, even before you come in here, because time is always important for everyone. And also to just take this forward, please do join CPSI as members, because that would also help you to present in more conferences and webinars and workshops. Thank you.
Thank you, ma'am, and I wish all the very best to the contestants. And with this, we come to an end of the session, and I request Professor Jayati sir to please felicitate Dr. Preeti Pai, ma'am. Please, ma'am, come. Yes, sir, to felicitate. Yeah, I said Professor, sir. Please, no. Sir will felicitate, ma'am. And I would request Tarana ma'am to please come up and felicitate sir. So please. I would request all members of PPSI to please join the AGPM meeting.